Okay. Good afternoon to everybody. On behalf of IAP TNSA, welcome one and all. First, we'll start with pediatrician prayer. Our Gopal Subramaniam, IAP TNSA treasurer, will start with prayer.
Welcome all on behalf of IAP TNSC. We'll start today's program by pediatrician's prayer. குழந்தை மருத்துவரின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயிலின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நான் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தன் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலைப்படி மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்து நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal Subramaniam. And so it's my duty to give a welcome address. It's respected President Dr. Ismail sir and Treasurer Dr. Gopal Subramaniam, ID chapter Secretary Dr. Sudhagar, and convener of the program today, and Dr. Narmada, Treasurer ID chapter, and as well as convener of this infectious disease program, and Central EB members Dr. Jalil, Dr. Somasekhar, and Janani, and Dr. Malli Raman sir, and senior members IJP editor Dr. Tangavel sir. So it's today's faculties Dr. Tangavel sir from Chennai, and lead panelist Dr. Jaikumar from Cochin, and panelist Dr. Sija Sugunan from Trivandrum, and Dr. Balachandra from Kottayam, Dr. Nemina from Coimbatore, and Dr. Sudhagar from Chennai, and lead panelist Winsley Rose from Vellore, and panelist Wilson Varghese Philip from Vellore, and Anila Chako from Vellore, and Dr. Palni Raman from Dindivanam, and Dr. Narmada from Vellore, and lead panelist, another lead panelist Dr. Arun Bansal from Chandigarh, and panelist Dr. Mullai Balaji from Coimbatore, and Dhiran Gupta is IAP intensive care chapter president chairperson 2021, and Arun Bansal is currently the secretary of IAP intensive care chapter, and Dr. Suresh Kumar Angara from the Chandigarh. So today is the second CME program we are having, and the first one was pediatric emergency management. It was fantastic response from all over India, and this is one of the most wanted and the best with the infectious disease CME we are organized, and we are having a vaccine update next month. We are having fourth Sunday. We are having a vaccine update. It will be organized by our convener by Dr. SPS sir. I think it's very glad to announce that also. Today I am on behalf of IAP TNSA, welcome and all. And finally, I welcome our Vice President South Zone, Dr. Major Nagaraj sir. He is our dynamic leader, and he is doing a lot of work in our area. And I welcome our VP, Dr. Major Nagaraj sir. So now I request our VP to deliver the inaugural address.
Good evening, sir. Thank you very much for asking me to inaugurate this CME. I'm thankful to you, all of you. IAP TNSC is doing a lot of these programs. The CME of infectious disease is very, very important nowadays. And I saw a lot of stalwarts names are there, like Dr. Tangavel sir and other people who are from outside of the field also. I don't want to tell the names because it takes a long time. I think that infectious disease become more important now after Corona has come. Previously thought that infectious disease will go out and other diseases like non-communicable will come out, but infectious disease again come back, and it will be very important to know about the different diseases of the viral diseases. Actually, now the panel is going to discuss all these things today. And today we have a senior most people also like Srinivasan sir and my executive board members, that Somasekar, future president, told already, and also the IIT TNSC stalwarts like Ismail is not here, and Dr. Rajendran, Gopal, Subramaniam, Tirumurugan, and the faculty from neighboring state, Dr. Jay Kumar, Balachandran, I can see Balachandran here, and other people who are here, and also from Delhi, Dhiran Gupta, all the people attended. It will be very interesting to learn all these new things. I think the most important thing is one of the concepts is medicine always changes. Learn, unlearn, and relearn is one of the concepts you have to learn. Very important you have to know about this thing, and it will be very useful for all of us. These programs and all. Today morning also we had a very good task module where I spent up to 12:30 with them only, and it's very useful for new things to know. And all of you, it will be very important to learn more and more new things. And I wish this program will be a great success and happy learning for all of you. Thank you very much. Jai Hind, Jai Hind. Thank you.
Thank you, sir. Thank you, sir. Now I request the program convener, Dr. Sudhakar, to tell few words.
At the outset, I thank the IAP TNSC for considering our ID chapter as well as the ID topic to be a major CME. Really, ID chapter really takes it as a great honor, and I have to thank President Dr. Ismail, Dr. Rajendran, and Treasurer Gopal for this support, and I have to thank the faculties also. We have a very great team of faculties for another 4 hours. It will be like a great celebration, and it's with a great learning experience. I thank everyone. I welcome all the faculties.
Now I request Dr. Narmada to tell few words. Narmada, convener.
Thank you so much, Rajendran sir. Actually, all the faculties have very gracefully consented the moment we called from our IAP TNSC to have come and participated this. I'm really thankful to every one of them. And I also thank IAP TNSC for having confidence in us and giving us the opportunity. I thank Dr. Nagaraj sir. I requested him to be here and he immediately accepted, and all the faculty members. I'm very sure you're going to have a great academic experience, and I'm sure you're going to enjoy this academic bonanza. Welcome all to all the delegates who are very enthusiastically, almost all the 100, more than 100 people have logged in. Thank you so much for every one of you for having come here. Thank you so much. I specifically thank all the faculty members too. Thank you, sir.
Thank you, Dr. Narmada. I think we can Zoom, we can accommodate 100 members. I think in remaining they are joined in YouTube also. It was a very good response. And now it's I welcome Dr. Tirumurugan, Joint Secretary, to tell few words.
Thank you, sir. I think it's we have been very active in promoting some organized CME events, and these monthly CMEs, which are conducted at the end of the month and 4th Sunday of the month, have 2 purposes. One is to develop our knowledge on a specific topic, and also to give us the opportunity to earn some important credit points for the TNMC. So I think I'm very thankful to every one of the organizers, speakers, and the conveners for joining together to make this event possible. Thank you very much, and I'm sure we'll have major success with these programs. And as our Secretary Dr. Rajendran said, we are going to have one at the end of every month. So we are planning another 8 more by the end of this year. So which means we'll have at least 8 credit points. Part of our headache with TNMC goes away. Anyway, thank you very much, and wonderful to have all of you. Thank you very much.
Thank you. Now it's over to Dr. Sudhakar to take over that CME. Sudhakar, unmute.
Thangavel sir, you are a co-host now.
Okay.
You can.
Tirumurugan sir, Dr. Winsley Rose.
Sir, 1 minute, sir. Thangavel sir, 1 minute, sir.
Dr. Winsley Rose and from people from CMC have not joined Thirumurugan. Sir, please have them on the waiting room so you can accommodate them.
They are not in the waiting room yet.
If they are there, sir, please.
Okay. We're just waiting. Who is the other one? Dr. Rose and
Dr. Winsley Rose, Valsan Varghese, sir, Sheija ma'am has not joined yet.
Yes,
I saw Sheija is there. I saw Sheija. Sheija is there already. I saw her.
No. Sorry.
Dr. Sheija is there.
Already there. I saw her.
The co-host.
Dr. Anila Chawla.
I'll look into it and then try to sing as a join.
Remaining persons.
Sir, shall I start, sir? Shall I start the
I think
program?
you can start.
Yeah,
Sir.
remaining persons, they can join the YouTube,
Yeah.
IAPTNSE YouTube. Okay, right. Yeah, please go ahead.
It gives immense pleasure for me to introduce my great teacher, Dr. Thangavelu sir, who is the head of the department of pediatrics, Dr. Mehta's Pediatric Hospital. He doesn't need any introduction. He got the best teacher award from Tamil Nadu, Dr. MGR Medical University. He's played a vital role in developing PICU, both in ICH as well as in Dr. Mehta's Hospital. He was the main person behind the Childhood Diabetic Clinic in ICH. He was the executive editor in IJPP from 2014 and now current editor-in-chief of IJPP from 2020. An excellent team leader and teacher, a popular orator for past decades, and he has been conferred Iron Order Oration in 2016, Professor Ellis Oration in 2017, and many journal publications, many chapters in the textbooks. We welcome you, sir, to deliver the talk on fever with thrombocytopenia, all are not dengue.
Thank you, Sudhakar. Respected Professor Srinivasan, Dr. Major Nagaraju, IAP ID chapter functionaries, Tamil Nadu TNSE charter, President Dr. Ismail, Rajendran Secretary, and then Dr. Gopal, Treasurer, and all my dear friend, Dr. Sudhakar, and all the faculty has come all over from India. Welcome you all. I just started this program, fever with thrombocytopenia, all are not dengue. This is a very common and major problem a general pediatrician will come across, fever and thrombocytopenia. So, but it comprises of a lot of underlying etiology, maybe a simple benign illness like a viral fever associated with some spurious thrombocytopenia or something in maternal leukemia. So, with a proper approach, we can definitely reach a diagnosis. That's what we are going to discuss in the next 17 or 18 minutes. So, to begin any good program, we should have a divine darshan. So, let us have a divine darshan of the live cells of blood. You can see RBC and beautiful platelets, violet color dots, beautiful platelets. And the bigger arrow you show you there is the immature platelets, which is giant platelets, which is immature but more energetic platelets. This is a referral letter from one of the pediatricians from a rural town. Here we are referring this boy, 10 years old with 5 days fever and the platelet count of 55,000. So this is the reference letter of a pediatrician from a small rural town, but definitely will help in narrowing down the differential diagnosis, but it is grossly inadequate because from the general data, we have to go into the focus history and probability examination, laboratory, which may be basic laboratory as well as the specific investigation, differential diagnosis, then only we can reach a diagnosis. This cannot be a shortcut. All the time, we cannot make a shortcut from this. These are some of the numbers related to thrombocytopenia. Normal count is 150,000 to 400,000 per microliter. Practical cutoff is less than 10,000, less than 100,000. Usually they remain asymptomatic till the count goes below 50,000. Clinically, they'll definitely become symptomatic when the count goes below 20,000. A falling trend is more significant than one single value. It causes petechiae, purpura, and mucocutaneous bleeding. If you look at the causes of thrombocytopenia, it's quite large, but we can group them into 3 categories: increased restriction, impaired production, and sequestration. If we narrow them into practical common causes, commonly these are the common causes: and acute fever, thrombocytopenia, pseudothrombocytopenia, viral illness secondary to dengue, COVID, EBV, parvovirus, chikungunya, HIV, sepsis, and then scrub typhus among the bacteria, malaria, leukemia, HLH and LCH, and hemorrhagic syndrome. Very rarely, drugs given during fever may also cause thrombocytopenia. With this background, we'll go through some case scenarios and try to understand various aspects of thrombocytopenia fever. This is a child who had fever, but no focus of infection, no rash or bleeding tendency. There is no organomegaly. Clinically, child was looking very simple, benign viral fever, but automated counter has given a normal WBC count, differential hemoglobin, but platelet count is given as 45,000. A big warning has been sent to the pediatrician. CRP is negative, NS1 is negative. If we happen to see a thrombocytopenia given by automated counter, but clinically not correlatable, we can think of two possibilities. It is called spurious thrombocytopenia. Either it may be a small clot in the sample, because of that the counter is counting it very low, or second is EDTA-induced problems which is happening in vitro. Here you can see two smears. One is you can see the clumps, platelet clumps. Even if the count is 45,000 pieces, so much of clumps, we need not worry because the count must be definitely normal. This is platelet satellitism. So all the platelets are surrounding the neutrophils. When you see this, it will give you a lot of reassurance. So the counter, the threat created by counter will be nullified if somebody can see a smear and found these clumps of platelets. It will definitely reassure. So how to overcome the problem? Overcoming the problem, you have to use a heparin or citrate containing sample. This will solve the problem of EDT related in vitro antibody causing agglutination. When Sudhakar asked me, he said that don't talk anything about dengue. So I just given only a picture. A fever with hepatomegaly, purpura, right side pleural fluid, tourniquet test. You can see the small bruises at the site of applying the BP cuff. This child came with a severe dengue on day 6 with the bleeding, encephalopathy, and refractory shock. Of course, fever with thrombocytopenia, definitely we have to think about dengue and then only we can go beyond that. This is a simple approach to a child with thrombocytopenia given in one of the articles published in IJPP 2 months back. So step 1 is look at a history and examination. As I said earlier, is no shortcut. Look at a CBC and peripheral smear plays a major role to find out other cell lines are okay or not, how the platelets in the peripheral smear. Then step 2 is clinically we decide whether it's a sick child. Sick child means a child with infection, having shock, respiratory distress, or respiratory irregularities, or altered level of consciousness, or malignancy, child coming with severe pallor, thrombocytopenia, and purpura, HLH, hemolytic uremic syndrome presenting with renal impairment. So well child means a child who does not have any serious critical signs, will be a spurious thrombocytopenia or maybe due to self-limiting viral fevers or drug-induced. Step 3, we have to decide whether are we planning for bone marrow evaluation and involved in the hemato-oncology consultation. It is definitely needed when we consider bone marrow failure as evident by bi or pancytopenia, leukemia, lymphoma, or HLH. But whatever the etiology, even before we reach the etiology, if we want to start on steroid in a child with thrombocytopenia, bone marrow aspiration is mandatory before starting even oral steroids. So some of these questions will help us to analyze the problem. Is it true or spurious? That smear study can solve this. Then we look at a child and ask whether it's a well child or sick child. Sick child is usually having an altered level of consciousness, shock, and respiratory distress and bleeding. Clinically susceptible by history, and clinically we can suspect many things by history and examination. Fever, hepatomegaly, flush child, dengue. Yashkar will indicate scrub. Pallor, purpura, bone pain to indicate leukemia. Persistence of a thrombocytopenia in a very sick child, even after 7th or 8th day of dengue, you think of HLH. A child presenting with thrombocytopenia, renal failure, may be HUS. So many clinical features will tell us and narrow down the possibility to one side. If more than one cell line is affected, like 2 or 3 cell affected, means more likely to be in dengue, aplastic anemia, AL, and HLH. These are the situations where you have more than one cell line is affected. Any focused lab, like bone marrow aspiration, dengue or other tropical infection screening will narrow down and fix the diagnosis. This is a 15-year-old boy, came with 1 week fever, headache, body pain, pedal edema and melena, referred for low platelet count. He had a very good clue to tell us that he is suffering from scrub typhus, eschar near the right earlobe, febrile pedal edema, mild tachypnea, decreased presence on right side, hepatosplenomegaly. Look at the investigation, thrombocytopenia is there, but PCV is not high. Neutrophilia leukocytosis, CRP positive in contrast to what we see in dengue, bilateral pleural feed and haziness, minimal free fluid abdomen, IgA malacia rickettsial was positive. This is a child with scrub typhus. This is one of the early cases we saw from 2009. The problem here is he started clinically improving, fever settled and shock is improved, everything is settling down, but platelet count remains very, very low, 30,000, 45,000, 55,000. We are unable to discharge him. When I discussed the pathology found out that this fellow has got a lot of platelet aggregates are there, plenty of platelet aggregates. But this thrombocyte, this is one of the bedside tests. it's not given any clearly in any book, but we have observed that many of them has this platelet aggregates causing thrombocytopenia. It's one form of spurious thrombocytopenia. So the child was smear showed plenty of aggregates, treated the doxycycline, and child completely recovered in a span of 1 week time. So again, smear plays a major role. These are all the scar in different places: left axilla, umbilicus, scrotum, behind the ear, back of neck, and inguinal region. So now in every child, we have to strip the child, giving privacy for the child under the screen to look for any scar in covered areas. Otherwise, we will miss a big diagnosis. This is a 4-year-old boy, came with fever and limb pain. I'm going faster because only 70 minutes time has been given for me. Limb pain for a week time. The limb pain was little alarming. Pallor and limb pain which should be very, very alarming, particularly night pains. And he had pallor, purpuric spots, cervical and axillary lymph nodes, and hepatosplenomegaly. WBC count was high, 35,000. Hemoglobin platelets were low. The peripheral smear of the child showed the following picture. You don't see not many platelets are seen, large cells. You can compare a normal cell here. It's a normal cell. In the normal cell, at least half of the nucleus is surrounded by cytoplasm. Here you see only a thin rim of cytoplasm. So we should, not only we, our young colleagues also should get trained to look at peripheral smear to identify blast cells in this. It's a very, very useful test, simple, useful test to make a big diagnosis. The child came with 5 days fever, septic shock, altered consciousness, respiratory distress, and low saturation requiring intubation, purpuric spots, mutable leukocytosis, blood culture has grown gram-negative beta. You can look at the both legs showing multiple purpuric spots. Sepsis presenting with shock and thrombocytopenia. This is an unfortunate child, 12-year-old girl. Fever for 4 days. She came with altered level of consciousness, hypotensive shock. She was deeply icteric. You can see the pallor, subconjugal bleed, purpuric spots, low GCS, clinically fitted with malaria, severe malaria. Urine color also confirmed that. Raised bilirubin, raised urea creatinine, hypoglycemia, hemoglobinuria, iron and metabolic acidosis. A smear showed falciparum gametocytes and trophocytes. Child was treated with IV artesunate ventilator support after 30 hours before it succumbs to the illness. This is an 8-year-old girl, came with 1 month of fever. You can look at the baby, look at the child. She has seborrheic dermatitis, exophthalmos, ear discharge, hepatosplenomegaly. Now, clear that you are coming to narrow down the possibilities. WBC 14,000, hemoglobin low, platelet low, and X-ray skull and CT showed well-demarcated osteolytic lesion in the skull. Diagnosis of Langerhans cell histiocytosis, LCH. Nowadays, many studies are available, biopsy, histopathology, and histochemistry studies are available to prove the diagnosis. This is a 10-year-old boy admitted to severe dengue with IgM positive. He continued to have fever beyond 1 week. So generally, we expect that child with dengue to recover by day 7 to day 8, but he didn't show much improvement. Fever persisted, hepatosplenomegaly, ascites, and mild jaundice. WBC, hemoglobin, and platelet starts falling. Of course, PC would have been raised further earlier. Now came down to normal, started falling down. SGPT, ACPT were rising, LDH was high. So these gave us 3 differential diagnoses. This picture on day 7 and 8, where we expect the child with dengue to improve. The child is worsening with falling platelet count, falling WBC, and falling hemoglobin. 3 possibilities: maybe a secondary sepsis, coexisting tropical infection, or infection associated HLH. Blood culture no growth. Other tropical screening was negative. Ferritin was increasing. We made a possibility of hyperferritinemic HLH. You can see the counts are platelet counts are going down. Ferritin is going up. Other investigation negative. The child was managed with IVIG. Child completely recovered. This again the child, 5-year-old girl with vomiting, fever, abdominal pain, hematuria, had decreased urine output, gross hematuria of 5 days duration. There is no history of loose stools. Pallor and purpuric spots were very striking. Urine album showed 4+ and plenty of RBCs. You can see the raised creatinine, hemoglobin 5.5, platelets 24,000. Peripheral smear you can see in the next slide showed a microangiopathic hemolytic anemia. LDH is high, retic count is high. So this fit in with the diagnosis of hemolytic edemic syndrome. The child is undergoing PD. Just before connecting the ventilator, the child is being bad. You can see the purpuric spots here. This is recent events, a 5-day fever, 12-year-old boy. He had dengue, NS1 was negative, thrombocytopenia, bleeding PV. Everything was looking like dengue earlier. But his CRP was positive, inflammatory markers raised, CRP positive, 154, ESR was 78, WBC count 6,400. Look at the lymphocyte 14. So lymphocytic neutrophil ratio is very low. COVID RT-PCR are negative, but COVID antibodies are positive. D-dimer 3.4. Platelet count was low. Ferritin was high. CT, in fact, he came with abdominal pain. Our initial diagnosis was appendicitis or enteric fever because of right leg was a tenderness and ileal thickening. Ileal thickening, free fluid abdomen. Cultures in dengue and tropical fever skin is not contributory. It was looking like an MIC-like pictures and COVID antibody positive. Treated the antibiotic and IVIG, child improved. Again, come back to the original where we started. Step 1, history and examination. Step 2, see whether sick child or well child. Step 3, we see the smear and decide whether we have to do bone marrow study or not. So what are all the things we will elicit in the history? A fever, diarrhea, child coming with thrombocytopenia, more likely to be HVS. Bone pain, particularly nocturnal bone pain, should point to the possibility of leukemia, particularly in child has got splenomegaly and pallor. The child is already on drug like heparin or carbamazepine, valproate. The drug-induced purpura also we should consider. Hepatomegaly, fever, 5 days, dengue, conjunctival congestion, myalgia, icterus, pallor, hepatosplenomegaly should point to a tropical infection like malaria, scrub type, malaria, leptospirosis. Of course, eschar will point to the diagnosis of scrub typhus, hepatosplenomegaly, pallor, bone pain. I'm repeatedly stressing many of the time child with coming with 7 to 10 days fever will turn out to be leukemia. Puffiness of face, hypertension, following diarrhea, dysentery, you should think of HVS. Seborrhea, exophthalmos, hepatosplenomegaly, consider LCH. Of course, investigations, baseline investigations, of course, always it is helpful. Lymphocytic leukocytosis, anemia, thrombocytopenia, blast cells in the smear suggesting leukemia, raised urea creatinine, microangiopathic hemolytic anemia, microscopic hematuria, HVS. Bicytopenia always should raise the possibility of HLH whenever a child is not recovering by 1 week in dengue or other infections, which should be supported by high transaminases, high triglycerides, and low fibrinogen. Osteolytic lesion in the skull will give a very simple diagnosis from a very simple investigation like X-ray skull. Specific investigations like bone marrow aspiration, serology, blood culture, histopathology, and immunocytochemistry and flow cytometry will be very useful when you point out to a particular diagnosis. Some lab combinations are very useful. For example, thrombocytopenia as a part of bicytopenia, relatively stable child in the early phase could be suggested a dengue. When the child becomes sick, we'll think of HLH and ALL. Thrombocytopenia plus transaminitis, it is a very good indicator that whenever you see a child with fever, thrombocytopenia and transaminitis, it points to narrow diagnosis to a tropical infection. Among the tropical infection, we see low counts and negative CRP, it is dengue, and all the other it will be lepto, typhoid, and scrub typhus. CRP will be raised and the total count also will be raised. Whenever there is multiple system involvement, as we saw in a child with severe malaria, encephalopathy, renal failure, anemia, hemoglobinuria, metabolic acidosis, when you see multiple system involvement, there are only 2 situations it's possible. One is malaria, severe malaria. Another is child developing infection associated HLH. Most of these situations, smear will be very useful in the early part. Bone marrow aspiration will be useful in later part of the clinical diagnosis. I'm coming to the last few slides. These are all, I given 5 smears. Each smear will give you the diagnosis. If you see a child, fever subsided but persistent thrombocytopenia, the platelet aggregates, it is indicative of scrub typhus. Child with jaundice, hemoglobinuria, encephalopathy, anemia, renal failure, this gametocytes will show the diagnosis. Child with diarrhea, recovered from diarrhea, developed pallor, thrombocytopenia, and renal failure. Cystocytes, helmet-shaped cells will give a diagnosis. Here, leukemia. Here, the platelet clump and satellitism. So what we understand is a single most investigation which will be able to pick up a very major diagnosis of peripheral smear. I think we are not training our students more on this aspect. Every student should be familiar to this. Coming back to the last slide. Fever, thrombocytopenia, transaminitis narrows the differential diagnosis, but shortcut never works. We have to go through these steps. Focus history, problem-oriented examination, basic laboratory, specific laboratory, differential diagnosis. Any child with tropical infection, HLH, and AL has to be considered as common causes. If there's a prolonged illness, evaluate for HIV. Whenever we plan to start on steroid, bone marrow aspiration is mandatory, irrespective of the diagnosis we make. So I'm looking at the net for once a week. There is a lot of directions we given for once a week. Once a week you clean the toilet, once a week clean the kitchen, once a week you dye your hair. But I feel that once a week, we should visit the laboratory to look at a smear, even a normal smear or anemia or leukemia or HUS. We'll develop that habit. If after the lecture, if our students pick up the habit, I'll be very happy. Thank you very much. Reaching a diagnosis by simple investigation is possible with the stepwise approach. Thank you very much for the opportunity.
Thank you, sir. We'll go through the questions. Chat box been filled with a lot of queries. That's why. Sir, is there anything, any other question? Only the chat box is full of other details, sir, actually.
Okay, so no questions. Thank you.
1 minute, sir. It's filled with 1 minute, sir. Many people have sent their same
MCA number, say the
MCA number and everything. That's why I'm not.
No question, you can proceed.
Okay.
That's why you want.
Yeah.
Thank you. Thank you,
Dr.
sir.
Narmada, please introduce the next panel.
I'll stop sharing.
Thank you so much. So I will. The next panel, Dr. Jayakumar sir. Thrimurgan sir, can you please share his introduction? So we are having a very interesting panel of how to treat resistant organisms in our office practice. So this was basically started with an idea to when we are meeting with the resistant organisms in the normal conditions, how do we really treat this? We have an allied panel for this headed by Dr. who's a professor and head pediatrics AIMS Kochi. He's also the executive board member of IAP Kerala. He's done his MBBS and MD from Government Medical College Trivandrum. He is also a fellow of Indian Academy of Pediatrics in 2011. He was a president of IAP in state chapter, president NNF Kerala chapter in 2013 and 14, and he was a national executive board member consecutively for 2021, 2012, and 2007 too. And he was a national secretary of IAP and Allergy and Immunology chapter from 2014 on till 2017. He has 4 international publications, 5 national publications, and he is also the postgraduate examiner for the past 13 years. And he has authored various chapters in various books. We are very happy to have you, sir. Over to you to introduce your panelist.
Yeah. So thank you, Dr. Narmada. Can you hear me?
Yes, sir. Yes, sir.
For the nice introduction. So at the outset, I would like to thank Tamil Nadu State Chapter of ID for your kind invitation to present this problem, resistance of important or common organisms. To discuss with that, I have esteemed panelist, Dr. Nemithan. He is the consultant pediatrician and the MD of Children's Hospital, Kovai, and Dr. Balajendra, senior consultant pediatrician Kerala Government Service, and Dr. Shrija Segunan, associate professor and intensivist from Government Medical College, Trivandrum. So before I begin, I should thank the president of Tamil Nadu State Chapter, Dr. Ismail, and South Zone Vice President, Dr. Nagaraju, Dr. Rajendran, Dr. Sudhagar, and Dr. Vengadeswaran, the South Zone President of an Infectious Disease Chapter. And most importantly, all my pediatricians, my fellow pediatricians from Tamil Nadu. Thank you so much for kind invitations. So, unresponsive organisms in office practice. So that's the topic. Okay. So you know that antibiotics are the gift of the mankind. Key weapon for the survival of the mankind is antibiotics. But at the same time, it's a double-edged weapon. So use and throw culture leads to alarming consequences. So you know that only 13 class till 1980 and only 4 class of antibiotics after that, not very much. So you have to use it when you are in need. But I would like to say that you have to keep it in our locker, as in the case of our precious ornaments, for reuse. No compromise on optimization of antibiotic dose, duration, and for that matter, anything. So whenever possible, before you start antibiotics, do take culture before we start an antibiotics. For example, CSF culture, urine culture, blood cultures, various cultures in a few, various cultures in fever with the rashes, either maybe induced saline or gastric aspirate or culture from a procured tissue sample. For example, BAL or gene expert, you have to do all those things. and then practice one antibiotics in more than 85% of scenarios, whether it is in the OP practice or in IP practice, and 2 antibiotics in at least 10% only, and more than 2 antibiotics only less than 10% cases. Okay, and immunocompetent host, watchful waiting in children with the fever if there is no definite evidence. But immunocompromised host, aggressive antibiotic administration, there is no doubt about that. But you have to practice antibiotic cycling in ICUs and PSU. So with this introduction, let us go to some of the case scenarios. So my first question is to Dr. Shija. So this is a case scenario of a 4-year-old male child, thriving very well, high fever 103. He complains of dysuria. Not sure about the stream of the urine. So I used to say to my mothers that when they come for review in the newborn period, they have to come out with a video of the urination. So male children, we can't go and verify whether the stream is good or not. Suppose they come out with a video of the urinary stream. It's very easy for us to know whether the child is having a poor stream or not. In this case, pustules numerous. Child was started on cotrimoxazole, time of the 10 milligram per kg per day, twice every day. But the parents themselves stop treatment after 5 days as the child is to be asymptomatic. Dr. Shija, your thoughts? Whether did we err in the management? Whether anything wrong in the management? Dr. Shija?
Yes, sir. First of all, good evening, and thank you, the Tamil Nadu team, for giving us this opportunity. So coming to the topic, what the sir has posted the case. So we are having here a 4-year-old boy who is having high fever and probably a UTI because he's symptomatic. He has a dysuria and pustules are plenty. So an empirical antibiotic is definitely warranted in this case. But what we have not looked into is we haven't confirmed the diagnosis. We haven't sent the urine for culture. Unless we send it for culture, we would not know what antibiotics the patient is sensitive to, whether our empirical antibiotic was right, whether we need to change. So that part we haven't done. We haven't looked into the predisposing factors or the etiology or the probable cause why the child developed a urinary tract infection. Regarding his urinary stream, on examination, did you get the kidneys palpable? Was there a renal angle tenderness? Is there a constipation? All those, any spinal abnormalities, any previous history of UTI, all that are important. And the third and the most important is regarding the counseling, regarding prognosis, that is how long you have to treat and what are the complications that you're anticipating. So all these 3 parts are important in any child who's presenting to you with a urinary tract infection.
So Dr. Shija is very clear. First of all, you have to confirm the diagnosis for that culture and sensitivity is very mandatory. So you have to look for anorical anomalies, bladder is distended or not, she has told the constipation present or not, dribbling present or not, nephromegaly present or not. And also you want to say about something about tight phimosis. Isn't it like that?
Yes, yes, sir.
Okay, definitely. Then. And poor urinary streams and spine, we also have to look because child baby is having some spinal problem, spinal dysraphism, that also has to be looked. Thank you so much, Dr. Shija. And the story continues. Readmitted, the same child readmitted after 10 days due to high fever and vomiting. Child is very toxic and we found that child is in persistent pyuria. And urine culture result, E. coli resistant to cotrimoxazole, cephalexin and cefotaxime, and quinolone is sensitive. What next? What's the I want to know about what's the short-term management, what is the best method for collecting urine for culture and sensitivity, and do you want to image these children?
So coming to the first question, that is, what is your short-term management? So now we have a child who has now come back with a complicated UTI because he's having high fever, he's having vomiting, he's toxic. So from an ordinary UTI, he has moved on to become a complicated UTI. So definitely the child requires admission, proper hydration, supportive care, and also a parenteral antibiotic. Now the parenteral antibiotic.
He needs admission.
Yes, he definitely needs it. This child will definitely need admission. And this time, definitely we are going to take the urine, send it for culture and sensitivity, start him initially, but we already have the culture report telling about the sensitivity pattern. But whatever it is, the child requires admission, child requires parenteral antibiotic. The next is the correct dosage of antibiotic. And we have to see that it is not mandatory that you're going to give the antibiotic for the whole duration. That means you require treatment at least for 10 days, may extend up to 14 days, depending upon the clinical scenario. But initial 2 to 3 days, IV is mandatory. After that, when the child is febrile and the child is improving, you can definitely change it to oral antibiotic for the completion of the course. The next is, do you want to send a repeat culture? A repeat culture definitely is not mandatory. But if after 72 hours of appropriate therapy, child is not showing response, the child remains febrile and child is toxic, then a repeat culture is needed. Then how do you want to take the culture? Now, this is a 4-year-old child. You can definitely take a midstream clean catch urine culture can be taken. Even a catheterization to obtain a sample can also be done.
So what about ultrasound guided suprapubic aspiration for collecting urine for culture and sensitivity? In Kottayam Medical College, you know, the each and every patients, they used to do like that, suprapubic aspiration for urine culture and sensitivity.
It can be done, but personally, I wouldn't advise, because we are really moving away from less and less of invasion. So if you are a clean catch urine sample is giving you as well information, in this scenario, I wouldn't really like to go for a suprapubic puncture. It can be done. Definitely it can be done. And it's more sensitive. The colony count will be more sensitive from a suprapubic aspiration rather than from a midstream. But I would personally still go for a midstream or a clean catch or a catheterization sample.
Dr. Shija says even though it's a gold standard or a platinum standard, she prefers a clean catch specimen rather than the gold standard or platinum standard. So what about our imaging strategy?
This child definitely is a complicated UTI. Otherwise also, the child definitely requires an ultrasound abdomen to look for the kidney size, any perinephric collections, any hydronephrosis. That part is mandatory. And subsequently, he also needs a DMSA scan. And if any of these are abnormal, that is, if you find something abnormal in the ultrasound or you find something abnormal in the DMSA, he will require an MCU. Otherwise, routine MCU is not needed. And the timing would be, you need to do a DMSA 2 to 3 months later and not in the acute stage, whereas ultrasound should be done while the child is admitted in the hospital in the acute stage itself. And MCU, if needed, that is after 2 to 3 weeks of antibiotic completion, and that too usually with the antibiotic coverage also.
Could you please elaborate once more about this imaging procedures?
Imaging procedure basically depends upon the age of the child. So if you have a UTI, your decision what imaging to do, in fact, depends upon the age of the child. So if the child is less than 1 year, the latest, the 2021 guidelines by the IAP recommends all the three. That is, you need to do an ultrasound, you need to do an MCU, as well as a DMSA scan. We all know that that is a little bit of a controversial topic, because most of the Western guidelines have now moved away from MCU for children less than 1 year, telling that only if the other two are abnormal or if the child is very sick or not responding to your antibiotic, those children need only go for MCU. But for the time being, IAP sticks on to the guideline that less than 1 year, all the three needs to be done. That is because most of our children may not come back for follow-up, or our counseling might be inappropriate. We may be missing cases, and antenatal ultrasound is not a routine for all the babies. Taking all that into account, IAP sticks to that. All the three imaging modalities should be done for less than 1 year with a UTI, because they are a high-risk population. When it comes to children between 1 to 5 years, what is recommended is you have to do an ultrasound as well as a DMSA scan. If anything is abnormal, then you go ahead and do an MCU. For children who are more than 5 years, only an ultrasound is recommended, and the other needs to be done if ultrasound is abnormal. If a patient comes to you with a recurrent UTI, the patient definitely requires a DMSA as well as an MCU.
So it's very clear. It's 3, 2, 1. 3 in less than 1 year, 2 in 1 to 5 years, and 1 in more than 5 years. It's quite clear. And anyway, image is a must in a culture-proved urinary tract infections in children. Okay, that's good. Thank you so much. My question is, resistance common with urinary pathogens, and what could we do to prevent resistance in ESBL producing organisms in general, and in particular in urinary tract infection? And what are the antibiotics you like to start empirically in most of the patients with the urinary tract infection? And how common is ESBL enterococci? And once you prove that, how will you treat these infections of these ESBL organisms? So, and last question, whether child need prophylactic antibiotics in VU? A lot of questions. Could you please answer all these questions? So I'll repeat if you want.
Okay, we'll go one by one. Is resistance common in urinary pathogens? Yes, definitely. Resistance is common in urinary pathogens. But
and we saw in this case also. Okay.
Yeah, we saw in this case also. It is quite common, in fact. But only difference is that you need to know your local antibiogram, because hospital differences may be there, city differences may be there. So there is a lot, even from India, the different studies that are coming from different parts of India say different percentage of resistance. So you need to know the local antibiogram to decide on that, what antibiotics you need to give. But definitely we need to understand that urinary pathogens do show resistance. So this particular study, in fact, is from the Northeast, where you can see that the resistance to ceftriaxone is very, very low, just 2%. Whereas the next study is from South India, and you can see the resistance is quite high. It is close to 50%. So there is a regional variation, and we need to be aware of that. The second question is, what could we do to prevent resistance in ESBL producing organisms in general and in urinary infections in particular? So the most important thing is, please do not give antibiotics for asymptomatic bacteriuria. The second is, when you have a bacteriuria, see whether it is symptomatic and always confirm it with a culture, because every pyuria is not urinary tract infection. It may be part of a systemic infection. So we need to differentiate between the two. When you have in children and you have catheterized, ensure that the catheterization is done in the most sterile manner, and try to remove the catheter as soon as possible. Here again, a catheterized patient having a urine culture positivity does not mean that the child requires a treatment, because it may be just a biofilm. Removing the catheter may be curative. Unless it is symptomatic, you don't need a treatment there. And when you're finally treating a child with UTI, see to it that you're sticking on to the proper antibiotic, the proper duration, and the proper dose. So that is important. And in your hospital, when you have ESBL organism or resistant organisms, always follow all the contact precautions now to see that it is not spreading from one child to another. So that is also very important. Then
last question is whether these children need prophylactic antibiotics, and how long you have to give this prophylactic antibiotics.
Okay, prophylactic antibiotic duration or this thing will depend upon what is the grade of VUR. If you have grade 1 or 2 VUR and your child is less than 1 year old, you need to give prophylaxis till 1 year of age. But otherwise, it is prophylactic antibiotics are recommended only for children with higher grades. That is grade 3 to 5 only. You need to give prophylaxis, and that is only up to 5 years of age. So prophylaxis for VUR depends upon the grade of VUR.
So it's quite clear, as Dr. Shija has correctly said. You know that pyuria is pustules more than 5 per high power field in 10 ml centrifuge urine and more than 10 per cubic millimeter in uncentrifuged urine. And as she said correctly, so all cases of pyuria are not due to urinary tract infection. You have pyuria in nephritis. You have pyuria, sterile pyuria in Kawasaki disease. All these are not urinary tract infection. Thank you, Dr. Shija, for your wonderful explanation. Now the question is, and my message is that confirm urinary tract infection children with the fever, with or without focus, irrespective of the gender, by culture and sensitivity. Stand by antibiotics even before the culture results are available. You can't wait for the culture results, but you have to take the culture before you start antibiotics. Image all. Adhere to the antibiotics dose and duration. Prophylactic depends upon the severity of the VUR as told by Dr. Shija, and counseling is a must in urinary tract infection. So you have to advise them to prevent further episodes of urinary tract infections. Especially, I would like to suggest to my patients that squatting maturation that empties the bladder completely, prevent constipation. So these are some of the important advice that you have to give to male children, and see the stream of the urine, and also wash from front to back in females. So sterile hygienic practice is very important. Squatting maturation do a lot of things, and you have to correct phimosis, especially tight phimosis in all children with a urinary tract infection. Thank you so much, Dr. Shija. Now, and other important thing is that ESBL E. coli is on the rise. Higher mortality and longer hospital stay due to ESBL organisms. Reduce the clinical and microbiological response when compared with infections that do not produce ESBL. You can slow the spread of the ESBL by barrier protection, as she said earlier, and restriction of third generation cephalosporins. Okay. Now the question is to Dr. Another scenario I want to say that this is a case that happened before the COVID pandemic. That means somewhere in June. This patient returning from Mumbai. So admitted due to 12 days history of fever. This is to Dr. Nathan. Please listen.
Yeah.
Abdominal pain, vomiting, loose stools, and occasional cough. Both hepatitis splenomegalis is there. Vital stable, pickle normal. Routine investigation showed leukopenia, thrombocytopenia. Right now we heard from Dr. Thangavellu sir about this thrombocytopenia. Dengue combo negative. Peripheral smear non-contributory. EBV IgM negative, equally positive. Chest X-ray mando urine within normal limits. Typhoid OT is positive, and Vidal 1 in 320 awaiting the results of blood culture. So, 1 second. So for this child, start on ciprofloxacin 20 milligram per kg per day as a BD dosage. but high spiking fever continued irrespective of the antibiotic even after 7 days. USG done to roll out cholecystitis, but it is normal. Blood culture grown, heavy growth of salmonella, enteric typhi, and resistant to quinolones. So my question, have you come across similar situations in your clinical practice, Dr. Neminathan?
Yes, sir, of course.
Okay. And
Yeah.
could you please elaborate, why does this happening, this resistance to antibiotics? So quinolones, with this patient is sensitive, they are started on quinolones, and what is the reason for this failure of this antibiotics? Is it because of a resistance that has developed, and what is the reason for that?
Yeah, probably with the history, if you are the child coming from Mumbai is a place where the antibiotics, particularly quinolones, are used left and right. So the highest resistance to quinolones happens in Mumbai. So it is a capital of quinolone resistance. So it's the reason is the wrong empirical choice of
the Utthav Thackeray is not there in the group. Okay.
Yeah. And probably it happens. We need to be very, very selective in choosing empirical antibiotics. And of course, quinolones does not come as an empirical therapy. It's a restricted use drug. So basic problem is misuse of drug. Yeah.
So that means the wrong antibiotics they have selected and wrong dose and wrong duration. Is it like that?
Yeah, it's
okay.
right.
Okay, yeah. Then. So misuse of antibiotics, the reason for this occurrence of resistance. Thank you, Dr. Neminathan. So the question is, okay. So can you predict the drug resistance in Salmonella enterica typhi and enterica paratyphi infection? So what's the answer?
Definitely. Most of the time what happens is, in the culture report, the report says quinolone, that is ciprofloxacin sensitive. But when you try in the patient may not respond, as in this case with 7 days of quinolones and adequate dose, the fever doesn't come down. It's because in vitro it will be sensitive, in vivo it will not be sensitive. Another important thing is, most of the labs, they do not use this nalgesic acid disc in the antibiotic panel. So what says is it's ciprofloxacin sensitive, but in the true case, what we need to do is, we need to do either nalgesic acid or a p-floxacin disc, and then see for as a quinolone surrogate marker. If nalgesic acid resistance is there, you should not use ciprofloxacin, even though if ciprofloxacin sensitivity is reported there in the research. So message is, you have to look for nalgesic acid sensitivity rather than looking at the cipro sensitivity.
So you have to look for this sensitivity pattern. This. Okay, and this. Yeah. Okay, then. So what's the short-term plan for this child?
The shortest plan is to stop the cipro. Okay. The first thing, the moment you see the child, and then look at the antibiotic pattern, see for the best sensitive antibiotic. I'm sure ceftriaxone will top the list. In that case, I will start at the dose of 50 to 75 milligram per kg per day in a 2 divided doses.
So that message is clear. Sir is saying that I need not start 100 per kg. Most of the people start 100 per kg straight away for any infections. So he wants only 50 to 75 per kg depending upon the sensitivity or the dose that he prefers. Okay, 100 per kg is not needed for this type of infections. Okay, thank you, sir. And then the question is that, okay, this problem. So this antibiotic was changed to ceftriaxone for this patient, 50 milligram per kg per day. So that was only sensitive drug. Even though the temperature subsided within 48 hours after starting the ceftriaxone, the fever recurred. At this time, you know that they have done an MRI straight away, and that showed evidence of osteomyelitis in the left femoral head. So ceftriaxone hiked to 100 per kg per day and continued monitoring of the CRP, but the child responded very well after this increase in the dose of ceftriaxone to 100 per kg per day, and that they have given for a longer duration, around 4 weeks, based upon the CRP. Okay, then my question to you is that, so how you come across similar problems in your practice when you manage children with enteric fever?
Of course, many a times I have seen such a similar situation. Basically, typhoid is otherwise called as enteric fever. The name itself is a misnomer. Actually, enteric fever is not related to enteric alone, typhoid. It's a multi-system disease. So you expect, naturally, you expect any complications arising from any system, from head to foot, from CNS to bone and joint. any system, it can cause complications. And this complication of osteomyelitis, in such a case, I would look for any hemoglobinopathy, particularly sickle cell, or take a history of past bone marrow injury, bone injury, or a joint surgery, or a local fracture, or an immunosuppressive disorder that can lead to such situation. And most of the time, it happens in the end of long bones. So, having diagnosed this one, I will definitely go for, as done earlier, I'll go for sequential antibiotic therapy. Sequential antibiotic therapy is changing from ceftriaxone from 50 milligrams to 100 milligrams per day, and then to monitor the child clinically based on the fever, pain, and clinical symptoms, and also monitoring the child by CRP and ESR. If everything goes on well, gradually I will taper from IV to oral, and then I'll maintain the child on 4 to 6 weeks of antibiotics.
So here you will take to give cefodoxime rather than cefixime. Is it like that, sir?
Yeah, cefodoxime will be a better choice in bone and joint rather than cefixime.
Sir is very clear because he is very familiar with this hemoglobinopathy in sickle cell anemia. He may be getting patients from tribal population in Palakkad district, Attapadi region. Here, sickle cell anemia is very common in Kerala, in that part of the Kerala. And also, you have to look for other complications in the CNS, pulmonary, cardiac, GIT. So each and every organ may be affected in case of salmonella infections. Thank you, sir. Okay. So he said he will continue with the ceftriaxone. He will make use of this antibiotics based upon the CRP level. So how will you prevent salmonella infection in the community? Any method? Because we should be ashamed that we have salmonella typhi in the community. So we are trying to eradicate measles, but salmonella typhi is a bad disease. It's a shame for our country if children are having typhoid fever.
Yeah, I do agree, sir. Basically, prevention is aimed at 3 levels: at community level, at individual level, through vaccination. At community level, definitely we need to educate the public about boiling water and taking. Most of the time, it is the corporation has to take up central coordination, and safe potable drinking water. It's a part of the government to provide that. At the individual level, we have to educate our patients, particularly to avoid street food, particularly ice cream. When coming to ice creams, most of the time, particularly during school holidays, during April-May vacation, we do find lots of outbreaks of salmonella following ice cream intake, because these ice cream chambers, this ILR, where the ice cream is kept, salmonella typhi organism can thrive for nearly 30 days. So ice cream is a source of salmonella typhi. And cut fruits that are not clean, uncooked food street side, and tracing out food handlers and carriers and treating them is very, very important. And the lastly, coming to vaccination, all of you are aware, you have this typhoid conjugate vaccine that is given from 6 months of age. It's a wonderful vaccine. IAP has taken it up. And the other vaccine is TY21A, oral vaccine. It's a mutant variant.
Sir, is it available right now? Because
that's not available. Earlier it was available in India.
So now but we are using only conjugate typhoid vaccination, the only vaccine that's available in our country.
Yeah.
Sir is very clear in the sense that the prevention, he said central chlorination is very important. So you have to use municipal water supply where there is chlorination. Suppose if you take well water, so people in Kerala are very intelligent and they used to take from well water. In that process, they will get infection because that is not chlorinated. If possible, take chlorinated water from the municipal water supply or corporation water supply. So that's the message that you have to give rather than well water. So that is not chlorinated. There is chance for infection, especially when they share the bucket. Okay. Okay. So what is the resistance pattern in salmonella infections in your state? Dr. Neminathan.
Truly speaking, ciprofloxacin resistant is a pan-India resistant.
Not in Tamil Nadu, everywhere it is there.
Yeah, okay. Yeah. And Tamil Nadu, one of the topping the list. And in Coimbatore, we do see lots of majority, nearly 80% of the cases are ciprofloxacin resistant. And ampicillin chloramphenicol resistant is sensitivity is slowly gaining back. It's becoming more sensitive. And ceftriaxone resistant, particularly in Tamil Nadu, is practically zero, sir.
So ESBL producing Enterobacteria salmonella is quite high, and as a result, you are preferring to use ceftriaxone rather than ciprofloxacin or chloramphenicol or ampicillin. Your choice is ceftriaxone. So do you have to use any other? If patient is resistant to ceftriaxone also, what will you do, sir?
So in those cases, I will choose azithromycin 10 to 20 milligram per kg weight per day.
High dose.
For a for a period of 7 days. And if there is allergy to cephalosporins, I'll use aztreonam. It's not meropenem, it's aztreonam.
Okay. So that means, so you have resistance against quinolones, you have resistance against ampicillin, chloramphenicol. So you have multi-drug resistant salmonella typhi, and you have extensively drug resistance including ceftriaxone. And where you have the choice is azithromycin. I fear that even Pakistan, even azithromycin is also resistant to this against salmonella infection. So new name is salmonella typhi Enrica typhi. So what about that patients coming from Pakistan? What is the choice?
Pakistan people.
Fortunately, nobody is coming from Pakistan into India.
Unfortunately, people don't come to India. Even if they come, we have to be very careful because it's almost pan-resistant. They are resistant to all drugs. In those cases, as per evidence, we need to start on ofloxacin 15 milligram per kg per day for a period of 14 days. Or you can use, once again, if they are sensitive to ceftriaxone at a dose of around 60 milligram and cefotaxime at dose of 80 milligram per kg weight, you can try. If they are fluoroquinolone resistant, as indicated by nalgesic acid, you can use azithromycin.
Okay, thank you so much. So, my dear friends, you have to see that resistance is quite high against salmonella. So, you have multi-drug resistant salmonella and also extensively drug resistant salmonella, and even resistance to azithromycin also has been reported. And you should be very careful in seeing the resistance. And most importantly, prevention is better. You have to immunize all the children against salmonella type from 6 months of age onwards. And as sir said, only single dose is sufficient. So tell people to vaccinate against salmonella typhi. Okay, thank you so much. Next question to Dr. Bala.
Yes, sir.
So this is a case scenario. 2-year-old child vaccinated as per national immunization schedule. That means they have not taken this what do you call hepatitis A or conjugated pneumococcal vaccinations or other varicella. So they have taken only this Pendavac, OPV, Rotavac, and MR only. And then fever 104, no, only URI symptoms, incessant crying. Child was shown to a pediatrician, he diagnosed acute otitis media, bilateral. And unfortunately, he was started on cefixime and 10 per kg per day for 5 days. Even after 3 days, antibiotics fever didn't subside, and in fact, discharged from the ear, bilateral and discharged from both ear. And but at the same time, there were irritability and fever reduced. So, what are the thoughts, Dr. Bala?
First of all, let me thank our organizing team of IAP Tamil Nadu chapter and the ID chapter of Tamil Nadu, and our Vice President Nagaraj sir and my friend Narmada for giving me an opportunity to be part of the Tamil Nadu CME. So in this case, we have a 2-year-old child with on national immunization schedule, where we all know that 2 vaccines are lacking to prevent acute otitis media. That is, one is a booster dose of Haemophilus influenza and the pneumococcal PCV13.
Pendavac they have taken. They have not taken booster dose. They have not taken booster dose of influenza.
Booster dose is not
included.
So, so with this immunization in mind, it is the practitioner has diagnosed as acute otitis media. It's not wrong, but still, when a child comes with incessant cry, it may not be always acute otitis media unless you do the otoscope. And here the organisms commonly seen with acute otitis media is Pneumococcus, H. influenza, Moraxella. That is the most common organisms affecting the acute otitis media. But other organisms like Group A Streptococcus and gram-negative organisms can also cause otitis media, especially in newborns in the IP settings. In CSOM, Pseudomonas and Staph aureus are more common, and in developing countries we get Mycobacterium tuberculosis, and of course virus is part of all diseases, and Mycoplasma.
Dr. Bala,
so
what about the choice of antibiotic that he has selected? He has selected cefixime.
Yes, sir, I'm coming to it. In this case, Pneumococcus, H. influenza, Moraxella is common organism, so everybody knows the amoxicillin is the drug of choice. So in this case, cefixime is started, and there's a journal saying that cefixime is for all infections below the diaphragm. And so in this case, antibiotic choice also is wrong. And otitis media, this condition, the spectrum of disease where you get acquired otitis media with effusion and the CSO. And this tympanic membrane, you can see the tympanic membrane as a dull.
One second.
Yeah. Next slide. You can see this picture, a dull, lusterless picture of normal tympanic membrane on otoscope. And if it is acute otitis media, you will get an epithematous bulging. And in the last picture, you can see the perforation if there is, if it is not properly treated. So, so in this case, the diagnosis may be correct, but the antibiotic choice is wrong. So that is why the and for a 2-year-old child, he has started antibiotic on day 1. It is reasonable because
bilateral tell us.
Bilateral also. So the reason for starting early antibiotic, according to the AAP, American Academy, is that most of the pathogens causing acute otitis media is the bacteria, and the 2 is it will prevent suppurative complications like perforation, and symptomatic improvement resolution is far better. So, but IAP guidelines say if only the child is sick with fever more than 100 around high fever with severe pain, then we can start antibiotic in more than 2 years. Otherwise, we can wait for 24 to 48 hours before starting the antibiotic. And most of us start amoxicillin.
IAP recommends amoxicillin rather than cefixime or some other drugs. First line is amoxicillin.
Amoxicillin is the difference is the dosage between AAP and IAP. We haven't got, according to IAP, we don't have much resistance to pneumococcal this thing.
In India, it is not there.
50 milligram per kg per day is enough. And but AAP says it is 80 to 90 milligram per kg per day. And most of us use amoxicillin rampantly, but in this case, the 3 indications for starting amoxicillin is one is if you used amoxicillin or any other antibiotic within 30 days, last 1 month, or if the child presents with conjunctivitis and along with the otitis media, the chance for this H influenza is more risk. You can start amoxicillin, or child receiving chemoprophylaxis, which is not given nowadays for recurrent otitis media. So always diagnose.
But 1 second. After the use of this Pentavac, the H influenza is not a very rare cause for otitis media, because most of the people have been vaccinated against H influenza by this Pentavac. So it's not coming to the picture at all. Okay.
And always use an otoscope, even if not pneumatic otoscope, for diagnosing otitis media.
So the postgraduate should have an otoscope with them.
Otoscope and ophthalmoscope. Follow up on day 3 and day 10.
Okay.
Day 10, we have to do the impedance audiometry to rule out the serous otitis media, which may be asymptomatic.
Okay. And next, story continues. Child continues to high speaking fevers and was admitted in another hospital. The CRP elevated, CBC counts more than 20,000. Blood and urine cultures taken, and child was started on injection ceftriaxone 75 per kg per day. And fever subsided, stopped antibiotics due to financial reasons, and got discharged. They have received only 1 dose of ceftriaxone. And 1 month later, they again consulted the first pediatrician with a bilateral non-resolving discharge from both ears. So what are your thoughts, Dr. Bala, at this time? See the story. So they have treated treatment first with cefixime, then with ceftriaxone, and after first dose, 1 dose they stopped, and then after 1 month they have bilateral purulent and discharge from both ear.
Yeah. Here in this case, this child has not the previous slide, sir.
Okay.
In this case, the child had not perforation. That perforation has not healed. Child is having the non-resolving discharge from the last 1 month. From the history, what we can see is that the bilateral non-resolving discharge for the last 1 month. So more chances of unresolved otitis media, because CSOM there should be more than 6 weeks. So it may be either unresolved otitis media or recurrent otitis media. And CSOM occurs when it is partially treated or inadequately treated, and as in this case, where you get a perforation of the tympanic membrane with the tympanosclerosis and a traction pocket in the tympanic membrane, and there will be chronic infection of the mastoid as well as the middle ear. And this unsatisfactory response maybe due to the poor compliance, as in this case, or maybe intercurrent infection or persistent association to dysfunction, reinfection, or impaired host defense. And repeat admission, in this case, repeat admission in a month can be due to organisms like pneumococcus or MRSA, and also this child has not given PCV, pneumococcal conjugate vaccine, so more likely to be a streptococcal pneumococcal vaccine.
So that's a strong possibility, because child is immunized as per the NIS schedule only, and child has not taken vaccine against strep pneumo. So my question to you is that, is it due to resistance or the complications of otitis media? What's the management strategy in acute otitis media? How will you prevent acute otitis media? Is it possible to prevent? And what's the management strategy in chronic otitis media? So do you have any suggestions to prevent hearing impairment? You know that frequent otitis media can lead on to conductive hearing loss. So could you please elaborate?
Yes, sir. So this is not a resistance case, but because there is no proper treatment the child has taken because of the financial constraints. This is a complication of otitis media. As you all know, otitis media is a very common age group, 6 months to 24 months, where it's a spectrum disease where you get acute otitis media, middle effusion, and then you go into CSOM. And here, the acute complications are the perforation, or maybe brain abscess, subdural edema, all neurological complications. Non-acute complications like chronic perforation, otitis media with effusion, adhesive otitis media, cholesteatoma, and aortic hydrocephalus. And even though most of the effusion resolves spontaneously, 25% can last more than 3 months and 10% can last more than 1 year. In such cases, you should always look for speech, language, hearing problems, because this is a chronic problem. They will not, since the child is asymptomatic, they will not go for an expert opinion from an ENT physician. So speech, language, hearing problems, balance disturbance, and behavioral problems can occur with the long-standing conditions of otitis media.
So what's your acute management?
Yeah. So the second question is about the management of otitis media.
Yeah.
So pain relief is very important. You can use paracetamol, and in some situations you can use Brufen, ibuprofen.
So do you prefer ibuprofen or NSAIDs in COVID season also, Dr. Bala?
When there is an epidemic condition, or maybe after June, July in our state, I don't think we should use Brufen, but some somewhat healthy conditions like March, April, there is no harm in using ibuprofen properly. And you can use benzocaine anesthetic ear drops, and always use earplugs to prevent entry of water into the ear. And the antibiotic of choice, so after the pain relief, antibiotic, everybody knows antibiotic is a drug of choice, and there is some difference between IAP and AAP. So regarding the dosage only, the less than 6 months always start empirically on antibiotic. The child presents with incessant cry, and if you use otoscope, is better. And between 6 months to 24 months, if the child is toxic and with high fever or otalgia, up to we have to start antibiotic definitely. And up to 2 years, antibiotic should be given for 10 days, 2 to 6 years, 7 days, and after 6 years, maybe 5 to 7 days. Always review the child on day 3 and day 10 to rule out serous otitis media. The drug of choice is amoxicillin, and if the child is already on amoxicillin, you can give amoxiclav, or if it is not responding within 48 hours, the pain will be relieved in 48 hours. If it is not, then you can start on cefpodoxime, cefuroxime, or cefdinir. And if the child is very toxic, if you want to admit, then you give IV ceftriaxone 50 milligram per kg per day for 3 days. And in spite of 2 courses of antibiotic, the child is not responding, it's better to refer to an ENT surgeon and get a laryngotomy done, a small incision 1 millimeter on the inferior quadrant of the tympanic membrane. That will relieve the pain definitely.
So laryngotomy is indicated in acute cases. Okay, then how will you prevent this otitis media? Is it possible?
Yeah, otitis media can be prevented. You all know that 90% of the cases are due to the viral infection, especially in
that
the
you can't prevent.
Nowadays, both the parents are are going for job, and the child will end up in daycare center from year 1 onwards. So the children after the age of 1 year more chance for getting viral infection and disposing to the otitis media. So prevent daycare settings. And second is the vaccination. Now you should always go for a pneumococcal conjugate vaccine. And as said, Haemophilus influenza 3 doses are taken. Better to take the booster dose at 1.5 years also to get a complete protection. and promote BFHI. That breastfeeding is very important. The immunoglobulins and B and T cells in the breast milk and the non-immune factors like interferon and glycoproteins all will help in preventing otitis media. And the oligosaccharides in the milk will block the pathogens entering into the mucosa. And in the passive smoking, regarding passive smoking, this global blood cell hyperplasia occurs, and there is mucociliary transport will be affected, and the cotinine on biochemical marker regarding acute otitis, passive smoking and association with passive smoking and otitis media is increased in passive children affected with otitis media due to passive smoking. And always pacifiers, even though we don't use much, but in foreign countries they use pacifiers, and in our place also bottle feeding in supine position, that has to be discouraged.
So message is quite clear. Message is quite clear. So you have to give a vaccine, whether it's a 10-valent Synflorix or Pneumocil or a 13-valent PCV13 or Prevenar. It's very important that all of your children should be vaccinated against strep pneumo, and promote breastfeeding and avoid passive smoking. And Bala is seconds using pacifiers and supine bottle feeding. Thank you so much, Bala. And now, so then what about the chronic CSOM? Do you have any suggestions?
Yeah, chronic CSOM, the drug always start with autotopicals like fluoroquinolones, or better to combine with a steroid, which has got a better effect. And systemic antibiotic only if there is systemic symptoms, or if there is failure of autotopicals, or if there is child is not cooperating with the autotopicals, you can use systemic antibiotic after oral toilet. You have to clean the ear and then send for culture and sensitivity also. There is no role for, otherwise there is no role for antibiotics, but antihistamines, steroids, decongestants, mucolitis, and intranasal steroids. You can do myringotomy and insertion of grommet tube if there is recurrent otitis media, like 3 episodes in 6 months or 4 episodes in 1 year, with the last 1 episode within the last 6 months. And also the one indication is the hearing loss of more than 40 decibels. When you do the impedance audiometry, if you get the hearing loss of more than 40 decibels, then you have to do. And tympanомastodectomy is a surgery if there is complication like mastoiditis and other neuropathic.
That's in CSOM. That's in CSOM.
Yeah, I'm talking about CSOM. And adenoidectomy if there is recurrent airway obstructions, especially and obstruction, and it's better to avoid in submucous cleft palates. Otherwise, you can do adenoidectomy, give some protection. And lastly, the antibiotic levofloxacin in some case of refractory otitis media, when you suspect when all other antibiotics fail, you can use levofloxacin, and vancomycin and metronidazole also sometimes may be useful in refractory cases.
So you want to use systemic antibiotics only if the child is having toxicity. Suppose the child is in CSOM and then suddenly child become toxic, then you may administer systemic antibiotics.
Having systemic symptoms, the child is toxic.
Okay, fine. So then, okay, that you have told. Then next one is so
previous slide.
Okay. What about hearing loss in this condition?
So the
preventive strategy to prevent hearing loss.
Strategies to prevent the hearing impairment. As you all know, the otitis media with effusion can produce hearing loss, conductive or sensory neural, and average loss is around 27 decibels, even though 15 to up to 40, and more than 40 is an indication for meningotomy. And tympanic perforation will have a grommet tube insertion, and tympanic membrane perforation will have 20% loss in hearing, which will heal without any sequelae. So acute otitis media can also produce 20% hearing loss, which will recover once the tympanic membrane is healed. And otitis media, the effusion can produce up to 35% hearing loss. So grommet tube insertion will definitely relieve the hearing impairment. And as preventive strategies related to the otitis media, various preventive strategies are the adenoidal hypertrophy. You have to do the adenoidectomy. As in this previous slide, I've shown a boy with a typical adenoid facies, and there are a lot of associations with this CSOM. This allergic rhinitis can occur in association, where you can have to use the inhaled nasal spray. Antihistamine use has to be sterile. early diagnosis of otitis media with early antibiotic. I've given 3 reasons for starting early antibiotics, and properly and timely insertion of grommet tube or meningotomy, and vaccination also I said earlier, and BFHI to encourage and stop passive smoking, which is very common nowadays in our family. And in general, what we have to to prevent hearing impairment, always do as a newborn screening program, OAE, and neonatal jaundice has to be looked into. Hypothyroidism has to be ruled out, and any newborn with a prolonged NICU stay, we have to be very careful with screening the hearing. And
I think in most of the hospitals now OAE is there, and all children are getting this benefit.
Yeah, Kerala we have declared
hearing friendly.
Hearing friendly last year, and all the hospital delivery points we are doing the OAE, irrespective of whether it is government or private. And thanks to Dr. Abraham K. Paul. And language delay also, a child with a language delay, dysmorphism or chromosomal anomalies, we have to do the screening for to prevent hearing impairment.
So what about Dr. Nemathan? What about Tamil Nadu? Whether all children are getting OAE? They are all newborns, babies are benefited by OAE. Are they getting that? Dr. Nemathan, please, are you there? Okay.
We are yet to start all treatment, all newborn OAE, sir. But in private hospitals, we have started.
Okay, government hospitals is not there, so that's sad. Yeah. That in Kerala children are getting the benefit. Okay, next one. Next, please. Okay, then so
message.
The message is quite clear. Message is quite clear. No oral antibiotics in CSM unless it is toxic. No head bath for minimum 4 weeks. No saline nasal drops. No ear drops. Look for other airway issues and treat adenoids and other possibilities for eustachian tube block. Next one, please. So, friends, we discussed 3 cases. First one is ESBL producing E. coli, second one is CSBL producing salmonella, and the last one is not due to resistance, but actually due to the improper use of antibiotics and lack of vaccination. Now the question is to Dr. Shrija Sugunan, another case scenario. Very interesting. 12-year-old child, fever, nasal congestion, myalgia, June 2019, respiratory 30 per minute, saturation 92, CRT less than 2 seconds, vaccinated again here also with as per the national immunization schedule. Vital stable, pickle normal, CBC is leukopenia and thrombocytopenia, no thrombocytopenia, sorry. And dengue combo negative, but you know that oseltamivir was started because it is season, monsoon season, and also this thinking that is influenza. Oseltamivir was started empirically. Leukopenia, no thrombocytopenia, discordant is there. Then oseltamivir was started. Fever 102 degree, no acromegaly, no meningeal signs. System review within normal limits. Your thoughts?
So this is what we see here is a 12-year-old child, and what are the main things that we are seeing is that the child has respiratory symptoms, is hypoxic, but otherwise the vitals are stable. Along with that, he has some systemic symptoms like nasal congestion, myalgia. There is leukopenia without thrombocytopenia. So what are the possibilities that we are looking at? We are probably looking at a community-acquired pneumonia. It can be that they have started oseltamivir. Yes, a viral pneumonia is a possibility, taking into fact that he has nasal congestion and also hypoxia. So viral pneumonia is a possibility. A secondary bacterial infection, especially with a streptococcal pneumonia, is possibility. Then you can have a systemic infection.
Especially as child is not vaccinated, they can strep pneumo by.
So pneumococci is a possibility. Then you can also have a 12-year-old child. So definitely mycoplasma is also a possibility. And then finally, definitely do not rule out a systemic infection, like they have already ruled out dengue, but respiratory signs are quite common in lepto also. So that also should be there in the back of the mind, but lepto usually does not manifest with leukopenia. It usually presents with leukocytosis. So that could be an initial differential diagnosis when you're seeing this child at this point.
So any chance for staph infections if the patient is deteriorating, Dr. Shrija, if it's an influenza?
Staph infections after an influenza is a possibility, but right now when I'm seeing this child, I wouldn't really think of a staph infection. Okay. I would think of staph only if you have a toxic child, you have a skin or soft tissue infection, you have localized effusions. I would be more in favor of that. Otherwise, a 12-year-old child coming in this scenario, I wouldn't be really jumping into into a staph infection at this point.
So CRP for this child is 30, and in malarial parasite negative, lepto IgM negative, routine urine blood culture normal, chest X-ray showed interstitial pattern, suggestive of viral infections, maybe mycoplasma. And injection amoxiclav was started 90 per kg per day, but fever persisted. Amoxiclav changed to ceftriaxone 75 per kg day along with the azithromycin. And fever pattern same even after 4 days of ceftriaxone and azithromycin. And thinking that it's staph infection, so I started this child on cloxacillin 200 per kg per day, and along with amikacin 15 per kg per day. Your thoughts?
So now we have a child, we have initially started on amoxiclav, and then we have moved on to ceftriaxone. So already the amoxiclav was on quite high dose, 90 mg per kg per day. So usual penicillin resistance should have been handled by that. But still probably thinking of a resistance, we have moved on to ceftriaxone. Then adding azithromycin, definitely a 12-year-old child coming with an interstitial pneumonia, mycoplasma is a possibility, thinking that maybe probably azithro has been added. So till that, we are okay with the antibiotic selection at this point. But still, what is bothersome is after 4 days, the child is in fact deteriorating and not improving. And antibiotic clox with amikacin, as I already said, I wouldn't be very much in favor for a clox amikacin for this child, taking the whole clinical scenario into perspective.
But high fever is persisting. We cannot blame the physician because already started on amoxiclav, didn't respond, then he changed to ceftriaxone and then azithromycin, but still fever is persisting. Then he might have thought that staph is a strong possibility.
In fact, amoxiclav would have covered an MSSA. Ceftriaxone also would have covered an MSSA. If you're really looking at a staph, then we're probably looking at an MRSA, and then you would have gone for vancomycin in that state. But interstitial pneumonia without this thing.
Yeah, Dr. Shrija, if patient from community, MRSA is a possibility?
Yes, MRSA is a possibility. It's not that it is not a possibility, because in our hospital, we are getting around 15 to 20% cases of staph are MRSA. So definitely MRSA is a possibility, but thinking of the other round, 85% are MSSA. So I would like to give emphasis on the 85% MSSA.
Anyway, this child was on cloxacillin and amikacin, and then what happened? Let us see. Okay, and at this point of time, multiplex PCR for nasopharyngeal staph for common respiratory virus and atypical organisms, negative for influenza but positive for mycoplasma. The result came, and oseltamivir was stopped because it is mycoplasma pneumonia. X-ray not suggestive of staph pneumonia, as you said correctly. Irregular fever persisting, general condition, okay, improved, not worsened. General condition not worsened. Okay, and then my question is that what the patient is not improving irrespective of this change in the antibodies that you have made?
So mycoplasma definitely is a possibility. 12-year-old child presenting with pneumonia along with pneumococci, we definitely always will be thinking about mycoplasma. And regarding the choice of antibiotic for mycoplasma, there is a little bit of a problem there, because azithromycin resistance is being increasingly reported. In fact, many studies are now telling that azithromycin sensitivity if mycoplasma is less than 10%.
You have come across similar situations. You had a similar experience.
Yes, we had in fact multiple cases. In fact, there was a period last year in between, we were getting multiple children with mycoplasma.
So is it due to left and right use of azithromycin in the clinical practice?
Yeah, must be, because azithro is such a commonly used drug for almost everything, from URI to LRI to for otitis media, everything we seem to be giving.
Anything and everything, azithromycin. One reason is good compliance. Good
Yeah,
compliance.
because once daily, short duration, so
three
patients
days,
are happy.
Everybody is happy. Okay, then when will you suspect mycoplasma infection?
So classically, we are taught to think about mycoplasma when you're getting a school-going child and he has got an interstitial pneumonia, and the symptoms are less and the signs are more. That is, you say walking pneumonia. But I would say that it is not like that. The 3 X-rays that are shown, they're all proven mycoplasma PCR positive cases, subsequently antibody also positive. And as you can see here, they are presenting with lobar pneumonia. So mycoplasma pneumonia, we used to call it as an atypical pneumonia because it used to produce a more interstitial pattern. But nowadays, we are definitely coming across mycoplasma pneumonia, which are lobar, which has effusion, many times hemorrhagic effusions. And when you have systemic symptoms, definitely think of mycoplasma. If you have a thromboembolic complication, one of our child had a pulmonary thrombosis, another child had a peripheral thrombosis. Some patients have anemia along with it, DCT positive anemia. So when you have a systemic symptoms also, think about mycoplasma.
Shrija, of late people are telling that if a patient has COVID-19 and if they have mycoplasma infection, there is more chance for thrombosis and more chance for complication. Is it true?
COVID-19 as such is a prothrombotic condition, and mycoplasma also often precipitates a thrombosis. So whether both together are additive, we'll have to wait and see. It's a possibility, definitely.
My question is that, as you said correctly, why our patient didn't respond to azithromycin? Because we have started the antibiotic here along with, but patient didn't respond.
That must be the resistance to azithromycin, because resistance to azithromycin for mycoplasma is quite common. And what is really sensitive to mycoplasma now is mainly the quinolones, the ofloxacin, and doxycycline is also a good alternative.
The good news for you, levofloxacin started 10 per kg and the child became effervescent within 48 hours. Okay, so the message is quite clear. So you have to manage the approach pneumonia systematically based on age-wise bacteriological pattern as suggested by IAP. Resistant strep pneumonia is rare in our continent, but it is there. Especially if there is, you are suspecting a strep pneumonia, you have to cover antibiotic that can penetrate into the CS of maybe vancomycin. Be cautious. So best since resistance is 33% in against TMB SMX and 20-25% tetracycline and quinolones 2%. Strep pneumonia resistance is also a fact now, as said earlier. But MRSA is very common in hospitalized children, as said correctly by Dr. Shija. Adolescent mycoplasma is a possibility. You would consider mycoplasma when children are having infections. Widespread use of macrolides has resulted in resistance ranging from 50 to 95% against this mycoplasma. So in case of MRSA, the newer antibiotics are vancomycin, daptomycin, linezolid, tedizolid, delphoxacin, quinolone derivative is a quinolone derivative, omadacycline, ceftaroline, and ceftobiprole, and new one are dalbavanacin and oritavancin and televanacin. These are against MRSA. So now the question is to Dr. Neminathan. So this is a live case, 12-year-old boy from Balaseri, that's near Kozhikode. Immunized for age, had high fever, tachycardia, muffling of the heart sounds. Clinical diagnosis of myocarditis was made, and child was managed with the IVIG and other supportive measures. And child was referred from this periphery hospital to EMC Kozhikode. A general condition was not at all satisfactory. 2 days later, child had bloody stool. Initially, there was no bloody stool. Sibling of the child also had similar story, bloody stool. Other systems normally means vitals, tachycardia, BP 100/70, fever 104, respiratory 26, pickle non-contributory. There is alteration of sensorium, and GIT showed some dehydration. And CBC, leukocytosis, CRP is 200, troponin was elevated. Urine routine examination with the normal limits, blood culture, urine culture taken, motion culture sent, and injection ciprofloxacin was started, 20 milligram per kilogram body weight, and cardiac status improved. Your thoughts, Dr. Neminathan?
Yeah, this is a 12-year-old child coming from Kozhikode, an endemic area for lots of parental diseases, coming with a history of bloody stools, myocarditis, altered sensorium, with a similar illness in the sibling, with elevated total count. It will swing the pendulum towards entropathogens. Particularly, I will group them into 6 entropathogens. The topmost in the list, I will keep Shigella in mind, because Shigella is an organism wherein 2 persons in the same family having at the same time, because even a minimal of 10 organisms can infect both persons. And also Kozhikode, there was an outbreak of shigellosis, epidemic of shigellosis, probably recently. And also next organism will be, I'll keep it in the mind, is Salmonella, is a close mimic of Shigella. And the other 4 organisms are Campylobacter and enterotoxic E. coli. And of course, in the list, I'll have Clostridium and amoebiasis with a parvovirus in my mind. Parvovirus, it is less likely. And amoebiasis also, as per the ICMR study, the incidence in children is very less than 3%. And Clostridium difficile, usually it happens after a prolonged course of antibiotics, that's also ruled out. Campylobacter and enterotoxigenic E. coli in this situation could be a possibility, but keep them in the last in the list. So my view will be focus on Shigella and Salmonella.
So your priorities are Shigella, Salmonella, Yersinia enterocolitica, Campylobacter jejuni, and enterohemorrhagic E. coli. Is it like that?
Yeah.
Okay. So motion culture report came Shigella, Sonia, resistant quinolones. Antibiotics was changed to ceftriaxone.
Sorry, your time is up. Actually, it's
okay,
already
sir.
5:30. Yeah.
Oh, how many more minutes, sir?
Already you crossed 3 minutes. Sir.
Oh my God! Then I will stop with this case. Sorry.
Okay, okay, sir.
And then Doctor, antibiotics has changed ceftriaxone, general condition worsened, general child developed seizures and child succumbed. Sir,
Yes,
sir.
Sir.
Okay, so what
Yeah,
antibiotic would you like to suggest in this case? We have started on Cipro.
Yeah, probably this is a child with a lethal toxic encephalopathy or Ekiri syndrome. Probably this type of antibiotic resistance is very common. Particularly, it is antibiotic resistance in Shigella is multifactorial, innate, acquired, and adaptive. And nowadays, we see lots of children, particularly there is around resistance to ampicillin and other antibiotics to the tune of 70%. And ciprofloxacin, like salmonella, the resistance is nearly very high. So it is not wise to start ciprofloxacin as an empirical antibiotic even in Shigella.
So we had 2 cases of ciprofloxacin resistance. One initial case it was for salmonella, and now it's for Shigella, and Cipro is resistant. So you won't give any other drugs like this Lamotil or loperamide, and you may preserve, but you would like to start azithromycin. Which antibiotic you will start for this patient?
Yeah, preferably azithromycin, little higher dose. So that seems to be on the day 1, it's 12 milligram per kg weight, followed by azithromycin 6 milligram per kg weight for next 4 days.
So any other drug that you would like to start for this patient other than this?
Yeah, of course, cefixime at 8 milligram per kg weight per day, or nalgesic acid 55 milligram per kg per day in 4 divided doses.
Okay, nalgesic acid is similar to that of this ciprofloxacin. But do you want to start? Yeah. Then breastfeeding and hand washing. Okay, then 1 second. Okay, then high rate of resistance to Shigella. Fluoroquinolones 20 to 30% are resistant to Shigella. Azithro and SF. So all these antibiotics are resistant to Shigella. So antibiotic selection by antibiotical susceptibility testing. Options: fluoroquinolone, azithro, ceftriaxone, cefixime, TMP, etc. Okay, then so whether is there a time because we have one more case to be discussed that will take a little more time. That is a case of multi-drug resistant tuberculosis. Dr. Sudhakar.
Sir, sorry, already we are running late.
Okay, then let us.
It's a very big program, sir.
Okay, thank you so much, sir. I'll summarize and then okay, it's a big slide. Dr. Bala.
Oh, it's okay, sir.
Sorry that I couldn't take your case because
we'll keep at MDR tuberculosis a separate session another day. Sir.
Separate session. So we'll give you a chance to Dr. Bala.
Okay. Definitely we'll invite him for that.
Okay. Last one. Last slide. 1 second. Last one. Next one.
Sir, that case you.
Next, one second.
Yeah.
Yeah. Make it fast. Next one. So we're going to. Oh, yeah. This one. So, my dear friends, at the end, I would like to conclude this panel discussion with the statements that antibiotics are life-saving. Antibiotics are not antipyretics. Antibiotics has to preserve for future generation. And also, you have to prevent ESBL producing enterococcal species, prevent MDR, XDR salmonella, prevent MRSA resistant staph pneumonia, resistant mycoplasma, prevent Shigella, and prevent MDR, XDR TB. Next slide, please.
There are some questions in the chat.
I would like to thank IAP Tamil Nadu ID chapter and also my panelists, Dr. Neminathan, Dr. Balajendra, and Dr. Shrija Sugunan. So they were very kind to me in cooperating. Their answers were fantastic. And any questions? And finally, Dr. Narmada also, and also all the organizers of this meeting.
So there are some questions, but most of them I think Bala and Shrija madam had answered. One thing is like a 3-month-old infant, the urine culture has shown E. coli twice, and which is ESBL and carbapenem resistant and sensitive to colistin and nitrofurantoin. The child is having no pus cells. Would you treat this child, and if so, with what antibiotics?
Dr. Shrija, what's your answer? Dr. Shrija,
okay.
Can you
hear? I could hear. That's a very interesting question and very relevant too. You have a small baby, 3-month-old, who does not have pyuria. So that is a problem here because you are getting a culture which is showing ESBL, and that too, so you are the sensitivity given is a higher antibiotic. So your decision whether to treat or not depends on whether you think it is a UTI or not. So how do we decide that? So for whenever we get a culture positivity, a urine microscopy should reveal either pyuria or bacteriuria. So earlier teaching was without pyuria, bacteria doesn't make sense, but now it is either pyuria or bacteria. The urine microscopy, you should get either pus cells there or you should get bacteria or both, either way. So if one of those is positive, then the culture definitely has significance, even in the absence of pus cells. And culture has significance if the child is symptomatic. So that is also important. The child was admitted with fever and vomiting, and by the time you get the culture and the child is okay, there is no need for you to go for the higher antibiotic, because always in vivo presentation is more important than in vitro sensitivity.
So go for SP urine. There is no doubt about this contamination.
It's a small child, sir. That is
yes,
a 4-year-old
small child or big child. You can safely do this SP urine.
Yeah,
We used
small
to do
child,
SP urine left and right with and we will get even if one puzzle is present, even if the colony count is less than 100,000, you're quite sure that's UTI if it is suprapubic aspiration of the urine.
That is what Rangavel sir has commented, sir. And I'm very, CMC does only suprapubic aspirate every time. So there is one more question of pan-sensitive salmonella typhi. Also, the child goes for complication and death. So how do you explain it? Pan-sensitive.
Yeah, that's a good question. Sometimes in the sensitivity pattern, you have all antibiotic sensitive. But in practice, none of the antibiotics are working. The patient continues to have fever. That's because most of the time in vitro, the antibiotics will be sensitive and they may not be available in vivo. That's the most problem. Another important thing is you have to ask your lab person to include p-floxin disc in the antibiotic antibiogram. So if you include a p-floxin disc, if it gives a sensitivity pattern, you can use in such situations, you can use quinolones. Particularly, you can use the higher quinolones. Most of the time, they will be sensitive. There was a question about DEXA in typhoid.
Yes, sir. Higher dose.
Yeah.
What is the question?
Yeah.
What is the question?
All
antibiotics are sensitive, but still child had complications.
Yes,
sir.
Like
yeah, not responding.
So you have to investigate the patient, see whether the child is having a focus. So the same thing happened in our case, that child was responding, but they have started antibiotics, but with respect to that child was fever was there, and when taken MRI that showed osteomyelitis. That we won't pick up usually. So you have to investigate this patient, you have to investigate the patient detail if they are running fever. So now we have facilities. It was not SREs when they don't have any facility. Now we can investigate the patient and see whether the child is any focus present or not.
Yeah. Regarding the DEXA, if the patient is in shock in a typhoid fever, if there is a delirium, obdentation, stupor, and coma, first we need to rule out a bacterial meningitis by doing a CSF analysis. Bacterial meningitis is not there. You are advised to start dexamethasone at the dose of 3 mg per kg IV given over 30 minutes, followed by 1 mg per kg given every 6 hours for a total of 8 doses. The fatality in the DEXA arm is around 10%, whereas in the non-DEXA arm is nearly 55%. So you can reduce the mortality by using DEXA.
Okay, I think we'll stop it with here. So there are still certain questions. Dr. Bala has answered almost all his questions in the chat box. So if there is any question left, I would really request the panelists to answer. Thank you so much for that.
Sir, regarding I want to put one point. Actually, this is nothing to do with the discussion, but to make a clarity in the public that there about the OAE and BARA. In Tamil Nadu, there is 32 centers are doing OAE and BARA. Monthly, more than 12,000 newborn babies are being screened for OAE every month. And there are a lot of cochlear transplantation just for the sharing the information for the public.
In government hospitals or in private
in
hospitals?
Government hospital through the district early intervention, there are 32 district early intervention centers.
I heard that Tamil Nadu government is giving pneumococcal vaccination free of cost.
Yes, pneumococcal vaccine less than 2 kg. All the newborn babies are getting pneumococcal.
In Kerala, it is not there. In Kerala, it's not there. So that's
yes,
very,
really monthly, that's why I want to convey the message that monthly 12,000 to 15,000 newborn babies are being screened for OAE as well as BARA if needed.
That's good. That's fantastic.
Yeah, we are also in the march to along with.
Oh, surely.
Thank you. Thank you.
Thank you so much.
Sir. I think we'll stop with the session and
thank you, Dr. Narmada, Dr.
Thank you,
Shija, Dr. Bala.
Yeah,
thank you.
We will let us start with this. Yeah, thank you all the panelists and faculty moderators, sir. Thank you all. Next, due to some administrative reason, I am inviting Dr. Narmada North Arcot IAP President, South Zone EB member for Central IAP ID chapter, and she's holding a lot of posts, and she's being a module preparator for many model at national level. So without wasting time, I invite her to talk about the infection control measures, me and my health system, what infection control measures can be done even in a small clinic setup. Welcome, Dr. Naraj.
Thank you so much, Dr. Sudhakar. So I will just share my slide. Just give me a minute. So can you see my slides?
We are able to see it.
Yeah, okay, thank you. So this was infection control measures, me and my healthcare system. Usually when we are actually thinking about infection control measures, we usually think about bigger hospitals. And so much has been talked about antibiotic, correct usage of antibiotics and rational management of antibiotics. So it is only ideal that it is very necessary that our infection control measures starts from our clinic itself. So the outline of my talk will be on the need for the topic. What are the difficulties in infection control in small healthcare units like ours? What does the rules say? And what is the difficulties in implementation in our system? The role of healthcare workers and the economic impact. Now, the need for the topic is National Sample Survey Organization says that the private healthcare providers have increased exponentially over the past 20 years. About 10.4 lakh enterprises are there, which is more than 64% is occupied by our clinics, smaller and mid-care hospitals. So we are not talking here about institutions. We are not talking here about corporate sectors. We are talking about clinics and small and medium healthcare units, which means both the healthcare associated infections as well as antibiotic rational management, unless until it starts from our units, it is not going to make an impact in the nation. Totally, we have around 21 lakh healthcare workers, which makes about 5% of the population who are in the service industry and who are going to be affected with these infections. So that is the reason it is very important that we talk about healthcare associated infections in smaller concern. Healthcare associated infections previously was referred as nosocomial or hospital-acquired infection, and it occurs in a patient during the process of admitting themselves in the hospital, and it was not present at the time of admission. And it also includes an occupational infection among healthcare workers. COVID is also an occupational infection which we got, and we lost many of the doctors here. It also includes infection acquired within 30 days of hospitalization, as some infections may manifest later. So WHO has estimated that about 7 to 12% of patients are acquiring the infection at any point of time. That is 1.4 million people are getting affected. This rate is very higher in India, with a multi-center trial showing 14.7% of infection associated infection, 8.7% infection. See, the problem is we are this is maybe about for higher establishments. The center trial came only from the higher establishment. But let us note that we are having 2 to 3 bedded ICUs. We are having surgical units that is handling surgery. So it is not reflecting, it is not only saying about the higher centers, it is also reflecting our smaller healthcare units, which also cater to the same population. The global pandemics, Corona and Nipah virus, really showed how healthcare workers could be affected with this healthcare infection. The Crimean Congo hemorrhagic fever, the first toll was from a doctor and nurse who had cared for the index patient. So it is very, very essential for us to know about the hospital-acquired infection. So the menace of multi-drug resistance is also one of the reasons contributing to healthcare-associated infection, as well as is one of the causes of it also starts with multi-drug resistance organism. With India being one of the highest consumer of antibiotics, they're almost consuming 10 units per person, and there is a high possibility that we might be the reason for multi-drug resistant organism. Pakistan has already had pan-resistant typhoid, so we are not far behind. And with the smaller establishments, as I told you, 64% of us are catering to this population, and we are the largest healthcare system. So it is very imperative that we start the infection control in our healthcare unit. The main reason why the difficulties in small healthcare in unit is the economic impact of it. When you think that when you are going to start a prevention of healthcare associated infection control in our smaller units, it involves cost. All of us know that because of the corona, when we started getting this PPEs, this mask and everything, the economic impact of us, it almost took about 25% of our revenue, which makes it is not immediate, it is not acceptable for any of the administrators of a small healthcare unit where they don't have a large amount of profitability here. And here, one more thing is the advantages of having a HAE, preventing a HAE is not tangible immediately. It needs meticulous documentation. So you need to really see how much amount of infections you have prevented. And goodwill and social benefits are very difficult to quantify. You don't get it. You really wait for 10 whole years or 15 whole years for your hospital to get a good name. And that is not really tangible immediately. And now with the youngsters, we are looking at immediate results. So it's not going to be coming up immediately. And there is no lack of direct incentives to the physicians and staffs. Now, even my staff, when I told them to wear, though we provided PPE, we provided the disposables, the staffs were not willing to take it up. They had a lot of issues with wearing a mask because they did not see the direct incentive of wearing all these preventive measures or contributing into the prevention of healthcare associated infection. And of course, there is a lack of political will. Only 15.6% of developing nations have a national surveillance system, and the small healthcare units, it is very, very difficult to monitor them. So these are the reasons why it is very difficult to implement all these policies in smaller healthcare unit. What does the rule say? We have two rules as of now, which binds these small healthcare units. One is the NABH. Now, it has not been made mandatory, but with the insurance companies claiming that all of us have to be NABH standardized, then smaller units like us are thinking about that. The Clinical Establishment Act of 2018 had not made any specific recommendation, except for the biomedical waste management, except for an agreement with them. We really are not having any act that binds this smaller healthcare. But of course, NABH says it is documented that one of the standards is the organization should have a very well-designed, comprehensive and coordinated infection prevention and control program, and it should implement it. It should have surveillance activity to capture and monitor and also to prevent and control. And it says that it has to have adequate and appropriate resources. By this word, appropriate resources, they have clearly mentioned that even if your unit is going to be small, you could still have a smaller unit. For example, in my infection control committee is just myself, another one of the staff nurses. It involves a laundry worker as well as a maintenance persons. So even a 4 members, it is not necessary for us to institute in a bigger unit. You can institute even in a smaller units. Appropriate actions has to take when you find an outbreak of infections, you need to prevent it. Documented policies and procedures for sterilization, stick it up, make it aware for all the staffs to know about it. Biomedical waste is handled in an appropriate and safe manner, and it also involves appropriate training of the employees as and when possible. So to an extent, hospital-acquired infections can be controlled because if we take up the choice of implementing NABH in our hospital, and due to the indirect pressures of the insurance companies acting for it, now we, the small healthcare unit, need to apply this. And how do I implement in my healthcare setup? It's caused by a variety of resistance and unusual organisms like E. coli, enterococcus. And we also need to make our patients as well as our staff aware. It is transmitted by inanimate objects, airborne routes, droplets. Thanks to Corona, it has brought some sense of an awareness in all of us. And the host factors also we have to take into consideration, give more care for the extremes of age. For example, the pediatric age groups as well as the older age with disturbed immune status, given importance to the comorbidities, their immunization status. These sort of children and these sort of older people, will give more, probably have a separate entry for them, probably do adequate screening so that the sick children are taken care separately and the people who come for vaccination are taken care separately. This sort of immunosuppressed adults are seen in a separate OPD. Some sort of a provision can be made here. Now, the other thing is hand hygiene, the use of personal protective equipment. One of the important factor in we do tell about hand hygiene, but the important factor in hand hygiene is to have wash basins in the OPD setup itself, where and when possible. Right from entering the institution, the hand hygiene has to be there. Use of personal protective equipments for all personnel, including the reception staff. We usually think about the nursing staff, but we forget about the reception staff. So we have to think about using the personal protective equipment. We need to follow aseptic things, include while giving the venflons, while putting the venflons, while doing the vaccination, by even if your institute follows IM injections for adults, they have to follow that disinfectant practice. Respiratory hygiene and cough etiquette, adequately given awareness during the COVID times, appropriate disposal of medical waste, as well as improving safety in operating rooms and critical areas a must. And we also have to maintain a safe working environment and safe work practices. And this is only possible by constant education. So for establishing such practices, the healthcare unit, as we said already, should have an establishment of prevention and infection prevention and control program. And we should also have the infection control committee, which can be modified according to the size. An antibiotic policy and stewardship, which is acceptable for the unit, has to be there. Right from the emergency area, right from the triage area till the higher operation theaters, everybody should follow the antibiotic policy. And you can take the help of the nearby institutes. Like, for example, we follow what CMC follows. They release the antibiotic policies every year. So we take that policy and we put it as the initial drug of choice for our unit. So that even when you're going to transfer to because you know where you're going to transfer, so the continuation of care will be available. So these three are mandatory. So then coming to the OPD setup, is it necessary for me to implement in my OPD setup? Yes, of course. All these factors can also come into the OPD setup, and you can be affected by this. Most of the time when coronavirus came, it was the private practitioners who were affected first. And in that condition, we need to be careful that our staff is also not affected. So how do we do that? We should have the ventilatory settings quite. We say a very closed OPD. We have to get away from that. The openings have to be more than 20% of our flow area and should be on the opposite side. Like it can be full of glasses and windows. You can use a fan or an AC or a mixed mode ventilation where you make sure that air condition is adequately changed and the air spaces air changes per hour is up to 6 to 12. The ideal seating arrangements will be nurse sitting at the side of the window where she's on the doctor sitting at the side of the window and the exhaust is behind us so that we get clean air as well as whatever the contaminated air is there, it goes away and the patient should be near the exhaust. The environmental cleaning, we have to do the routine wet mopping with natural detergent using high-tech surface, 0.5% hypochlorite solution. And this has to be in a routine practice of 2 to 3 hours. The toilet should be cleaned properly and we should have a monitoring system for that. And hand hygiene and PPE should be strictly followed. And the reusable devices can be sterilized with 70% of alcohol. This is, I'm just mentioning about OPD setup. So suppose you have a minor OT setup there, you have an X-ray unit there, you have a lab equipment there. There are certain regulations given which you have to follow in all your in every unit of, and it will keep changing depending on in intensive care it will require a different amount of intensive monitoring. In operation theaters it will be different, and in general wards it will be different. So we need to know what is the appropriate cleaning measures we have to use in each of the unit. And this is introducing the concept of a care bundle where the key intervention and guidelines can be implemented together. This will reduce the significant cost of implementing to reduce the hospital-acquired infection. So commonest health, one of the examples I will take is like IV-related bloodstream, which is more, we might not be thinking about ventilator-associated pneumonia, we might not be taking care of them or a central line associated, but we pediatricians do put the lines every time. So what we can do is a small thing as usage of polytetrafluoroethylene or polyurethane catheters can be used. The training of the staff is very, very important. In fact, what happens is in my unit, whenever I ask for a venflon, the venflon comes separately, the cotton is brought separately, the sterilium is bought separately, and they are all kept it on the bed of the patient. So the nurses does not take care to bring all that in a tray and then follow proper aseptic precautions. So this has to be educated to them. I can choose the appropriate site of insertion and aseptic precaution. Alcohol should be along with the tray. And when we are using a central lines, antimicrobial prophylaxis can be followed and close pressure monitoring system. These are certain smaller things which I can introduce into my unit so that the healthcare associated infection comes down. Now, for this, what do I do is I can incorporate quality control policies into the system. So this one, quality control, whenever we talk about quality control improvement or point of care quality control, it is what comes to our mind is always the higher institution. But this is for smaller institutions like us also. Like we have to identify the problem, form the aim statement, analyze and measure what is the quality of care at present we are giving, develop and testing the changes. You put a change and then you see how it is working. There is a PDSA cycle. So for example, the problem is my sister does not bring the tray properly, aseptic precautions are not taken. Then I can manage, I can bring the team together. I can see who's most influential in the team, find out the steps which I'm doing, what are the resources at present I'm having. Then form an aim statement wherein I see what is the thing I'm looking at. Like every Venflon is put with the proper aseptic precautions or not. That might be that is a very small achievable aim which I can take up. I can discuss with my unit, form a statement, see what are the modifications I can do, and then I can document. And let me be practical, like 20% of the patients were only getting an aseptic care. With the problem identification, educating my staff and putting in the proper practices, this could be increased to about 50 to 60%. Slowly in this way, I can find out all the problems in my healthcare unit where the healthcare associated infections are on the high, where my staff is not getting prevented from healthcare associated infection. And then I can use my own team members and slowly I can bring in the change. So point of care quality control improvement is very, very important for smaller healthcare setup also. It is not for bigger institutions alone. And this is a very detailed workshop and the details of it is available. AIMS has got a very big protocol for it, very easy to follow, and it will be useful for people like us. Now, so as I said, healthcare workers forms the crux of the entire system. So they are the reason for propagating antibiotic resistance or healthcare associated infection, and also they get affected by the same. So studies reveal that the nurses have a considerable opportunities because they spend a lot of time with the patients than us. So their knowledge is more influential in preventing the healthcare associated infection. And we have seen that in a study has shown only 32% of the nurses are even aware of a barrier nursing in smaller units like us. And fatigue and stress, like they're having a 12-hour duty system or a 16 hours, it really doesn't work. So here is where the infection control committee, identifying the problem, making smaller changes can help us in order to reduce the infection. So the economic impact of infection control, there is a lot of trade-offs and sacrifices between implementation. Now you need to consider that in the long term, your goodwill is going to stand and it is going to help us thrive in this competitive world, even though the corporates are going to be there. The less work has been done in the smaller units in comparing prevention and treatment. Our cost accounting system, like whenever we go to the auditor, when we fix on our rates, it is very important that we take the direct and indirect cost which is involved in that. And if you know that this healthcare associated infection prevention takes about 32% of the health budget, and we contributing 64% of this entire system, we can greatly reduce this public system cost. So the way forward is application of patient safety initiatives is our priority. We have to have an education to reduce healthcare associated infections. Intervention should target at to reducing this. We have to apply national safety standard to reduce the expenses. Growing awareness about healthcare. There is a person who enters, even if he comes for a smaller clinic, he's looking at how neat we have kept. He's having a growing awareness of it, and like a hotel, he's going to rate us on the Google. So let us be aware of it and let us make the change from our unit rather than waiting for somebody to come and see. And again, we would say that in the long run, cost is very, very beneficial. It is not a very big thing to do. Only a bigger institutions can do. We can do it in our own potential space itself. We are also prone to get this. Measures are available to reduce the HAE and depending on the area catered. And though it is not palpable, long term it is very beneficial. Please take care of your staffs. Care bundle approach can minimize the cost and it is effective. Point of care quality control measures needed, and it is very easily implementable in units like us. Preventive HAE improves the long-term trust and builds the goodwill. I thank you, and thank you for the organizers for taking this. We thought we would take this different topic because we feel smaller institutions need not do anything about healthcare associated infections. We felt it is imperative that smaller unit starts, then the HAE will come down to a bigger concept, as well as antibiotic stewardship program should also start only from our units. Thank you. Sudhakar, is there any questions? Hello, Dr. Sudhakar? Painiraman sir, I was audible, right? I can see only you in the video.
Yes, yes, audible, audible.
Okay, because I'm not seeing it. Was there any questions also? I did not know. So,
Actually, in the chat box, no question.
yes, sir. Okay. I think there are no questions. Any comments from Sir Paniraman sir, because you are having a smaller healthcare unit, and Tangvel sir also can help us.
The comment is only thing is you can still concise and put as a 1, 2, 3, 4 steps for the small clinics so that it will be next day we can apply it. That is the only comment.
Probably I was trying to do that only with the quality control. That is why I introduced the Venflon concept.
Okay. Okay. Thank you.
Narmada? Narmada?
Yes, sir.
It was an excellent presentation, Narmada. I think only comment I can make is that when you are a healthcare person, you have to go by the rules, whether it is small or a clinic or a small hospital or a big hospital. If you are a healthcare person, you have to go by the rules. So everybody, it's imperative duty of all the doctors, irrespective of the size, it is the mind that determines. So everybody has to follow this one. It was a wonderful talk.
Thank you, sir. Thank you. But I think why I touched on this economic impact and the quality control is to make aware of our people that it is still economically viable. It is still possible for our units like this. Though the rules say it's still viable for us. That is what I was trying to insist
That's
on.
Right. It was a good talk. Thank you.
Thank you, sir. So shall we go ahead with the next presentation? I'm very happy to introduce Dr. Winsley Rose, sir, the infection control professor of, can I have the slide? Dr. Murugan, sir. Yeah. Dr. Winsley Rose, Professor, Department of Pediatrics, Christian Medical College, Vellore, and they have done a lot of work on the infection control, as well as from the morning, whatever the lectures we have been listening are the studies that has done from CMC Vellore, and he's from February 2016 till date. He is a Professor, Department of Pediatrics at Christian Medical College. He has numerous publications to his credit. Now I invite him to come and take over and introduce his esteemed panel, which had accepted in spite of their busy schedule to come and deliver this panel discussion. Thank you, sir. Winsley Rose, sir.
Yeah, thank you, Dr. Narmada.
Thank you, sir.
Am I
audible,
visible?
Yes, sir, audible and visible, sir.
Okay. So, just before I start, can you just tell me how much time we have? Because I think we are running about 25 minutes late.
Yes, sir. We have about 45 minutes and 5 minutes to take up the questions, sir.
Okay. Thank you. For today's session, I mean, we have three panelists who will actually join me in discussing infections in unusual sites. Shall I just start sharing my screen?
Yes, sir. Yes, sir.
Okay. So we have Dr. Palani Raman, who is actually a practicing pediatrician, and he's quite a popular person in many panel discussions in the ID chapter of Tamil Nadu state. And so he's a practicing pediatrician from Dindivanam. And we also have Dr. Valsan Verghese, who is actually a pediatric ID specialist, and he is the head of our pediatric ID department at CMC Vellore. And we have Dr. Anila Chako, who's also a pediatric ID specialist. I mean, both of them have trained in Canada in pediatric infectious disease. And Dr. Anila is an associate professor at CMC Vellore. So what we're going to do today is to look at this was the topic given to me, which was infections in unusual sites. So I've sort of chosen some few cases which highlight that this topic, and for the sake of this panel discussion, what I'm going to do is to first put up the cases itself, and then I would ask the panelists for their opinion, and we will go on from there. So not all the cases are fully not all the panelists know all the cases fully well. So they will be giving some of their own input to all these cases. So can I ask Anila also to join? I mean, I know she's on the panel. If she can also switch on her video.
And I'll just ask her to.
It's on. I'm here. Can you see me?
Okay, great. Okay, thank you, Anila. So we'll start off with the first case. The first is it's a 1-year-old boy who presented with a fever of about 18 days and neck swelling for about 7 days. He also presented with 2 days of noisy breathing. And this is the child. You can make out that there is some sort of a swelling at the side of the neck. Can I ask Dr. Walson, what would you consider in this child? What will be your differential diagnosis, and how do you think you'll approach this child? So the child is a 1-year-old with fever for a prolonged duration and the shorter duration of neck swelling and noisy breathing, and has the swelling by the side of his neck.
So actually the differential fever for 18 days, first question I would ask, has the child received any antibiotics? The second thing is the swelling, whether it has been progressively increasing. And then what worries me is the noisy breathing. So normally if you had fever, cough, and noisy breathing, you would think of laryngotracheobronchitis, but then you have a neck swelling. So you would think of pharyngitis, you would only have drooling, you should not have noisy breathing. A paropharyngeal abscess could have noisy breathing. And in that picture, you can't really make out whether there's any parotid swelling. But, the earlobe doesn't appear raised. So whether there is something within the throat. The other question I will ask the mother is the child drinking? Is the child drooling? Is there any difficulty swallowing? So, and if this so my differentials, I would think of any abscess within the oral or cavity, or and then the other thing is, of course, whether there is, because of the swelling, whether there are any lymph node enlargements.
Okay, so I think that's fair enough. I think we need to actually consider next phase infections because of the swelling and this and the prolonged fever as well. So what investigation would you like to do next?
Normally, if I thought of a pharyngitis, I would look at the throat. But this noisy breathing is actually worrying me, because noisy breathing and stridor, the classic teaching was, if you have an acute epiglottitis, you don't look at the throat unless you are ready to intubate. So, if I find that the node is not enlarged, there's just noisy breathing and a diffuse swelling, I would actually, if I'm thinking of a, retro or a parapharyngeal abscess, I would think of doing an X-ray, lateral X-ray of the neck.
Okay. And would you consider diphtheria in this case? Because that seems to have a resurgence over the past few, years. So is that something that should be considered as well?
I think so. Definitely, especially if you're looking at the throat and I find a membrane, then diphtheria would be high on the list of possibilities.
Yeah, I think the issue with the stridor, I think that's a worrying sign. The only thing is, acute epiglottitis, it's a very short illness, and they don't usually become they don't go on with fever for a prolonged period of time and then develop stridor. Acute epiglottitis, they are sick very fast, and also with the hip vaccination, hopefully that's not the issue. So these are some of the investigations that have been done. So the hemoglobin was 9.8 grams per deciliter. Total count was 19,200, showing that there is some evidence of a bacterial infection. Differential count showed 60% neutrophils and 30% lymphocytes. The platelet count was elevated, which probably could be due to iron deficiency, or it could be due to the inflammation itself. So there was an lateral X-ray of the neck taken. Dr. Palaniraman, can I ask you to comment on this X-ray, and what do you think about this X-ray, and why would you, if it's abnormal, why would you consider it as abnormal?
having the history known and the clinical examination findings known, I was expecting a retropharyngeal abscess in the X-ray neck in the lateral view. So as you see, you can see the loss of the lordosis in the cervical spine. The child is actually straightened cervical spine because of the muscle spasm, number one. Number two, the retropharyngeal space is widened. And this space is around more than, actually normally the space should not be more than the breadth of the vertebra, a cervical vertebra. Here it is more than twice or thrice the breadth of the vertebra. That shows that actually there is something going on in the retropharyngeal space. So these are the two things commonly we will be able to find it out. Mostly we will be able to do, we are dealing with a case of retropharyngeal abscess or retropharyngeal cell rate.
Yeah, so as Dr. Palniraman rightly mentioned, I mean, so this is a child with a retropharyngeal abscess, and the things to note are the loss of lordosis as well as the retropharyngeal space being wider. That is, anything beyond the size of the vertebral body, that will be actually considered as significantly enlarged. And in this case, I mean, it's much more than the width of one body. So, Dr. Anila, can I ask you, in this child, how would you approach treatment? Okay, I'm not sure whether Anila might have got disconnected, I think.
She is coming now. She is coming.
Okay.
Yeah, she is there.
Hi. Sorry, I just got disconnected.
Yeah. Anila, can you, I mean, so we were just discussing this retropharyngeal space being widened. So, I mean, what empiric antibiotic would you choose, and why would you choose such antibiotics?
So, I mean, when the space is widened, definitely, it points towards a retropharyngeal abscess. So, the organisms which cause retropharyngeal abscesses, one is group A strep, and the second is the anaerobes which are there in the mouth, the oropharynx. And then Staph aureus can sometimes come there. So these are the common organisms which I would like to cover. And so when you think of something which has anaerobic cover and cover for group A strep, then something like, either clindamycin with ceftriaxone, or even augmentin, amoxiclavir high dose. But having, if I was giving something without an MRSA cover, I'd probably add vancomycin. So those are the antibiotics I would use, and that's why.
So this child was actually treated with ceftriaxone and clindamycin, and there was no drainage which was done, and the child got better after that. So like Dr. Anila mentioned, I think it's important to consider that all these retropharyngeal abscesses, the main organisms which cause retropharyngeal abscesses are the oral commensals, oral commensals, and of course the pathogenic organisms being group A streptococcus, Staph aureus, and oral anaerobic mycobacteria, especially Fusobacterium, Prevotella, Veillonella. So all of them will be covered by clindamycin. And ceftriaxone, of course, I mean, if you have, it will have some amount of MSSA cover as well as group A strep cover. So I think this is a reasonable choice, and co-amoxiclav would have been okay as well, but with the caveat that it will not cover MRSA. I just want to ask Dr. Palniraman, I mean, did you consider incision and drainage at all?
Actually, as a practicing pediatrician, after diagnosis, I referred the case. Then I followed the case. What happened in the institution? The higher institution, they gave the IV antibiotics, ceftriaxone and clindamycin for a period of a week, and they decided about the surgery, particularly for the thing. But when they went to the theater and they found it was actually subsiding, and they finally came out of the theater, and the baby responded only with the oral antibiotic, settled with the antibiotic itself.
Okay, so. Okay, I think that's a good point, because not all retropharyngeal abscesses require surgery, and this is a suggested algorithm which you may use to actually treat retropharyngeal abscesses, because it could just be a phlegmon. I mean, phlegmon you cannot anyway drain because it's just like a solid inflammation. So if there is a phlegmon, then I think a trial of empiric antibiotic would be good. And if there is no improvement, then a CT chest would be required. And if there is an abscess, and if the abscess is more than 2.5 centimeters in size, that would require surgical drainage. And if not, it can continue the antibiotic. So it is likely that this was just a phlegmon which got improved with the antibiotic. So indications for surgery would be airway compromise. I mean, I understand the stridor in this case was a thing to worry about. And like Dr. Palniraman did rightly, I think he referred the child to a place where there was facility for all of that. And if you have the size of the lesion more than 2.5 centimeter cube, and it's well formed and into an abscess, that's a reason for drainage. And if there is failure of IV antibiotics also, that's an indication for drainage. So the differentials, I mean, Dr. Walson had mentioned, so anything that causes upper airway obstruction, sore throat, or neck stiffness can actually be a differential for retropharyngeal abscesses. It could be epiglottitis, croup, bacterial tracheitis, peritonsillar abscesses, laryngopharyngeal diphtheria, which is coming back in a big way. So that's something to worry about. Trauma, even anaphylaxis causing angioedema, and or tumors also can be in the differential.
Winsley, can I add one point? Can I
yes,
add one
sir.
point? Because in the last 1 year, I had met with around 3 cases of retropharyngeal abscess. One was this case, and another case, what happened, it was just a febrile, irritable child, little around 4 to 5 years of child with only the node in the lateral aspect. Because of the CBC showed neutrophilic leukocytosis with thrombocytosis, thought of as a Kawasaki and referred, and finally turned out to be a retropharyngeal abscess. Sometimes before going for the non-infectious causes, always try to rule out such a cases are like retropharyngeal abscess. Another case like had only a noisy breathing, just a subtle noisy breathing for a period of 15 days with on and off fever, and finally turned out to be a retropharyngeal abscess. So retropharyngeal abscess is not so uncommon. You should always have in mind whenever you have a noisy breathing with fever or high fever with neck nodes, or this is the situation we should have in mind. That is the message I want to say.
And also in this child, the fever of 80 days makes me a bit concerned about workup for tuberculosis, because tuberculosis also can actually present with, especially those with involvement of the cervical spine, can present with retropharyngeal abscesses. But in this case, looks like it was just a bacterial infection. So the next case, we will move on to the next case, which is a 3-year-old child who presents with fever for 3 days and neck swelling for 2 days. And this child also had drooling for 2 days. And this was the picture of the child. You can make out that there is like a significant amount of swelling in the submandibular as well as the submental regions. And the baby seems to have some difficulty in opening its mouth as well. So, Walson, can I, so what would be the differentials and how can these different?
Sorry, what is the question again?
Differentials of the such neck swelling, submental, submandibular swelling.
Questions, differentials, yeah, submental, yeah.
So this, actually submental or submandibular lymphadenopathy, parotitis, secondary, bacterial parotitis, but because it is diffuse and bilateral and associated with fever, first diagnosis would actually be a Ludwig's angina. So a differentiation would actually rest on whether there is lymphadenopathy or no lymphadenopathy, and sometimes it's difficult to make out when you look at it clinically. So sometimes an ultrasound or something will actually help. But bilateral, I would actually go for Ludwig's angina as my first diagnosis.
Dr. Palniraman, I mean, you treated this child. So yes. What did you treat with, and can you tell us why you chose that antibiotic?
Here, actually, the oral dental infection is the commonest cause for such a Ludwig angina. What happened in this child? The child was not toxic or sick enough. So I took a chance that I will start with the oral amoxiclav, which covers both the oral streptococcus, staphylococcus, as well as with the anaerobes, and with a high dose of oral amoxiclav, and with the frequent follow-up in the every day, every 24 hours. And finally, after nearly 48 to 72 hours, the child started settling, with the swelling started subsiding, and finally recovered without any other incision and drainage. The child settled with oral amoxiclav itself. But I was really worried whether the child goes for any respiratory compromise or anything. But as the child was not sick, I was able to manage as an outpatient in office practice itself. Winsley, I think Winsley is
yeah, so this thing that Ludwig's angina doesn't support incision drainage. Am I not audible? Hello.
Now you are audible. Now you are audible.
Am I audible now?
Yeah.
Yes.
Okay. So, I mean, I just want to reiterate that Ludwig's angina is usually doesn't suppurate, and usually you do not require an incision and drainage, and often it just settles down with antibiotics. And like you rightly said, again, it's a next phase infection, and the important organisms, space infections as the anaerobes. And am I still audible?
You are intermittently audible. Your voice is breaking.
Okay, let me connect. Okay, just give me a second. I'll just see if I can, if it makes it any better.
Wilson sir.
Yeah.
In a lighter note, how common is Vincent's angina in pediatrics? Because like Ludwig angina, how common is Vincent's angina in practice? Because that is also a
Vincent's is, I agree. So Vincent's is somehow less common. Both Vincent's and Ludwig's are associated with dental infections, like you rightly said, and you can actually have a gingival stomatitis. So if you have only caries, to be very frank, compared to retropharyngeal, all of these are uncommon, I would say, but Ludwig's is more common than Vincent's, and I would still say both are uncommon. I actually want to point out that point you made, Dr. Palniraman, about seeing so many cases which you had retropharyngeal abscesses which were not being suspected. The point I actually wanted to make is, it's quite, retropharyngeal abscess is commoner in children under 5 years of age, because they have a lot of nodes in the retropharyngeal and parapharyngeal spaces which involute after 5, like how the adenoids involute. Whereas Vincent's you can, and Ludwig's, you can have even after the age of 5. But I would still say Vincent's is even more uncommon,
Okay,
so,
thank you.
Yeah. It's interesting because they are all the same organism.
Winsley, unmute. Winsley, unmute. Winsley, unmute. Winsley, unmute.
Yeah, okay, yeah. So thank you, Dr. Wilson. I think those are very important points that you made. So I think next phase infections are actually, we should consider them to be one of the one of a serious concern, because they can cause serious infections. And these 3 spaces, especially the submandibular space, the parapharyngeal space, and the retropharyngeal space. So these are potential spaces. These are all areas where there are loose areolar tissue, which is actually get infected easily from the oral organisms. So moving on, this is a case of a 3-year-old boy who has a history of axillary swelling since 6 years of age. He was treated as BCG adenitis after a biopsy at around 1 year of age. He had no improvement, and he continued to, and the infection continued to spread to the supraclavicular as well as the pectoral regions. So this is a picture of his lesions. You can make out that there is this BCG scar, which is also sort of slightly VP. There are these lesions on the deltoid region, over the pectoral region, and over the neck as well. And you can see the biopsy scar at the left axilla. So my question to Dr. Palaniraman, so when would you worry about BCG adenitis? I mean, I'm sure BCG adenitis is something that you see in your practice fairly frequently. And when would you worry about BCG adenitis, and how would you treat BCG adenitis?
In BCG adenitis, coming to the treatment first, usually I don't do anything. I don't do anything and usually wait and watch. Usually it will involute. If it is going for suppuration, non-dependent drainage or non-dependent needle aspiration, frequent needle aspiration I can do. No role of incision drainage. Unless it is very big, you have to go for excision rather than incision and drainage. This is the management aspect. Usually BCG adenitis and BCG abscess are common, but if the child is failing to thrive, we should always have in mind something is fishy, whether I'm dealing with the underlying immunodeficiency. So this is the point we should have in mind. If the baby is not failing to thrive and healthy, we can take chance. Mostly the child is having just a simple BCG adenitis.
Winsley, so, I just had a comment.
That yes,
first slide, I think it is from the first slide, I think it's mentioned 6 years. He must be
6 months of age. Sorry, 6 months of age. Sure. Yeah. I think that's a typo. Yeah, sorry.
Yeah, no.
It's 6 months of age.
Panel, 2 people asked. Sure, go ahead.
Like Dr. Palaniraman mentioned, I think BCG adenitis, there's really no role for any antibiotics or anti-tuberculous drugs are also often ineffective. If you have a good immune system, that will take care of it. And if there is a lot of suppuration, then you can aspirate it with a needle. And if there is, needle aspiration basically only prevents the discharge and its associated complications. It sort of shortens the duration of healing. And surgical excision can be done if the if the nodes are very large. But then, you have the risk of general anesthesia. So this child, this is the same child. You can make out the BCG scar. It is obviously abnormal for a BCG scar to be like this at around 3 years of age. Dr. Walson, when would you worry about a BCG scar? Walson, can't hear you. I don't know whether you're muted.
Yeah, sorry, I was mute. No, I would actually worry because that scar should have healed even with, what do you call a BCG adenitis going on, and BCG adenitis is usually single. It's axillary. It can be supraclavicular. It can be cervical. But to have all these areas involved, number one. Number two, to have the scar not healed, that to me indicates that there is some degree of immunodeficiency. And like Dr. Palaniraman said, normally you don't get all this going on and on. It usually subsides. So the fact that it is there, I would worry about combined immunodeficiency or something else like a predisposition to persistent mycobacterial infection. There is something called an MSMD, Mendelian susceptibility to mycobacterial diseases. And this actually makes you susceptible to infections with, low virulence mycobacteria, such as the Mycobacterium bovis, which is found in the BCG. So I would actually definitely work on immunodeficiency as my first point over here. The second thing is, if I have an abscess which I can drain, this one, because it's going on for so long, I will send it for a culture. And I want to know whether it's atypical. I want to know whether it's bovis. I want to know whether it's tuberculosis. One of the issues with the PCR, the expert is it takes complex, which includes bovis. So probably give me up.
Yeah, so I mean, moving on. I mean, I think you can make out. I mean, that was the front of the child, and this is the back of the child. There are multiple, collections at the back as well. You can see one collection on top of the scapula also. So this child obviously had an extensive BCG infection. So we did a culture from that lymph node, and it actually grew Mycobacterium tuberculosis, and the expert was positive, and there was resistance to rifampicin. Dr. Anila, I mean, I just want your opinion on is this TB or is this BCG? How do we know?
Yeah, so M. bovis is what is there in BCG, and that is supposed to be intrinsically resistant to pyrazinamide. So when you see an MTB detected high, it actually means it's one of the M. tuberculous complex, and that includes M. bovis. Now, to sort this out, one would be to look at the pyrazinamide resistance when the sensitivity comes, if you have that. Or the other way of doing that is to do a PCR for M. bovis. And that would tell you whether it was Mycobacterium bovis. Yeah.
So I guess the point is that even though it actually the expert is positive and the Mycobacterium culture is actually grown, it need not necessarily be TB. I think it will still be BCG. And like Dr. Anila mentioned, I think the pyrazinamide susceptibility is a surrogate to say that it could be BCG and not TB. But unfortunately, at that time in our lab, we were not doing pyrazinamide susceptibility. Another interesting point here is that, I mean, this is probably BCG because, I mean, you can make out that the BCG scar was so big. And also, I mean, everything sort of started off from the BCG region. And this was INH as well as rifampicin resistant. Now, is that something that can be considered? Can you have BCG, which is INH and rifampicin resistant? Dr. Walson?
It's rare. Like Anila said, I would actually expect pyrazinamide. I would not expect rifampicin resistance. Isoniazid resistance can be there with M. bovis, but rifampicin is pretty unusual.
Yeah. So it is unusual, but then I mean, since we are dealing with unusual sites and unusual cases, so I thought so. I think it is very likely that this was MTR BCG, and it's been shown in many studies that people who have immunodeficiency generally tend to, I mean, because of the multiple courses of the antibiotics that they receive, they actually do develop resistance to rifampicin also. So you can actually have a MDR BCG problem. So, I mean, this is just to give you a flare of what, I mean, of the literature that's out there, which actually shows rifampicin resistance to BCG. So in this child, we did immunodeficiency workup. The total counts were okay. Differential counts were also okay. HIV was negative. Immunoglobulins were all within the normal limits. DHR was done, which was done to look for a chronic granulomatous disease, which again was negative. And the lymphocyte subsets was done to look for any features of SCID, and the numbers were all actually normal. We did a MSMD workup, like Dr. Walson mentioned. I mean, this was a Mendelian susceptible to mycobacterial diseases. And nowadays, it's easy to do this test with a next generation sequencing. And we found that this patient was actually IL-12 RB1 gene. There was a mutation, homozygous mutation, which was positive. And that was the reason he was developing all these abscesses in spite of our prolonged treatment. I just want to put up his growth chart. Dr. Palniraman mentioned that if there is failure to thrive, you should worry about immunodeficiency. But I can tell you that if for MSMDs, for some reason, if they have MSMD, even if they grow, I mean, they generally grow well. And it's only when they are very sick that they actually go off the growth chart. They generally grow well. But like you rightly said, I think with combined immunodeficiencies, they have failure to thrive. But with MSMDs, I mean, we've had many children that we've seen over the past few years with MSMDs. They somehow seem to grow well till they become very sick. This is the growth chart of this child. And unfortunately, this child, actually, we could not treat. We planned for a bone marrow transplant where they could not afford it. And then the child succumbed to this illness. But yeah, so this is just to highlight that BCG infection can progress. And if there is unusual BCG infection, you should suspect a primary immunodeficiency. So just to tell you a little bit about the complications of BCG, complications of BCG could be local, which could be abscesses, keloids, or ipsilateral lymphadenitis. Now, these can happen with people who are immunologically competent, whereas distant complications that, like, for example, osteitis or osteomyelitis can happen even in healthy individuals. And this is actually very common in the Scandinavian countries in the 70s and 80s. So much so, they stopped BCG vaccination in those countries because of these distant complications. Whereas disseminated BCGosis...
Excuse me, sir. Excuse me, sir.
Yeah.
Sorry to interfere. We are getting many complaints that audio is not very clear. Can you cut down the video so it may be easy, especially
Okay.
Dr. Winsley? Yeah, thank you, sir.
Yeah. So just to tell you that with disseminated BCGosis, there is that is often associated with primary immunodeficiency. Now, moving on, this is just another, I mean, so this is a 12-month-old who's got fever for 8 days, red eyes for 5 days, right-sided painful neck nodes, and the lips are red and cracked. And the BCG scar is actually trying to reactivate. And you can look at the hands, which are actually, there is also some periungual desquamation. Can I ask Dr. Palniraman, so what do you think this could be?
This is Kawasaki unless proved otherwise.
Yeah, I think that's a very important point, because when you have Kawasaki disease also, especially in infants, there is reactivation of the BCG scar. That's a very, very important point to note, that if you have Kawasaki and if you have, I mean, if you have fever and if you have reactivation of the BCG site, that's something to keep in mind. I mean, it's not always a BCGosis or a BCG problem. It could just be Kawasaki. So moving on, this is another child. I mean, I've got about 3 cases. I'm going to show you pictures of 3 cases. Wherever I've shown, I mean, always people have come back and said, oh, I've seen somebody like this in the past and we didn't know what it was. So that's why I'm actually included this in this. So this is a 20-month-old boy who had a swelling which was progressive for about 12 months. It started off with the buttock. He had IND done twice. There was no pus. When he came to me, he was actually unable to walk. He had no fever, no injury, no bite, and no other infections. This is the front. He had an indurated swelling which progressed to involve the scrotum. It was ulcerated. There was no regional lymphadenopathy. There was no palpable organomegaly, and he had grown very well. Some of the investigations, his total count was very elevated, 34,000. Differential showed significantly high number of eosinophils. Platelet count was also very high. We did an X-ray and that did not show any bony involvement. This is another case. This is a 3-year-old. Again, thigh swelling for a year, progressed to the buttock and scrotum. No other swelling, no fever. He's a well-grown child, but he had this non-tender induration involving the thigh, buttock, and scrotum. There were no regional nodes, no liver spleen enlargement. Here again, total count was elevated. There was eosinophilia. So can I ask Dr. Palniraman? So what would you think? How would you proceed with this child if you were to see this child in your clinic?
It may be two things, either a chronic infective process or a chronic malignant process. Because I have come across such a particularly like a gluteal region you have shown on swelling and finally turned out to be a sarcomas. But this can be, but the picture which you are showing, because it looks like some chronic infection, either a fungal infection or some unusual infection. I think so.
Dr. Walson, can I ask for your comments and how would you progress on with this child?
I actually don't have more to add than what Dr. Palaniraman has said. What I would actually want to do now, I mean, I agree with him. Malignancy, he said sarcoma, I will add T cells lymphoma, and infections, chronic infections. Some of the things that can present with localized swellings could still be tuberculosis, could be fungal. I mean, bacterial is unlikely, especially in the absence of systemic symptoms. So my next step would actually be to plan for, you said an X-ray was done. I would actually like to, if they can afford an MRI to look to see where the, swellings are, whether it is subcutaneous within the muscle or whether the bone is, there's some bony involvement, and then a biopsy and for histopathology and a culture. The culture I would actually send for bacterial, mycobacterial, and fungal.
Okay. So if you see, these children, actually, both of them had biopsies done. And on their biopsies, it actually showed broad aseptate hyphae. Now, Dr. Anila, what would you consider when you see broad aseptate hyphae on a biopsy?
Yeah, so what we would consider is something belonging to the mucor group, or a subcutaneous, what do you call it? Subcutaneous fungal infection, like an N of basically diseases like basidiobolomycosis and conidiobolus. But I think given this location, I think basidiobolomycosis is what is more likely. So these are subcutaneous fungal infections, and
yeah, so I think thanks. I mean, so as you rightly said, whenever you see broad aseptate hyphae, we should consider zygomycetes. And zygomycetes, I mean, the commonest things that we usually consider when we think about zygomycetes are actually mucormycosis. But mucormycosis usually happens in people who are who have some sort of a immune problem. Whereas subcutaneous zygomycetes, like you said, conidiobolomycosis and basidiobolomycosis actually happen in healthy people also. It doesn't need to be there in people who are immunosuppressed. So this is another case. This is actually somebody who sent me as a WhatsApp forward. I've just taken it ditto from that WhatsApp forward, including the pictures. And I'll ask Dr. Walson to actually comment on this. So this is a 6-year-old girl who presented with bad cellulitis in her right calf region, which has been gradually worsening over 6 months. It did not respond to multiple antibiotics. There was broad spectrum antibiotics were started. Debridement was done. Pus culture group Proteus vulgaris. Biopsy revealed extensive areas of necrosis with microabscesses and fungal elements which were aseptate. Conventional amphotericin was started and piptaz and amikacin for the Proteus. The lesions improved a bit, but then again became worse. We also developed fever, rash with amphotericin, so they stopped the amphotericin. So the questions are, would any other antifungal like posaconazole be useful, or is there any other differential to be considered?
So I think this also fits in very well with the other two cases you presented. If you were to just do a broad overview, yeasts, you can divide fungi into yeasts and molds. Yeasts are classically Candida and Cryptococcus. Molds, if you were to say septate, they're usually Aspergillus and some of the Ascomycetes. The aseptate, like you said, are Zygomycetes, which is mucorales and the entomorphorales. I would put this, especially with the subcutaneous location and the fact that it did not improve with amphotericin B, I would think of basidiobolus. Conidiobolus usually involves the, and it's enterorenal, it's actually sinus and can be GI. Basidiomycosis, again, very interestingly, treatment of choice is not amphotericin B because amphotericin B doesn't actually work well. What can be used for treatment for basidiobolus, you have the options of potassium iodide, cotrimoxazole, and I think just recently ID cases has released a series of cases of basidiobolus, all of whom have been treated with itraconazole. So the third option are the azoles. There are some reports on itraconazole resistance. In this case, voriconazole is given, but potassium iodide and cotrimoxazole are still actually up there as very good treatment modalities. So that is what I would say. Differential diagnosis, consider basidiobolus. Treatment modality, the amphotericin B is probably not going to work.
So this child, actually, I mean, I called this child back, and since this also the biopsy had already shown broad aseptate fungal hyphae, we treated with potassium iodide and Septran, and this is the basidiobolus ranarum, which actually grew on a culture in the first patient. The second patient did not grow, but we had a broad aseptate hyphae on the biopsy. And just to summarize, pathogenic zygomycetes could be the mucormycosis or entomophthalomycosis. And here what we are talking about is entomophthalomycosis, which happens in people who are not necessarily immunosuppressed, and that is conidiobolus and basidiobolus. And this is a picture of somebody with conidiobolomycosis. And what we've seen are basidiobolomycosis. These are the two children who, after treatment with potassium iodide and Septran for 2 months, you can see it actually works like magic. In fact, a child who was not walking for 8 months started walking after 2 days of potassium iodide treatment. So this is the other child who was treated with potassium iodide. Both were treated for about 3 months. We monitored them for hypothyroidism, renal failure, and hyperkalemia, and they all did very well after that. Yeah. So
Winsley, I want to another one thing.
Yes,
sometimes we come across as cases of particularly non-tuberculous mycobacteria producing such abscess particularly in the when in the periphery, when they give the IM injection and following vaccination or anything, the gluteal abscess not responding to the regular IND or regular things. Sometimes non-tuberculous mycobacteria also is one of the diagnoses I want to think.
Yeah, I think the important thing is not you can't look at it and say that this is basidiobolomycosis. I think the important thing is to say that if somebody comes like this, you need a biopsy. And once you've done the biopsy, you should send it for bacterial, fungal, and mycobacterial cultures, like Dr. Walson mentioned. And a definite differential is also a T-cell lymphoma, because they can also proceed on like this for many months with indurated skin lesions. So a biopsy is important, and then you can take it further. So the next case, this is of a 14-year-old boy who presented with back pain for about 4 months, fever for 4 months, and weight loss of about 20 kgs in 4 months. He had inability to sit for about 2 months. He had progressive weakness of both lower limbs. Bladder and bowel sensation were normal. His grandfather had tuberculosis when he was young. And incidentally, he also had sickle cell anemia, but had a splenectomy about 4 months prior to that. On examination, he looked very wasted. His tone was decreased in both lower limbs. His pain and touch were also diminished below the ankle. He had his plantar reflexes were absent, and he had a gibbous deformity in the mid back with a small ulcer and a left paraspinal swelling, which is 4 by 2 centimeters in size. He also had 3 centimeter hepatomegaly, and all the other systems were normal. This is his X-ray. Dr. Palaniraman, I mean, in the periphery, if you were to actually in the outpatient practice, if you were to see a child like this, what differentials would you consider, and how will you manage this child?
First and foremost, I definitely come to the conclusion mostly we are dealing with the part spine and the tuberculous paraspinal abscess, particularly when the AP X-ray definitely will show the abscess fusiform abscess, it can really show. And with the given history of going for 2 to 3 months with the loss of weight and loss of appetite, first and foremost, we should rule out this thing, tuberculosis. But here the red herring, or I don't know, you are given the sickle cell anemia and the thing. So here definitely the definitive diagnosis only after the particularly the aspiration and the culture, then only we can have a definitive diagnosis, because you have given some sickle cell anemia, splenectomy, something can have unusual things can be grown also in this type of situation. So usually we are not going to handle, we are going to refer the patient.
Okay, I think that's a fair point. I think the important thing is it looks very much like tuberculosis. It looks very much like pot spine. Dr. Wilson, I mean, how would you approach this child? I mean, since we work at a hospital.
I would definitely, want to delineate where the abscess is. Like I said, because of what Dr. Palniraman referred to as the red herrings, I would actually get our, spinal disorder surgery people to aspirate the abscess, send it for a bacterial culture, send it for, mycobacterial culture. For me also, the first diagnosis here would be a tuberculous spine. So, but the first thing is to get the pus, and if by any chance they are thinking of if any tissue is possible, well, a tissue, would also be perfectly good, but at least a bacterial and mycobacterial culture would be absolutely number one priority.
Would you start empiric anti-TB treatment?
No, this is not, because this is a situation where I can, it's gone on for quite some time. I'm not going to start empiric anti-TB treatment sitting in a tertiary care center. If I were in a secondary care center, if I were in a center where the patient says, I'm not going anywhere, doctor, you start, at that point, I would really be tempted to start anti-TB treatment, but in a tertiary care center, I would not, because, it's just that we've seen, things which mimic TB spine. So I would not start anti-TB treatment without getting a culture and, some definitive microbiological diagnosis.
So, I mean, this was the MRI which was done for this child. You can see the destruction of the L1 intervertebral disc and the vertebra. And also, there is a psoas abscess which is actually there. And everything pointed towards TB. But of course, I mean, we never start on anti-TB treatment without trying to get a definitive diagnosis in the form of pus or biopsy. And here, sure enough, we aspirated it and it grew something which we were surprised about. That was Burkholderia pseudomallei, which is actually basically melioidosis. So even though everything looked like TB, the final diagnosis was melioidosis. So Dr. Anila, can I ask you, I mean, if somebody develops melioidosis, would you, what else would you consider and how would you treat these children?
So when we see melioidosis, I mean, in this child is a child who's had sickle cell anemia, right? So this child has had multiple blood transfusions. So one of the causes where these Burkholderia pseudomallei, they survive is, when in high iron containing areas. So I would definitely check the ferritin and see whether that was high. And if that was high as a source for this Burkholderia to grow, I would give some medication in consultation with hematology to decrease the iron stores. Now, the other places where you see, other than sickle cell and these hemoglobinopathies, where you see Burkholderia growing are diseases, I mean, not necessarily pseudomallei. Any Burkholderia, you would definitely think CF, but that's not the case here. The other thing is immunodeficiencies. So immunodeficiencies like chronic granulomatous disease. So that is a condition where you have these organisms growing. And so these need to be ruled out in this child.
So we treated this child with ceftazidime for 2 weeks and followed by cotrimoxazole for 6 months. So this is the recommendation from CDC for treatment of melioidosis, which is basically IV treatment, which could be ceftazidime or meropenem, depending upon the sensitivity pattern. In our case, it was susceptible to ceftazidime, so we did treat with ceftazidime, and oral therapy with trimethoprim sulfa for another 6 months.
6 months.
So that's the treatment for this. And I think the risk factors for melioidosis are any chronic liver disease, renal disease, thalassemias. I mean, Anila did mention about recurrent transfusions and the high iron overload state, which predispose to melioidosis, cancers or other immunosuppressing conditions, and of course, things like cystic fibrosis and bronchiectasis. So I can move on to case 6 if there are no, I mean, can I just ask the organizers if we are okay for time? And if you think we are okay for time, then I'll move on to case 6. Otherwise, we'll stop because I think we've taken more than 45 minutes. Yes, Dr. Paniraman, please go ahead.
Actually, coming to the melioidosis, not only the immunosuppressed child and other conditions is common, particularly coming from the rural community, playing in the brackish waters, sometimes presenting with a rash and multiple abscess like a splenic abscess, liver abscess, lung abscess, cystic or cavitary lesions. We should always have in this mind, because long back, Dr. Ashwath from Coimbatore presented a case with coming from the rural community and finally gone to the Bangalore. Finally, Dr. Jagdish picked up with the blood culture and finally turned out to be a melioidosis, which such a, as you told, ceftazidime for 2 weeks and followed by cotrimoxazole for 6 months, the situation settled. Sometimes even in a normal child, very rarely you can have such surprises. And the only blood culture proved the diagnosis. Otherwise, you would not have proved the diagnosis.
I just want to add on. That's a very valid point, Dr. Paniraman, because even if you are not immune compromised, if the melioid is a soil saprophyte, it's found in the coastal areas. It's actually been found from soil in places like Kadalur in Tamil Nadu, in Kerala, places where children live next to paddy fields. So, anywhere that is marshy. So even a non-immunocompromised child can have melioidosis. Thank you.
Sir, can we close this? Already 1 hour into that.
Yeah. So I think we will stop here. I'll just go to my final slide, which is just to say, just to conclude.
Sir, we didn't want to interfere, but we have one more.
Yeah. I totally understand. So I'll just conclude. So basically, next phase infections we first looked at, and it is to say that they are dangerous infections, and treatment actually should include covering all the oral commensals, including anaerobes, and you should drain it whenever needed. If there is airway compromise, then definitely drainage is needed. Then we looked at BCG. If BCG abscesses or the BCG scar doesn't follow the usual course, think of primary immunodeficiency. Not all of them. I mean, you might still have a total normal and differential count. HIV may be negative, but MSMD is something that you need to consider. And it can be, you can make a definitive diagnosis using an NGS. Or if you have any long duration of infection, think about fungal infections, and a biopsy is crucial for diagnosis. And finally, we looked at a case of gibbous. Now, any gibbous, it's not always TB. It's always better to make a definitive diagnosis and rather than giving empiric anti-TB therapy. With this, I stop, and I thank our panelists who've been very gracious in conducting these discussions. Thank you.
Thank you so much, sir. We really enjoyed. I think you can switch on your video now. It has been real pleasure listening to all of you with so much variety of cases. And I would definitely say that we learn a lot every time. Valsan sir was the first person who really kindled my interest into this hospital-acquired infection, and that's why I went on to know about it. And Paniraman sir always got the best, though he's into his private practice. Linsley sir and Anila ma'am really rocked. Thank you so much for the session. As usual, all the panelists were great. So now we move on to the next topic by Dr. Sudhakar. Dr. Sudhakar is the secretary of infectious disease chapter in Tamil Nadu, as well as he's a professor at Institute of Children's Hospital, Egmore. Now he's going to give fever in a child less than 3 months of age. So over to you, Dr. Sudhakar. Thank you, and Susan. Sudhakar, are you there? Dr. Sudhakar?
Sudhakar enga ponapla.
தெரியல சார், அடிக்கடி போய் காணாம போயிடுவாரு சார். அந்த டைம் காணாம போயிட்டாரு.
ஹாய்
வந்துட்டாங்க. ஃப்ரெஷ் அண்ட்
ஆமா,
ஆக்டர் மாதிரி வந்து உட்கார்ந்து.
சார் 1 minute சார்.
So Sudhakar, do you need any more introduction for you, or I'll stop with this?
Wait. Okay, good evening to every one of you. Can I go ahead?
Yeah, please go ahead.
Yeah, good evening to all of you. This presentation is not going to be very intense as like in the last panel. It will be very light actually. In my presentation, only the last 4 or 5 slides will be really important. It is like a climax social movie. To justify that, we have added other slides actually. So it's about the febrile infant and outpatient approach. So I have, for practical reason, in an OP, when a practitioner is practicing, how to differentiate these 3 children, like less than 30 days to 3 months, 3 months to 1 year. This is not as per the ideal classification. It is based on my own experience. I'm talking everything from my own experience. So fever and outpatient, where is the confusion really happens? Many times parents will be bringing with fever or many symptoms. So out of 20 to 30% of our outpatients will have a carrying with fever. So the confusion is whether we have taken as a common harmless virus or less common severe viral infection or a very minor portion of the serious bacterial infections. We cannot overact thinking of less common SBI, or we cannot underestimate the occult severe bacterial infection against a simple viral infection. We always have the dilemma whether to start antibiotic or not. So fever neonates. Again, I'm going to differentiate 2 things in the neonates also. First 3 days and 3 days to 30 days. So what is the definition of fever? We all know it is about the rectal temperature. Rectal temperature above 38 degrees, but axillary is all. But practical reason, we measure only the axillary temperature, which is considered normal between 36.5 to 37.5. Axillary is always 1 degree less than the 1 degree Fahrenheit less than the rectal temperature. So it is. Again, coming to neonates, especially after 28 days or 30 days, it is not always the fever is indicative of infection. Even hypothermia is also an indicator of infection. So coming to a first case scenario, this is about a primary 30 years, conceived after 3 years, and anxious mothers after the LSES at 37 weeks, baby apparently normal, fed after 3 hours of delayed adaptation. Initially, the baby had an latching, so the hospital advised formula, but the mother is an educated mother, reluctant to start on formula. On day 3, the child developed a high temperature, settled after a while, and covered well for fever. And day 4, the mother noticed the jaundice, but there is no incompatibility with bilirubin 14. They started phototherapy in the hospital. The feeding reduced because the baby was most in the phototherapy, and mother wants the have the maximum time of phototherapy. The child developed high fever. They use the local measures like using fan for ventilation, all those things. On day 6, the child became lethargy, poor feeding, vomiting, and the child started on antibiotic, being treated as a sepsis. As the child sensorium worsened by day 28, and there is a huge weight loss, the child was referred to our NICU. Here, we admitted the child and we started on IV fluids and continued the antibiotics. Meanwhile, we started screening for the thing. But the point is, here we found out the urea to be 120, serum sodium to 170, CRP6, X-ray normal, and all the other results were normal, not everything in the borderline. So with proper fluid, the newborn showed very good improvement. So here, is it a fever? Now it's very difficult to answer whether it is a fever or anything other cell. So now we we have to understand there are other condition other than fever in newborn called hyperthermia. It is more common compared to fever. The incidence, it's not about the Indian data. I can quote only the Western data as per the books. 1 to 10% hyperthermia, whereas fever is only 1% temperature. In hyperthermia, it may exceed 42 Celsius, whereas in fever, it is 38 to 41. So the point is, I don't want to go into full detail. So the hyperthermia is more common in newborn period, especially in the first week. It is more of due to dehydration or overheating. It's due to iatrogenic. Whereas fever, there should be any chance of infection like prematurity and pre-rupture of membranes. Here, hyperthermia, the child will be well looking, where is unwell actually, and rapid response to the fluid management in hyperthermia, whereas in fever, it needs antibiotic, not the fluids can do anything. So we need to think about hyperthermia than fever, especially in the newborn babies. So the first 3 days, always consider overheating from the incubator, radio warmers, or ambient environmental temperature, maternal fever, maternal epidural anesthesia, phototherapy light, sunlight. Sometimes parents will be showing the baby in the sunlight actually, or maybe in poor feeding, it's due to dehydration and going to dehydration. Excessive bundling, this is also very often happen with our thing. Then comes your infection and CNS. So infection as a cause of fever at this stage, that means less than 3 days of is very rare, but still always observe and evaluate. So coming to 30 days to 30 days, fever and outpatient approach. So here, 20% of the newborn OP cases may present with fever based on the studies I'm quoting, Indian studies. About this fever, 10 to 12% of neonates have a serious bacterial infection. So that means almost 80 to 90% of the babies may not have a serious bacterial infection. But as a rule, we have to admit the child. There is no outpatient approach, but always look into history of the maternal fever, prolonged rupture of member, maternal culture positive for the group B streptococcal, and any history of genital. Never have, because these are things we often miss, and we'll start antibiotic, look for all culture, anything, but always don't forget to find out the reason. So infections in newborn easily outsmart our knowledge actually. So coming to 30 days to 3 months. 30 days to 3 months fever outbreak. Many times we come up, first confirm whether it is fever. Because many times we come across with the parents saying, Talaila sududu, virus sududu doctor, jorama irukku. This is the very common scenario people bring to us actually. Or like laryngomalacia, noisy breathing. Noisy breathing irundha chali pidichirukkudu, udambu thalayum virus sutittu irundhuchina fever irukkudu. Many times we forget to observe the child, how the child is dressed. They're full of sweater, especially during fever irukana innum konjam naal extra covering pannirpaanga. So always unwrap. As per the WHO, unwrap, open the baby, uncover the baby, leave it for 10 minutes, then check the temperature. So again, head to foot examination. It's like blessing the child and get the blessing from the baby. So from head to foot examination. And always, whenever you think about, if it is a fever, always think about 3 I's: infection, inflammation, infiltration. The infection always plays the major role in this duration of 30 days to 3 months. The history to include illness in elder siblings and their vaccine. It is very important to exclude these things actually, because many times small children will come and kiss their siblings actually, and they will transmit the infection. It is easy for to understand how the infection in that previous elder sibling, so we can relate to that. And never forget about the occult infections like urinary tract infection, bacteremia, meningitis, arthritis, etc., etc. And arthritis especially hip. And many times we often miss these things because we don't have any other evidence for that actually. So common infections are viruses, especially influenza viruses, enterovirus, adenoviruses, and respiratory syncytial virus. First 3 viruses will present in a very mild, or whereas RSV will present with a severe bronchiolitis, not responding to our own our humidification or something like that. So they may need even foreign ventilation. Come on, next to the bacteria, pneumococcal bacteria, Escherichia coli, and stuff. Considering our vaccination status in India, we are giving in the private sector only 7% coverage in the Prevnar pneumococcal vaccination. Whereas in the government, it is going less than 2 kg. That was started now only for the last 6 months. So we are yet to cover the whole system of new babies for pneumococcal. So we have to expect the pneumococcal. We cannot expect a HIV influenza. So Haemophilus influenza nowadays we don't get, because all the babies have been vaccinated with almost 97% coverage. Next, the E. coli and Staphylococcus we never forget actually. Then another I want to come, a 3 months baby on exclusive breastfeeding referred from Kanchipuram. This is a Kanchipuram GH is referred, fever with 3 days and anemia, spleen palpable and thrombocytopenia. It's a well-thriving child, smiles back nicely, playful, feeding well, and referred as a suspected malaria, but not started on anti-malarial drugs actually. We admitted the child because the child has been referred from another hospital. The counts were normal, the hemoglobin was 10 milligram per deciliter, it's a microcytic hyperkalemia, and there is a thrombocytopenia. It is not an alarming, it is just on 1 lakh. The abdomen shows a mild splenomegaly and other values are normal. And there is no evidence of any occult infection based on the culture and everything. How to go with this case actually? So my PG says that it could be in clinical malaria because there is a fever for 3 days, there is anemia, spleen palpable and thrombocytopenia. It may be a rickettsial infection or it may be a malaria or it could be a simple viral infection also. So the thing is, the message I want to convey is whenever in my practical experience, whenever you send for an ultrasonogram, the radiologist always gives splenomegaly. But the thing is, we always need to understand a palpable spleen is found in most preterm babies and 30% of the term infants. A spleen tip is still palpable in 10% of the infants up to 1 year of age and 1% of the children up to 10 years of age. It is always as per the spleen size. This measurement I have given, but we have to get within measurements that's cutoff levels from your own radiologist actually. This is the thing given in an article. Splenomegaly, anything more, splenomegaly has to be considered when anything more than 6 centimeter at 3 months or 7 centimeter at 12 months, 9.5 centimeter at 6 years, it goes on. So the point is, just because you feel spleen, don't take it as splenomegaly. Just because there is an anemia, because almost 65% of our children are having anemic. Almost 65 to 70% of our mothers are anemic mothers only. So we need not, but this child, we didn't do anything. We simply observed the child. The child was discharged without any antibiotic. So another case of drink, that was a simple case. Now I'm going to the next case. Danyasri, 2 months, 10 days, female baby. It's a second born non-sconty. Fever with 1 day with irritable cry and breathing difficulty. Apparently normal 2 days back. And there is a thing, there is a development, the child developed a erythematous rash involving the face, trunk and limb. The mother went to the nearby primary health center. Baby was treated with oral medications. After the first day, the child rash worsened. So the baby admitted under care, lethargic, refusal of feeds, incessant cry, bad CRP, rashes. The striking thing is about the rashes. No other findings actually. There was not much past history because baby is only a small baby actually. So the examination, there are the edematous lung, skin mottling was there, flushed face, trunk, palms and soles. So all the other things are there. Only thing is effortless tachypnea and a soft splenomegaly. So the investigation saw increased total count, a platelet with 4.5 lakhs and an anemia. The CRP is 12 and LFT, RFT normal. And there was the day 2, that there was a persistent tachycardia, continued fever spikes, shock did not improve with the fluid bolus and ionotropes continue. We upgraded without knowing what to do. We were also in a panic. Actually, we started to increase the antibiotic coverage. So we started meropenem. But still the rashes started progressing and it started going into a gangrenous level. PTA, PDT, INR was elevated. D-dimer was almost 1,920 and we started a FFE transfusion. And meanwhile, this is the case of the gangrenous and changes, erythematous change and a gangrene, the child. And as the hemodynamics maybe improved, fever spikes subsided, but the skin changes persisted. So we refer the child for the hematologist opinion to ICH, where all the cultures were normal, repeat CRP were normal. And finally, the child, because the rash was persistent and no culture was there, there is no proof of any infection. They thought about congenital anticoagulant deficiency was suspected and protein C and protein levels tested in both parents. It shows the mother having reduced protein S and C and father having reduced protein S. Finally, a diagnosis of purpurifilm. So we need to be very alert in our OP when there is a change. See, always what I want to convey here is whenever you're seeing a baby with fever or something, when you are not able to find out the focus, always please ask the baby to come back without starting any antibiotic. If the child is hemodynamically stable, we need not rush with any antibiotic, but always ask the patient to come back. Case scenario 3, baby Mitra, 3.5 months, had third dose of Pentavac vaccination, developed fever after 4 days, had been treated with antibiotics in private for 3 days, and admitted on 7th post-vaccination day with 3 days of fever. The vaccination site showed small swelling. There was no induration, no pain, well-thriving child. During a febrile period, taking feeds well. There was no foci of infection history and examination. So it has been registered as an adverse event following immunization. The parents were telling the VHN that because of her vaccination only everything happened, but the counts were normal, CRP normal. Anyway, for the sake of safety, we started an antibiotic. During examination, the baby was kept in the mother's lab. Nobody noticed that actually. There was a restriction of movement on the hip on the vaccinated leg. So now meanwhile, the blood culture we received the blood culture report. It shows Klebsiella oxytocin, which is a gram-negative, which indicates as a pathogenic bacteria. We need to rush with an antibiotic. But the point is, I'm not able to convince with the way the child is presenting. If it is a septicemia, the child should not be present like this. A well-thriving child taking feed very well in between that, except for a restriction of movements on the left side. But meanwhile, I'm not convinced about the injection abscess also. So ultrasound hip and MRI hip and knee joints were not done. Everything showed normal except for a synovial thing. Finally, it is managed as a transit synovial after stopping the antibiotic and continuing with only. So the point is, when with paracetamol, it is become normal. The point I want to convey here is our clinical examination is more important than your other results actually, because the initial ultrasound was in a confusing state. So we did an MRI and everything, find out. And I went through the journals. There was no transient synovitis following immunization has been reported, especially in the infants, except for rubella vaccine and flu vaccination. In certain few journals have been, that too only adolescent adults. There was no case reported in the young infants actually. So we are not able to explain these. It may be a simple viral synovitis. It's a coincidence actually. So 3 months to 1 year. A case scenario, 6 months, baby with fever for 2 days with running nose with fever spikes ranging between 101 to 103, no afebrile interval, as the parents are very anxious about high temperature. Child was started on oral, sorry for the spelling mistake, was started on oral antibiotic as well as CBS was ordered. The complete blood count showed total count 14,008 with neutrophilic predominance and a normal plate count with a CRP of borderline 6 nanogram. The point here is, we are not supposed to, we need not panic. See, here the case is a simple viral infection. Consider the duration of fever. It is just a 3 days, less than 3 days. Whenever you go for a fever, it's less than 3 days. Yes, the neutrophil is going to be predominant. We need not take it as a bacterial. Whereas other than that, when we don't have any culture positive and there's no any foci of other infection other than a running nose, very well we can manage the child with paracetamol. This is a case in my own practice. I managed only with paracetamol. The child is fine actually. Then again, another child, a 2 years child admitted 2 days back, 2 years old male child, high grade fever for 3 days, no other symptoms or signs of any foci of infection, WC normal, the MP-card test positive, the child was managed with syrup falcigo, injection amikacin, injection subtraction in just 3 days. This was in private practice in Chengalpattu district. And after getting admitted, I stopped everything in our, and simply observed, it's found to be very simple because MP-card test should not be been done for this child. First of all, it's a rapid test. You should not rely on the rapid test actually. Your clinical knowledge, because sometimes investigations misguide us actually. This child has been managed without anything and finally went very well. Case scenario 6, this is a 6 months female child Nila, present with high grade of fever and diarrhea for 7 days, treated as outpatients. I only started oral cefixime, started me of persisting fever and diarrhea. Still fever was persisting, as I don't know how to go with that. I don't want to take risk. After 7 days, I admitted the child in KKCTH under Dr. Janani madam, and madam made the clear diagnosis of multisystem inflammatory syndrome in children, MICC. So with the COVID and immunoglobulin positive, nicely managed, the baby is very fine actually. So we need to think that there is a wide varied presentation of fevers will be come to our OP. So we need to see everything with wide eye open actually. So there are a lot of, so how in a practical, I have talked about so many things in a very short time. So it can be a simple viral infection, or it could be a purpura fulminans, it could be MIC. So a fever can start with the, but we need to follow up the child in a meticulous way. Never hesitate to ask the parents to follow the temperature chart, teach the parents to follow temperature chart, ask them to come as much as possible. Then comes here, there are a lot of criteria. When you go to the textbooks, there are a lot of ideal things are there. There are Boston criteria, Philadelphia criteria, then comes your Pittsburgh criteria, Rochester. So a lot of things are there actually, especially for less than 90 days baby. So what is the problem? It is that you go through the investigation. They always need an investigation. But practically in the Indian setup, they won't hesitate. They will be hesitating to give a fees for you, 100 rupees or 200 rupees. If they how come they can do a complete blood count, urine culture, urine retain, and another biggest problem is most of the criteria require cerebral spinal fluid. Lumbar puncture is very much important to fulfill these criteria. So what is the problem in Indian? What is the difference between the Western? This slide, I thank Dr. Thangavel sir for sparing this child from his presentation. The Western environment and Indian army is totally different. The age and blood culture based is our Western literatures. So we should have our own set of blood culture results and age based diagnostic. Only institutes like Childress, CMC, Coimbatore, they are doing the studies actually. I think every institute have its own pattern of infections as well as culture sensitivity pattern. And uniform standardized approach from home care to emergency room, ward, critical care, that's a well-connected network thing, but we don't have anything. We don't have a uniform standard for our own investigations and antibiotics. So we need to improve of that actually. So Western protocols is very difficult to apply in our setup because it needs lab support, which is inaccessible, many times unfortunately unreliable and very expensive and not in convention in our setup. And the common illness like it differs from them because their vaccination rate is totally different from vaccination pattern as well as the disease pattern is totally different from Indian setup. We need to think more of dengue, malaria, enteric, leptospira, and of course, I don't want to forget the scrub typhus. And after going to Chengalpattu, I come across like a surplus of scrub typhus. And when applied, many bring a new perspective relevant to our own. So we start to think about our own thing, and we need to document every case of fever with clinical findings and investigations. And this, I'm going to come to the end that this is the literature review. Our Indian Pediatrics in 2017 has come out very nicely about that. This is about the approach of a child with fever in an emergency room as well as an OP. So here I have taken only this, a well-appearing child coming with fever to then our OP. It's either your OP or emergency room OP. So they have categorized into three things. So let us consider the first three things, 29 days to 90 days. That's up to first 3 months. Even Indian Pediatrics, IAP recommend a blood test of complete blood count, quantitative CRP. It is not just the qualitative, it is quantitative CRP. And another thing I want to mention always a serial of quantitative CRP. Then the band cells, we never ask for band cells. It is very easy for the pathologist to give it. I touch immature and total cell ratio. It is again going to be a very simple thing. Toxic granules. Yes, again, it is anyway, whenever the pathologist is going to say, they can mention about the toxic granules. Vacuolization in WBC, blood culture. And unfortunately, here also we need lumbar puncture. To be an ideal, yes, we need to have a lumbar puncture and X-ray and urine. Of course, except for the LP, all the other investigations, we can very well do it actually. Coming to the 28 days in neonates, I always tell better admit the child. If there is a fever less than 20, never take risk, better admit the child and evaluate the child. And 3 months to 2 years, or there is a partial evaluation for severe blood tests like complete blood count, quantitative CRP, band cells, IT ratio, toxic granules, vacuolization, RBC, blood culture, urine routine and culture. And we need to inculcate the culture of doing culture. Dr. Gunasingh always insisted this, never do start an antibiotic without doing any proper culture. And we need to sensitize our own parents of doing the culture. We never start, better not to start any antibiotic without doing any culture. Coming to the, so what is the thing? When I talk to Thangavelu sir, what can we do when the criteria like in Western criteria cannot be applied to that? So what is the criteria? Why don't we develop a criteria? That's what sir gave the reply. There is a criteria. It's simple pediatric assessment triangle. So here,
Sudhakar, you need to hurry up. You're already.
I'm in the last slides. Okay. So it is about the alertness, breathing pattern, and circulation. So we can go to the foci. If you have to look about the foci of infection with this. Okay. So the lessons to learn is parents may be panicked, but not their doctor. A proper history, proper examination, proper communication to the parents is the gold standard of management. If the child has received an antibiotic within prior to 3 to 7 days, because of the long half-life of antibiotic in young infants, administration up to 7 days prior to evaluation may mask the sign and symptoms of invasive bacterial infection. Be alert about it. Never take culture from sample from a non-sterile areas. Reports may be contaminated. Never just follow the results. Never start antibiotic based on acute phase reactants. Fever without foci. Please do a maximum examination, moderate investigation, and it makes you to give a minimum prescription. And evidence is always better than experience alone. Thank you, every one of you for the opportunity.
Thank you, Sagar, for your excellent presentation regarding febrile in the infant outpatient approach. It is one of the excellent presentation. Next 1 hour, we are having panel discussion on playing with labs. I want to introduce our moderator, Dr. Arun Bansal. He's a professor of pediatrics. PJ Chandigarh. He's one of the excellent person, and he is currently Secretary General for the IAP Intensive Care Chapter, and he is doing wonderful job in the pediatric critical care per se. Next is the panelist, Dr. Dhiren Gupta. He is currently Chairperson, IAP Intensive Care Chapter. I welcome Dr. Dhiren Gupta. And next one is Dr. Mullai Balaji. He is a consultant intensivist at Kovi Medical Center and Hospital. I welcome Dr. Mullai Balaji. Next is Dr. Suresh Kumar. He is Associate Professor, Intensive Care Chapter, Intensive Care at PJ Chandigarh. I welcome one and all. Now over to Dr. Arun Bansal.
Yeah, thank you, Dr. Rajendran, and good evening, everybody. Thank you, Dr. Narmada, Dr. Thangavelu sir, Dr. Rajendran, for giving us an opportunity to speak in this excellent discussion we have had till now. We had gone through, it was a very high quality discussion. I have been attending it since last few lectures. So coming to the last one for the day, playing with the lab. So I will be helped by Dr. Dhiren. Dr. Dhiren, if you can just raise your hand and introduce yourself.
Yeah,
great. Dr. Balaji.
Hi, sir.
And Dr. Suresh.
Yeah, good evening, sir. Good evening to all of you.
Good evening. Yeah, thank you. So I'll start sharing the screen. So this is an interesting topic basically given to us, playing with the labs. So it's again, we will be focusing on some of the cases which we'll go through and we will discuss about in this lecture about approach to different infections, how to interpret various laboratory reports, various cultures and various other reports, and rational use of antibiotics based on that, and what's the role of imaging in these difficult conditions. So first case, basically a 10-year-old female who was admitted in ICU with history of fever, acute onset, high-grade fever, and then developed abdominal pain, vomitings, non-bilious, non-projectile, and also had loose stools, 4 to 5 days, 4 to 5 per day, watery. But there was no history of rapid breathing, seizures, altered sensorium, decreased urine output, rash, or bleeding, or any jaundice. On triage, she had abnormal breathing and abnormal appearance, and skin circulation was abnormal, so she was unstable with life-threatening. Our main GCS was okay. Blood sugar was normal. Respiratory rate was 38 with increased efforts, and she had crackles on auscultation. Heart rate was high with CFT of 2 to 3 seconds. BP was 73 by 44. Central pulses good, but peripheral were poor with cool peripheries. She was febrile. with pallor, rash being present, periorbital puffiness. So she was having hypotensive shock and respiratory distress. So she was classified as resuscitation. So we started her on a nasal prong oxygen, gave a normal saline bolus, and also started IV ceftriaxone. So this was the child, the weight, the anthropometry was normal, was febrile, pallor was there, bilateral subconjunctival hemorrhages, puffiness, generalized lymphadenopathy, and there was an scar present over the abdomen. So this was the scar which was observed in the lower part of the abdomen. This almost we have discussed. So this was a child with 10-year female child, acute febrile illness, GI involvement with pallor, hypotensive shock, distress, generalized lymphadenopathy, conjunctival hemorrhages, capillary leak, scar, bilateral cleft, hepatomegaly. So very commonly we see this kind of presentation in our emergency. So we kept a diagnosis of various tropical infections, scrub typhus being prominent because of the scar, and then other possibilities were also kept. For shock, it was managed with adrenaline, started on doxycycline, and was shifted to PICU at 6 hours. So Dr. Suresh, these were the investigations which we found. Hemoglobin was 9, TLC was 15,600, DLC was 64 of polys, platelets were 57,000. MP test was negative. We have a sodium of 132, potassium 4.3, urea 88, creatinine 1.2. We have slightly raised OTPTs, bilirubin 9, calcium 9.1, phosphate 4.3. And this was the chest X-ray we had. So, Dr. Suresh, can you comment on these investigations? What can we make out from this?
Sir, Dr. Suresh, sir, I think you need to unmute yourself.
Yeah, sorry. Thank you, sir. So this child is a typical case of tropical fever, and if you go by history and examination, is fitting into scrub typhus, and at presentation he had respiratory distress and hypotensive shock. Investigation showed that there is some degree of anemia with leukocytosis and neutrophilic response is there, and thrombocytopenia is there. On biochemical investigation, transaminitis, OT more than PT, skeletal and soft tissue shadows, but there is definitely increase in parenchymal shadows, and cardiac silhouette seems to be normal with
okay. So we have in these
the investigation
simple.
that we see.
Yeah, so this is simple, like you have some high TLC, thrombocytopenia, some raised liver enzymes, and X-ray is being abnormal. So any child with the tropical infections, it is expected that these kind of picture will be there. You can have DIC-like picture, you can have neutrophilic response, and you can have some liver involvement in tropical infections. And lung infection can be there. So in spite of starting the doxycycline, the fever was persisting and the shock worsened, and epinephrine was already going on. Norepinephrine was added. But respiratory distress worsened, requiring ventilation, and liver parameters also worsened. So this is what we did, Dr. Dhiren. So these are the few other reports we have. So we have an HB which was fluctuating from 9 to 6, somewhere varying between that. TLC was gradually falling down. From 9,000, it came down to around 3,400. Platelets always were low, and they were always, the lowest was 8,000 by day 5. And you have a INR which was worsening, and you have a PTI which was low, and prothrombin time was also increased. And you have urea creatinine which was high, OTPT was worsening. So how do we interpret these reports in spite of we starting an adequate therapy in this case?
Yeah, can I comment on the previous 2 slides? One
yes,
is the
yes.
X-ray.
You can.
Can
yes.
you
Shall I
go,
go back?
two slides back? Is
yeah.
Before this? One is that because you said that lab includes X-ray also. two comments here, and one is that endotracheal tube is little bit in, means the gap between the
Yes.
carina and lower is just 0.5 centimeter, and secondly the line, center line is also little bit in. I mean, normally we expect from the carina two disc spaces. Two disc means
Yeah.
two
So
vertebral
I
body
will point
below.
out here. This is the center
Yeah.
line here, and
Yeah.
this is the ET tube. But Dr.
Yes,
Dhiren is trying to say. Okay.
Yes. So one thing is that, so this is also important when we play with the labs. And now move ahead. Second X-ray is perfect except the center line, but this is, we need not to change the center line, but we need to keep in mind that, okay, our center line is little bit lower. If some complication develop, one can focus on that. One thing. Secondly, it's a classical pulmonary edema. And at this time, means when we were giving fluid bolus, and one can make use of ultrasound, which you must have done, but just to make a point that ultrasound use can help in the deciding fluid responsiveness. Now we move forward.
Just before we move forward, can you just, for the sake of participants, what will you find in the ultrasound in this kind of pulmonary edema, if it is there?
See, everybody knows that more you give fluid, and if fluid is given unnecessarily, that is not taking into circulation in increasing the you can say fluid responsiveness or perfusion, that it increases the morbidity and mortality. Fine. So in ultrasound and echocardiography, inferior vena cava, because this patient is intubated, sedated, paralyzed, or not much having a spontaneous respiration, if you find your IVC is getting distended, distensibility index is more than 18%, likely that this patient is not going to respond to the fluid. Secondly, look at the contractility of the heart. That is very important guide in these type of patients. So these 2 points, along with B lines on the lung ultrasound, though in this X-ray is sufficient to say there is a pulmonary edema. So in these 3 findings are there, likely that these patients should not be given more fluid, more inotrope should be given, as it is done in this patient.
Perfect. So I would say means ultrasound in ICU or in any ER or any setting nowadays is basically a very handy hands-on tool, which can give you a very instant information, like Dr. Dhiren said. In fact, X-rays may take time to get it done, so ultrasound is very easy to do. So that's why I've included imaging as a one of the labs only as a part of this. Now coming back to this.
Now, looking at this, it means the history and a SHAR looks like a case of scrub typhus, fine?
Yes.
Or something like a dengue who is landing on some complication later in stage, like something like hyperferritinemic stage, or you can say some inflammation is persisting even after day 7. Normally, when you give doxycycline, these patients respond within 48 hours. And you don't expect these type of causes despite of normalization of blood urea and creatinine. Now there can be 2 causes which is leading to persistence of problem. One is liver dysfunction is not getting okay.
Yes.
I think a lot of disturbances are there.
Can we please mute those who are? Yes, thank you.
Yeah, thank you. So now if I analyze what is happening in this patient, your OT is more than PT. So it is an hypoxemia derived liver dysfunction, fine, not a hepatotropic virus. Second, these are persisting and these are worsening, and that is also manifested by PT-INR. Okay,
Yes.
and also fibrinogen is a hypofibrinogenic state. If you see at day 5, it's 0.8. Now come to the platelet. Platelet itself indicating that the patient is not improving and there's an inflammatory state that is persisting and consumption is there. Also look at the total leukocyte count. Especially if you look at the day 5, day 6, it is persistently low. So there are 2-3 series which are indicating that there is something that is not improving and some inflammatory state that is persisting, what I could say at this stage.
Yeah, okay. Balaji, you have anything to add in this, or you agree with this? What
just one point. I just want to see the ferritin also. What is happening to the ferritin and in this patient?
That's a good point. Yes. So we'll come to that. Dr. Balaji.
Dr. Balaji, you are muted.
Muted.
Yeah. Is it audible now?
Yes.
Yeah. Fine. So yeah, I completely agree with Dr. Dhiren sir and Dr. Suresh. So in this scenario, in a child whom we have a proper diagnosis like a test scar and possible scrub titers and classical multi-organ failure, we have seen the kid in the second week of illness. And when things don't go as expected, like usually we see the response in 48 hours of doxycycline, but the child is worsening. So two things can happen. Either there is some co-infection which is quite common in our setup, or there is some complication due to the primary infection, which as Dhiren said, inflammatory cascade that is got unleashed. So we need further investigations.
Dr. Balaji, your voice is getting echoing. You know, it's not very clear audible. And can you try some other audio? Is it true, Dr. Arun? His
Yes,
voice
there
is not very clear.
Lot of echo in Balaji's room.
Okay now?
I think double. I think cell phone also on. I think dual.
No, login only one device.
One device, no. Okay.
Looks like one phone is Mullah speaking and second is Balaji speaking. So both are speaking at the same time.
Is it still echoing now, or is it fine now? Better?
It's almost same. Anyway, go ahead.
Yeah, let's continue.
So,
excuse me, sir, please don't use the earbud, Bluetooth earbud. You will get echo. You better go for earphone.
He was using that.
Okay. So in this scenario, there are two possibilities that can be considered. One is either a co-infection that is there, that is present in the child, or it is the complication of the primary infection. So with scrub titers, it is well known that they can end up in hyperferritinemic sepsis, infection-associated hemophagocytosis. So that is one thing that we definitely need to consider, especially with worsening organ failures, progressive pancytopenia, and yeah, definitely worsening liver
dysfunction. So these are the possibilities that I would consider.
This is much better. Last
now
suddenly improved. Okay. So I think all the panelists agree to this, that there is a gradual worsening happening in this case, and especially by day 5, it was the extreme of this worsening was there. So either it is the complication of the primary disease or some other secondary infection or something else is happening. So further investigations, like Dr. Dhiren asked, ferritin was 11,000. You have fibrinogen 0.6. Bone marrow showed marked hemophagocytosis. Echo was showing ejection fraction of just 35%. And you have a scrub IgM was positive. Other cultures were sterile, and other tropical infection workup was also negative. So Dr. Suresh, what would you comment on this now?
Yeah, so definitely this child had evidence clinically, fever is persisting, cytopenias are there, and the liver dysfunction is also gradually worsening as highlighted previously. And when we did workup for hyperferritinemia or secondary HLH, it showed that ferritin is very high, and there is evidence of hemophagocytosis on bone marrow examination. And these make that the child fulfill almost all the criteria for HLH, except we don't have values for NK cell activity and CD25 level. So rest of the criteria are fulfilled. In addition, the ejection fraction is quite low, which could be a reason for the shock in this child. And after boluses, he went into pulmonary edema. So this could be the reason myocardial dysfunction is there. And scrub IgM is positive. So all this makes this child as a case of scrub typhus with secondary HLH.
Great. So thinking the same, he was started. What treatment is there, Dr. Dhiren, for HLH? Means what is advised for hyperferritinemia or HLH?
Yeah, I think steroid and IVIG, these are the two main thing, and especially secondary to infection. If it would have been secondary to some autoimmune disease, then DEXA would have been the first choice.
Yes. So thinking the same, methylprednisolone was started and was given means from day 4, day 5, when we had the maximum worsening, when we got the other reports and the workup. So he started showing improvement. and there was gradual improvement, and it had a remarkable recovery was there. He was extubated, and then this fever, cytopenia, liver dysfunctions started improving, and he was discharged by day 10. So that is what the importance of seeing all these labs and the clinical correlation is very important. So Dr. Balaji, when should we start suspecting HLH in these kind of cases, infections?
Yeah, see, that is a very valid question. So whenever things don't go in the way that we expect, so then we need to definitely think about any complication of the primary problem. So as said, whenever there is a worsening organ failures, that is when shock is not improving, and especially when there is worsening liver failure, liver dysfunction, then we always need to suspect that there could be HLH, and the subtle clinical clues will be progressive cytopenia, thrombocytopenia, and leukocytopenia, and as well as if there is other markers like hypofibrinogenemia that can aid it, and again hyperferritinemia. One interesting thing with scrub typhus is if identified early, I think this child landed up with us at second week, like day 8 or day 9. So that is the probable reason why the inflammatory cascade was already set up. With scrub typhus and HLH, when identified early, just the doxycycline or appropriate chemotherapy of the primary disease itself is sufficient. So many times these children do well with just the appropriate antimicrobial. But if there is worsening organ failure, worsening liver dysfunction, worsening shock, then obviously we need to treat. And as said, infection-associated conditions, IV gamma or IVIG is nowadays being increasingly employed.
Okay. So Dr. Suresh, how do you diagnose HLH or hyperferritinemic syndromes?
Yeah, sir, for diagnosis of HLH, we follow HLH 2004 criterias. But in presence of, like in our country or in countries with the tropical location, tropical infections are most common cause of sepsis, and then sepsis, hyperferritinemic sepsis, and HLH. This is a continuum of illness. But these are the like HLH 2004 criteria is what we follow. And the first criteria is like it's not always available at the presentation, so it's not like applicable always. And we follow set of 8 criterias, and out of these 8 criterias, we need to fulfill at least 5 criterias like fever, organomegaly, cytopenias, hypertriglyceridemia or hypofibrinogenemia, hemophagocytosis on bone marrow aspirates, and there should be low or absent natural killer cell activity, and elevated ferritin and elevated soluble CD25 levels.
Great. So in this child, we had fever, we had cytopenias, we had low fibrinogen, we have hemophagocytes on the bone marrow, and we have a high ferritin. So these are fulfilled, like means it's like a classical case of an HLH. Dr. Dhiren, you commented something on the infection-induced HLH and autoimmune HLH. So what are these means? Primary HLH or familial HLH, which is the term, and secondary HLH, like the infection-associated. Can you elaborate further on that? And
means as an intensivist, not an hematologist, I would like to simplify what I have understood over 15 years. One is congenital HLH, that is induced by some that got exaggerated by some infection. Even COVID can induce HLH in any given patient, and these patients usually present within 1 to 2 years of life, and they typically behave like any other HLH, but the problem is with the killer cells, so the type and the quality that matters. And these patients, you will find that the congenital HLH marker like soluble CD25, and these are the typical marker. And in slide, the molecular diagnosis can be made. One, bone marrow transplant is an answer. Second is the infection induced. Now this infection induced infection per se, or some patients with like SLE, or some patient with autoimmune disease, some patient with malignancy, these can go into HLH. And when these patients having some autoimmune or immune mediated diseases, they'll end up in HLH, then steroid, and usually hematologists prefer DEXA, and your rheumatologists prefer methylprednisolone as a first choice. When we talk about infection, like in this patient, infection-induced HLH, primary drug of choice which we prefer is an IVIG and steroid both, and because they are immunocompromised also, so we take care of both. So this is my understanding and about the HLH.
So Dr. Balaji, you want to add anything on this? And one more point is that any role of chemotherapy in HLH, like etoposide or vincristine people have used, or in what kind it is being used?
Yeah, so basically the majority of children with primary HLH, they do present at a much earlier age. So now the understanding is that there is some problem in their the apoptosis pathway itself, which predispose them to HLH-like state when there's an infectious trigger. So especially in young infants, like less than 1 year of age, a child presents with classical fever, cytopenia, organomegaly, it's upfront we tend to send the genetic workup for the HLH, and once common infections are ruled out, especially like EBV, CMV, these are some of the infections, parvo, these are some of the infections that can present as HLH-like picture, especially in young infants. So once these are clearly ruled out, especially in young infant, we tend to start them on chemotherapy with etoposide, cyclosporin, and dexamethasone, that the usual HLH 2004 protocol that is still followed. And as once mutation is proven, of course, hematopoietic stem cell transplant will be the answer in this setup.
Okay, so one last question, Dr. Suresh, before we move to the next case. There are different terminologies like MAS, macrophage activation syndrome, HLH, hyperferritinemic syndrome. So are they all the same, or there is any difference between these different terminologies?
Yeah, I think I mean, what I feel is different people label them differently. There may be some minor differences in pathogenesis or molecular pathways, but ultimately the manifestations and clinical features, biochemical manifestation, they are almost similar. So it's like macrophage activation syndrome for hematologist and HLH for hematologist, and hyperferritinemic states for intensivists. So I think these are different. I mean, what you want to label this condition as.
Okay, great. So I think we move to the next case. So this is
just one point, Dr. Arun.
Yes.
I think
Yes.
all this MISC is also some form of HLH. I think after some time, you will find they are almost common diseases and with varied manifestation with different type of cytokines release, and that's why different organs gets involved.
I totally agree, because HLH or this is basically hyperinflammation. So MISC is also hyperinflammation of the infection which the body is reacting to. So it is also maybe one of the variant of this. So moving forward, this is a 4.5-year-old child who presented with polyuria and polydipsia with vomiting, abdominal pain, and altered sensorium. I think very classical history for any child to present of diabetes and decay. So could be one of, means a very, maybe the clear cut. So we'll not spend much time on this. With no history of burning, micturition, cough, ear discharge, was taken to the local hospital, given IV fluids, medication, but the sensorium was worsening. So again, in this, we'll say that this child had efforts were increased with acidotic breathing. GCS was low, so that is an important finding. Pupils were not reacting to light. There was significant posturing. Blood sugar was very high. So this was again classified as primary brain dysfunction and resuscitation. There was no pallor, icterus, or clubbing. Anthropometry was preserved. There was not much in the respiratory or cardiac, but GCS has CNS has low GCS with not reacting pupils, increased tone, brisk reflexes, and extensor plantars. So this was probably a child with severe decay with symptomatic cerebral edema and raised ICP, probably herniated or not, we have to see. The blood sugar was high, ketones were high, and this was the blood gas we have. So Dr. Balaji, any comments on this? Though it looks simple, but just small comment.
Yeah, so this is a classical severe decay with cerebral edema. Now, what we need to know is why the kid has landed up in cerebral edema was
was there some concern with the fluid management or anything? Apart from that, there is severe hyponatremia as well, and we need to get a corrected sodium in these patients. So approximately it will come to 124 or 125, the corrected sodium as per the blood sugars of 300 if we say. So again, that is still very low, and severe acidemia, severe hyponatremia, all these predict the occurrence of cerebral edema, which is what has happened in this kid. So yeah.
Okay, so I think this blood gas looks simple. We can read out it's severe acidosis. There is significant metabolic acidosis, hyponatremia, and we have all the features pointing to decay on this. So it was managed on the line of decay with correction. IV insulin, raised ICP was managed. For suspected infection, ceftriaxone was given. The CRP was quite high. Procal was also very high. TLC was 18,000. Platelets were low. The blood and urine cultures were all sterile. So, and urea and creatinine were raised with the decreased urine output. So this was something which the other labs which we got. So what is the cause of persistent encephalopathy in this case, Dr. Suresh? And do we need to investigate that further?
Thank you, sir. So definitely this child had severe decay with cerebral edema. The risk factor for edema is longer duration of illness and severe acidosis, hyponatremia at presentation. The persistent encephalopathy after few days could be related to disease per se, or its treatment related complications like decay in this child, cerebral edema at presentation, and it could be due to complications of the treatment like which lead to osmolar shifts inside the brain. So one group of diseases like related to disease or its treatment. So cerebral edema and its sequelae, or it may be intracranial thrombosis like cerebral venous sinus thrombosis, or there may be intracranial bleeds. These could be one group of diseases due to the disease related and its treatment related complications. But if there are other features of infection like elevated TLC or thrombocytopenia, elevated CRP, and fever is persisting, then I would also like to keep infections as one of the possibility, because these children are predisposed to develop infections in form of either bacterial infections or fungal infections.
Okay, so Dr. Dhiren, do you agree with whatever Dr. Suresh said? And also, how can we explain this high TLC and high infective marker, platelets are low, urea creatinine is raised? Is it common in decays?
You know, diabetes means previous 20 years back, decay used to be having less complications. Now, over the time, I have found that these diabetic patients are more prone for complication, infectious complication, and while they recover, normal decay usually recover within 24-36 hours. That is the rule for most of the patients.
Yes.
In this patient, what I could see, this patient had catastrophic course at the onset, and almost probably might have coned a little bit, and brain coning might have happened. It looks like a patient developed some major catastrophe in the brain. Usually when we start treating them, and then they develop some brain edema if you give bicarb, or but in this patient, it looks like patient had major catastrophe during admission itself. Now, secondly, these patients are more prone for thrombosis. It's a hypercoagulable state. So I totally agree with Dr. Suresh that there is some major CNS problem is happening. Probably we should rule out some infectious complications because procalcitonin is high, patient platelet is persistently low, and you are given fungal. Now, what I have found that fungal infections are on rise in immunocompetent patients also. I could see the change in the pattern. Previously, most of the patients were getting higher antibiotics after say 7th-10th day of ICU admission. Now I have found that 40-30% of the patients are getting immunocompetent patients are getting antifungal. So past 6 months, past 1 year, there is a change in the trend, and especially these patients are very prone for fungal, these diabetic patients.
Very true. Agreed. So almost everybody agree here that this is a decay with complications, and it is probably an infection-related complication because of these high markers which we are having, and also affecting the kidneys and going into AKI. So, and neuroimaging is required because of encephalopathy. So what are the common infections, Balaji, in DK, which we see? One of these, Dr. Dhiren has already said, fungal infections. What are the others?
So yeah, coming to fungal infections, common things like oral thrush, genital thrush, oral candidiasis, these are quite common, as well as mucar is one infection that is very dreaded, and any child with altered sensorium, even a small blackish, it could be as simple as a blackish discoloration in the nose or blackish discharge. Then we always look out for invasive fungal infections, especially mucar in these patients. Apart from that, urinary tract infections are quite common, and soft tissue infections are quite common. So these are some of the common infections. And just a small comment on the labs in these patients. This kid obviously had elevated CRP, procalcitonin, thrombocytopenia, multiple things that pointed towards active infection going on. But elevated TLC as such is quite commonly observed in diabetic ketoacidosis, possibly dehydration and stress related. So if other pointers are not favoring an infection, and it's a straightforward child with just an elevated TLC, I would be really cautious in upfront initiating or suspecting active infection. Other markers don't correlate. But yes, in this kid, definitely not. This is a different story with other markers are as well correlating. That's just the point I wanted to make.
Thank you, Dr. Balaji. Dr. Suresh, CT head was done and the CT of the paranasal sinuses. So this is what we have. So can you comment on something on this? So this is the CT of the brain, and this is the paranasal nasal sinuses.
Sir, the CT, this is the non-contrast CT head, which showed that there is a hyperdense lesion in the left thalamic region with the significant edema around the lesion. And
this one, am I pointing it right?
Yes.
This is what you're talking
sir.
about?
Yeah,
Yes.
sir.
Okay. And this is the edema you are saying? Yes.
Yeah. Yes, sir.
Yeah,
and in addition, there is gray white matter differentiation is well preserved in other areas, but we can't see any sulci and gyri which are very not like they are not clearly visible. So there is definitely generalized cerebral edema plus hyperdense lesion in the thalamic area on the left side with edema. So it could be like it's possibly a bleed over there and surrounded by edema. The reason could be either it's a intracranial bleed in this location, or it could be secondary to venous sinus thrombosis leading to bleed. In sinuses, in the paranasal sinuses, CT, I'm not clear what is it, but maybe sphenoid sinuses are a little hazy, so there may be some soft tissue density in the sphenoid sinuses.
Yeah. So this is again the CT of that. So this is the other cut in that, in which you have seen the in the left thalamic region, these ones you have, and the midbrain, you have frontal lobe and medial temporal lobe. There is significant blooming lesions which are seen here in these areas. So these are probably suggestive of vasculitic infarct with hemorrhagic areas. And could be, it was reported as probably an invasive fungal etiology in this case, that this is what was causing the problem in this child. So further workup in this, the other labs which we got was, Dr. Dhiren, we have this blood and urine cultures were sterile. Nasal scrapings of fungal smears were negative. We have beta D glucone 109, galactomannan of 2.5, HbA1c A1C expectedly was very high. And you have of the ultrasound which was showing right pleural effusion, mild ascites, and there was some raised cortical echogenicity in the kidneys. So what do you how do you interpret this, basically this beta D glucone and galactomannan?
I don't have experience with the BD glucone, but a lot of patients for almost 10 years we get this galactomannan done. So first of all, I'll talk about what I'm experienced about. One is galactomannan. Yes. Second, it gives you some idea about invasive aspergillosis. but it's a very non-specific test, and we normally get it done in immunocompromised patients. And the problem is with this test is lot of cross reaction with the beta-lactam antibiotic.
Yes.
One second, regarding BT glucagon, D-glycon, that's a D-glucagon test, and this is usually a marker of pan-fungal. Means most of the fungal it covers except I think mucormycosis. Mucormycosis it doesn't cover. And these are the blood tests, and actually we don't know the sensitivity in pediatric age group. But as I told you, D-glycon, I don't have my personal experience as compared to galactomannan.
So Balaji, you want to comment? Yeah, please go
one
ahead.
thing or one point was, Dr. Arun, in these type of scenario with this type of imaging, even if you are not able to prove by getting, you cannot get a brain biopsy done in these patients. These are the indirect markers which definitely help us in this type of crux difficult situation. And this is a life-saving situation, and one should do everything. But these markers, especially galactomannan, I've seen that helps in, while treatment, the levels goes down. So that helps in chasing the patient and making the diagnosis. They are not very good tests.
Okay, so Balaji, you want to comment anything further on these two tests?
Yeah, so beta-1,3-D-glucan is actually a pan-fungal antigen. I think except for Cryptococcus or something, it is usually seen in all fungi, and galactomannan is more specific for Aspergillus. So whenever in this scenario, like the common fungal infections are, one is Candida when mucocutaneous infection suspected, or if it is invasive CNS, it's usually Mucor and Aspergillus. These are the two things, especially when angio invasion is also there. So these are the two dreaded fungal infections that will be thought about. And with DKA, Mucor takes an upper hand more than Aspergillus. So the problem with diagnosing in these things is obviously tissue diagnosis is what is needed. And many times when there is a brain involvement, we cannot get the proper tissue. If it's paranasal sinuses, then FES or something can be used. So these markers otherwise give a rough idea that there is a fungal infection going on.
So this child was started on liposomal amphotericin, thinking that mucormycosis is common in children with DKA and with the setting of acidosis and all these things, and the picture on CT scan which we had. And for AKI, peritoneal dialysis was given, and this child gradually improved. So, Dr. Suresh, what are the common fungal infections in DKA?
Sir, common fungal infection, as Dr. Bala already told, that it could be mucormycosis or Aspergillus infections are common, or it could be Candida infection. The common locations are urinary tract, CNS, and lungs. So these are common locations to have fungal infections.
And why do fungal infections occur commonly in DK? We don't see in immunocompetent people usually fungal infections. Why only in these children?
So one more site is paranasal sinuses. The location may be just to start. I mean, infection may start from there, and then that infection can travel to CNS. So paranasal sinuses could be a starting point for fungal infection, especially mucormycosis. In DK, because of prolonged acidosis, these children are predisposed to develop fungal infection. Plus, they are more prone to have various invasive procedures. And particularly with mucormycosis, what happens in DK is there is acidosis, and due to decreased pH, free iron is more inside the plasma, and there is decreased binding of iron to transferrin. So there is a lot of free iron inside the blood, and if there is any focus of this mucor inside the body, or due to invasive procedure, if child had acquired mucor inside the body, then the proliferation of mucor is more in presence of free iron, because it utilizes iron for its growth. So that's why these children are predisposed to develop mucormycosis.
Mucormycosis in them. So there has been one study from our unit in which we have seen that mucor is very common in children with type 1 diabetes. So majority of the time we have seen it's mucor, or very occasionally we have seen some other organism. So, and they have all been treated with amphotericin, and especially debridement of these lesion is very important. Otherwise, if you don't do the source control, they don't improve. And if done aggressively, you can have some reasonably good outcome in this cases. But mucus are known to spread very fast, so you have to be quite aggressive in these children. So, like everybody has said, any role of in CNS fungal infections, we may not get the tissue to diagnose. So the other labs can play a role in that, like these biomarkers which you have discussed, or any radiology or clinical features. So like clinical and radiologies are usually non-specific. So culture based, we can't usually culture these funguses in the blood or from other body fluids. We can't get the biopsy. So galactomannan and 1,3-beta-D-glucan are the two tests which are available with us at present. So beta-D-glucan, as everybody has said, is a pan-fungal marker, and except mucormycetes and cryptococcus, it is tell you it is raised. Anything above 80 is considered as positive. But its utility, like Dr. Dhiren said, in children is limited with poorly established cutoffs. So we don't have much of the cutoff. So we use the adult reference values only. And there can be false positives results in this, in bacteremia and like Dr. Dhiren said, meropenem, few other drugs, amoxiclav, and even albumin and immunoglobulin can give you a false positive result in these cases. Similarly, galactomannan is basically for aspergillus, but like in this case, it was raised. Even in mucor also. So in this child, we have 1.27. So the sensitivity is different, and false positive results again can be seen with beta-lactams and beta-lactamase inhibitors. And false negative results can be even in aspergillus if it is non-angio-invasive aspergillosis is there. So this child was given antifungal therapy, came out from ventilator, but required tracheostomy, but developed right hemiparesis, had on follow-up left chorioathetoid movements and some improvement in cognitive function. So had left significant sequelae in this child. So coming forward, any comments, Suresh, Dr. Dhiren or Balaji on this? You want to share anything?
No, mucor is bad. Mucor is bad.
It is, yeah.
Mucor, the cruxes, as you Bansi sir already suggested. First thing is early diagnosis. So when to suspect and how to diagnose it as early as possible. Second thing is once diagnosed, extensive debridement and apart from antifungal therapy, here liposomal amphotericin B will be the option. And apart from antifungal, it is like extensive tissue debridement that is going to save the child. So early diagnosis, suspicion, early diagnosis, and then extensive debridement along with antifungal. This is the only thing that is going to help in this child. And of course, treating the predisposition, like resolution of decay or any acidemic state. These are the possible 3-4 game changers whenever we have invasive mucor.
Thank you.
Just
So
one point,
yes.
Dr. Arun, I've seen my personal experience I would like to share. Always look for the discoloration of the eyelids and the medial part, medial epicanthus.
Yes.
Means I've seen around 5 patients where invasive fungal infection started with sinus and affected the retroorbital area, and we could diagnose on ultrasound eye, and but the starting point that the clinical clue was the discoloration of the eyelid, means there was swelling and proptosis of the eye and the discoloration of the medial palpebral part.
Yeah, that's a valid point. Practical tip, I think that's very important. So moving forward, so we have a 8-month-old child who had a chronic problem. So had a left leg swelling since 1 month, fever, and now developed fast breathing and irritability. So had a weight of 5.4 kg. So a 8-month-old child with 5.4 kg weight. Length 60, head circumference 41. There was pallor, you had tachypnea, respiratory distress, bilateral craps. You had a liver and spleen, and left thigh was swollen and tender. So what are the possibilities, Balaji? Could be in this case a long history, 8-month-old.
Yeah, so here the prominent pointers in the history and examinations, one is a young, infant, and the child has some poor weight gain, like 5.4 for an 8 kg. Now presenting with again a multi-system involvement with respiratory involvement, also having organomegaly, and having a musculoskeletal involvement as well. One of the histories was like there was some family history of some malignancy. So upfront, one of the differentials that were considered is either a chronic infection or something like a malignancy that we are dealing with at this point of time.
Okay. So that was discussed. Can you comment anything on this X-ray, Balaji?
Yeah, so this child has already been intubated. Endotracheal tube is slightly deeper, close to carina. There is a bilateral lung infiltrates, right lower zone involvement, as well as left the entire upper zone, mid zone, retrocardiac. There are infiltrates and with few air bronchograms as well as. So there is definitively bronchopneumonia with stomach distension and dilatation that is present. I'd also like the audience to have a look at this. The child had a left thigh swelling. So what we are seeing here is there is some involvement of the femur with there is a periosteal.
You are talking about this thing?
Yeah. So there's a periosteal reaction and a periosteal elevation. So that could again point towards some chronic infection which is causing multi-system involvement. So there is evidence of pneumonia. There is also evidence of osteomyelitis at this point of time.
Dr. Dhiren, anything to add?
Yeah, it looks like some chronic infection that has spread suddenly. Means something was going on slowly. Like staph is normally acute. I mean, this is some chronic infection that has spread. So my first thought process was looking at the case is a staph, and some acute on chronic event has happened.
Okay. So very rightly said that staph is very usually acute. This is 1 month history, so something more chronic is going on. So Dr. Suresh, the CT of the thigh was done. So can you comment anything on this?
Yeah, yes, sir. So CT is showing that there is definitely thickening of the soft tissue or like muscles and subcutaneous tissues thickened. And there is the cortex of the femur is very irregular. And there is also periosteal reaction is there.
This is the one we are talking about. Yes.
Yeah, and there is some periosteal elevation, periosteal reaction, and yeah, these are the findings on the CT.
Okay. So Dr. Balaji, we have this in
Dr. Arun,
yes.
Just one point. Did somebody give intramuscular injection for vaccination at the thigh? Did we get
no
that
history was there? No history was there about that.
Because I seen one patient of non-mycobacterium tuberculosis, like chronic infection, swelling, and then those things limited to the thigh only, didn't spread to the lung. So 1 or 2 patients I could get that.
So we have now the labs, blood labs came as HB of 11, TLC was slightly raised, platelets were normal, and you have a hypochromic microcytic picture. CRP was okay, ESR was 3 millimeters. So did further investigation, sodium was slightly low, urea creatinine were normal, albumin was 3.1, HIV was negative, ultrasound abdomen showed hepatosplenomegaly, and there was a very interesting finding in the liver of heteroechoic lesion in the segment 4, which is quite big, 2 into 1.5 query abscess. So Dr. Balaji, anything, can you tell us about these few reports?
So,
are we getting near the diagnosis with these bloods?
Yeah, so these, the hematological parameters were totally bland with mild leukocytosis, even the lymphocyte count, everything was normal. ESR and CRP, surprisingly, for the amount of the multi-organ involvement, did not show any elevation. Again, malnutrition is one thing. So in the background of malnutrition and failure to thrive, we need to take these inflammatory markers with a pinch of salt. Definitely, we are getting more involvement of even the visceral organs now. So initially we had lung involvement, then we have skeletal femur involvement. Now we have the involvement of liver as well. So in an acute setting, definitely staphylococcal infection is one thing which can present with this sort of setup. In a chronic history, definitely chronic infections, chronic either fungal or tuberculous etiology becomes more likely when we have this multisystem.
So moving forward, like you said, this child had gone into respiratory failure, needed ventilation, was started on broad spectrum antibiotics, few investigations were pending. So what can be done to have a definitive diagnosis, Balaji?
Yeah, definitely this will need some tissue diagnosis because something chronic is going on. So
which tissue? Do we need to poke the liver, or we can get from the bone?
No.
Or
yeah, I think the soft tissue infection in the femur can be more accessible in a sick child, whereas a liver biopsy will obviously entail more invasive and chance of bleeding risk. Everything is there. So
so
femur,
yeah, very rightly said. So biopsy from the femur was consistent with tuberculosis or osteomyelitis. So it showed fibrosis, histiocytes, necrosis, and few AFBs were seen. And the gastric aspirate also showed Mycobacterium tuberculosis were detected. And even though the FNAC was negative in this case. So that's an interesting point, that FNA may not yield in a very paucibacillary tuberculosis. So you might need biopsy in this case. Dr. Dhiren, you want to comment anything on this?
Yeah, I think one is the endotracheal aspirate, if possible. Secondly, liver aspiration bedside in a very sick patient is more feasible than biopsy from the femur.
Yes.
And gastric aspirate, you rightly said that we tend to, undermine these non-invasive tests and go for the fancy stuff first. So I think just one point I want to make, that liver test, liver biopsy, liver aspiration, bedside ultrasound guided are very safe, very simple to perform than very invasive tests.
Okay, so in segment 4, can we get it done? Is it easy to reach there?
Yeah, it's no problem. It's
no
possible.
Problem.
Yes.
So
yes.
that's rightly said. So it's not a deep-seated. With segment 4, we can get it done.
Yeah.
So we are short of time. So we have a couple of more cases to discuss. They are also very interesting ones. So we'll move forward. So this is a 17-month-old child who had presented again with fever, rash, loose motion, difficulty in breathing, presented with gasping respiration. TLC was high, platelets were low, started on ceftriaxone and clindamycin, also had AKI with high creatinine, CRP was very raised, and X-ray is showing a mild right-sided pleural effusion here. And ET aspirate had grown staph areas, which was sensitive to Venco, Tico, Ceftran, which was resistant to Clinda. It's basically resistant to that. So what do you make out of it, Dr. Dhiren? And this was the maldita of ET secretion, ET aspirate, which showed staph aureus, which was resistant to all these organisms, but sensitive to Venco, Tico, but resistant to penicillin.
Very surprisingly, that it is resistant to clindamycin. It looks like a community-acquired infection one. History matches, there's a rapid onset. So staph aureus can be an organism which can lead to all these clinical signs and symptoms. Thirdly, staph aureus, which is resistant to Clinda, normally it is sensitive to clindamycin because it is a community acquired, but nowadays doesn't follow the rule every time. But in any case, we need a bactericidal drug. So teicoplanin, I would like to choose. One is, if you ask me, antibiotic. Secondly, regarding labs, other labs, creatinine is high, CRP is pretty high. So this patient is going to land up in, this will take time to recover, and it's a life-threatening situation.
Yes, true. So Dr. Suresh, how common is community-acquired MRSAs?
Yes, sir. Yeah, community-acquired MRSA is very, it's increasing these days, and past few years we are seeing more and more number of children with community-acquired MRSA, and these commonly present with skin soft tissue infections and pleuropulmonary infections. So various studies have documented that community-acquired MRSA accounted for around 15 to as high as 30% of community-acquired staph aureus. So in recent years, the incidence is increasing.
Very true.
Now,
So
nowadays it's around 40%.
40 to 50%. Yes.
Yes, yes, yes.
Okay, so teicoplanin was added. After 6 days, he improved, was extubated, but inspiratory stridor was persisting, which required BiPAP. But before extubation, endotracheal aspirate had was taken because there were purulent secretion and fever was present. So we had grown Acinetobacter, and the gram stain showed many polymorphonucleosides. So Acinetobacter was there, which was resistant to many of the organisms. Many of the drugs. So, Dr. Dhiren, what should be the next course as stridor is persisting, but chest X-ray is normal and TLC is slightly raised?
This is a situation where we need to decide, should I give antibiotic considering as a vector VAP, or should I just ignore this because the patient has been successfully extubated? Other than stridor, there must not be very high oxygen requirement as patient is on BiPAP. TLC is 18,000. That can be well explained by your staff, because in staff it takes time. So at this situation, I want more information about the chest X-ray. How is the chest X-ray? Secondly, whether
it's normal.
the things
Chest
are,
X-ray, we didn't find any abnormality.
how the child is doing over next 24 hours. That is very important.
Very
because
important.
any worsening, I would give the benefit of doubt to the patient. But if child is improving, I may consider to be as a ventilatory associated tracheitis, because not a pneumonia, because chest X-ray, if it is normal, oxygen requirement is not there. So I would like to treat it as a case of ventilatory associated tracheitis. Patient also had stridor. Looking at the scenario over next 36 hours, I would like to give antibiotic if patient is deteriorating, but if patient is improving, I would like to wait in this patient.
Okay, great. So Dr. Suresh, what do you want to comment on this colony count, role of colony count in ET aspirates for labeling it as VAP or ventilator associated or endotracheal tube associated pneumonia? So this 40,000 of Acinetobacter, is it significant?
Hello?
Yes, please.
Sir, this the colony count is like 4 into 10 raised to power 4, which is not significant count for samples from ET aspirate. So if the clinical picture is not fitting into VAP, as Dr. Dhiren mentioned, so I won't consider this as a cause of VAP in this child.
Yeah, so the important message
Dr.
is
Arun,
that...
Dr. Arun,
yes,
just one thing.
Yeah.
When patients are receiving lot of antibiotics, fine,
yes,
and at times we may not get that magical figure of 10 is to power of 5 in ET aspirate or in the BAL. So what Suresh said is perfect, that one should look for the clinical criteria other than just 40. So 40,000, nor you can ignore if patient starts deteriorating.
Yes.
Nor you should take it as a just a a clear-cut case of ventilatory associated tracheitis or pneumonia. So I mean to say 40,000 figure, we cannot ignore if patient has received antibiotics.
Exactly. So if the child is running high-grade fever, worsening of respiratory distress, X-ray is bad, then this 40,000 also is very significant. But if he's did not show any further deterioration, like Dr. Dhiren said, I'll observe for 24 hours. And if he's stable, so we can hold on the antibiotics, and it may just be a colonizer rather than a true infection. So that is an important message for which we have taken up this case. So coming to the last case, a child 4-month-old had received a vaccine and developed shock and fever, was intubated, also had a cardiac arrest for which given CPR in an outside hospital, then was transferred after he had received meropenem, was in cardiac failure, required high frequency oscillator, inotropes, developed renal failure for which peritoneal dialysis was given, and was continued on meropenem. So this was the story we had. The endotracheal aspirate, again, the biofire had grown multiple organisms, Dr. Dhiren, in this. We had Acinetobacter, we had Enterobacter, we had Klebsiella, we had Staph aureus, we had Strep pneumoniae, and what all in this. So how do we make out of this in the BioFire? We have a full vegetable garden in this.
You know, this similar looking case we also had, and at that time I was little bit confused looking at the similar looking report. So what I thought that let me go clinically, and the type of antibiogram we had in our ICU. So looking at the colony count, the colony count which are very high, say 10 raised to power 4 plus, means 10 raised to power 5, maybe in pathogenic organisms. Again, too much reading this report, this patient may end up in over treatment. So what I would like to do, I would like to see my own antibiogram, type of bacteria, type of viruses we have in past, prevalent in our past 6 months, past 1 year. Based on that, I would like to target Acinetobacter. Second, because patient had difficult intubation and CPR, and also, so I would like to cover MRSA. So these two bugs I would like to cover out of these based on the clinical scenario, not going by the report, because this is an PCR. PCR will detect very minuscule amount of dead virus or bacteria that can be represented as an infection in these given reports.
Perfect. So that is very important. So we should not be chasing the labs. We have to correlate it with clinically and your past antibiogram growing in these cases. So what will you do, Dr. Dhiren, in this? Like what you said?
As I told you that I would like to give colistin and teicoplanin. With colistin, I would like to give one more, because I feel that alone colistin covering Acinetobacter is not a good, you can say, a good thing.
Okay. So we again then did an ET aspirate which grew Acinetobacter, which was sensitive to colistin, and so colistin was also added to this. And how much reliable these PCR reports are, and what should be our next step in this case?
As I told you, PCR reports gives you almost all sort of DNA and RNA which are present in the endotracheal tube, whether they are colonizer, whether they are commensals. So that is the problem with the PCR. So we need to correlate with the clinical presentation, your scenario, where the patient is, and the blood reports and other labs has to be played with the PCR. One should be very cautious in starting treatment based on just on PCR.
Yeah. So these could be, means we have to be very careful to see whether they are colonizers or not. With the low colony count, and we don't grow anything on culture, probably it's a colonizer. And if you have multiple nucleic acid targets in low counts, may also be indicative of colonizers, or normal respiratory flora may also be picked up on these PCRs, because they are very sensitive tests, these BioFires and all. So they do not correlate with bacterial culture in colony counts only. So colistin was added, like you said, it is important based on this progress. So the child had, based on his clinical course. So was it a right step, Dr. Suresh or Balaji, you want to comment on this, or we could have added any other drug?
Sir, if we suspected VAP in this child based on clinical feature, deterioration in oxygenation and radiological evidence plus other lab investigations, and even at that point of time, we could have treated for ventilator associated pneumonia based on what organism we see in our unit which causes VAP. So like in our unit, we cover for Acinetobacter. If we suspect that VAP is definitely there based on clinical and radiological investigation, then we add colistin. But we don't see.
Organism was sensitive to both colistin and TG cycline.
Yeah, I think colistin is okay. I mean,
okay, okay. So how can we give any Dr. Dhiren or Dr. Balaji colistin? Then any some tips to this so that this can be more efficacious?
Yeah, Dr. Balaji. Yeah.
Colistin, especially when we are dealing with VAP, there is also a role of adding a nebulized
Dr. Balaji, your sound has become again childish.
Is it better now or?
Yeah, now it's a adolescent sound. You go ahead.
Yeah. So with especially ventilator-associated pneumonia, along with intravenous colistin, there is also an option of adding an add-on therapy of nebulized colistin along with the IV colistin when we deal with VAP. So that is one strategy that can be followed. And another thing is like prolonged infusion of colistin is one more thing that has been advocated. So these are some things that can be tried.
So I think we have had some good cases and good discussion.
One comment, Dr. Arun.
Yeah.
You know, I was a few days back, I was reading about the colistin synergism.
Yes.
In past 2 decades, we are left with just one effective antibiotic, that is colistin. Fine. Especially for Acinetobacter with the advent of NDM. Okay, now this NDM is not a problem of West. So they have avibactam combination with the ceftazidime that doesn't work with our Acinetobacter. Now, how to deal with? So to increase the synergism of colistin, they say that you can add another antibiotic which has got anti-synthetic effect, means something like that suppresses protein synthesis. Okay, so what they do, they have tried to use combination like some antibiotic like minocycline, some antibiotic like tigecycline. Tigecycline they didn't mention, but they have used antibiotic like vancomycin. What these antibiotic does, that the colistin increases the permeability of outer cell, the cell membrane, that lipid A moiety, it leads to saponification. Now antibiotic like this one, not meropenem, we know that there is a sensitivity, there is a synergism with the meropenem and other antibiotic, but I am talking about something very different. So the vancomycin can enter the cell and can act against gram-negative bacteria.
Yes.
Why in previous few years these antibiotics couldn't act against gram-negative? Because they couldn't enter the gram-negative bugs.
Yes.
So if they are trying that if we combine colistin with these antibiotics, probably because now they can enter the cell, so they may work. Also in some form of colistin, they say that even if it's a colistin resistant, I mean, now they're talking about colistin resistance, at subclinical level, it leads to saponification to that extent that antibiotic can penetrate inside the cell. May not colistin work, but other antibiotic will start working. So this is a newer concept.
The
scientists, the microbiologists are working on it. I think over the time we'll come to know.
Great. Any other comments, Balaji or Suresh, before we hand it over to the host?
Yeah, sir, regarding the case 3, other possibility could be the fungal infection, the child with thigh swelling and lung involvement. So previously, Dr. Rose discussed about various fungal infection which could present like similar presentation. So that could be one possibility.
I agree. And especially once it was worked up, like Dr. Balaji has put up in the chat box, this case was given by Dr. Balaji. It was a case of immunodeficiency only. So tuberculosis and fungal infections are common in them.
Yeah, okay. It was turned out to as severe combined immunodeficiency.
Yeah, Dr. Balaji, I was listening to the previous presentation where the myelidosis was one of the case in the pot spine. Fine. Recently, we had a case of myelidosis presenting as an ARDS and it affected the brain. Culture grew, not only blood culture, urine culture as well as CSF culture. All culture grew myelidosis. And means everything patient survived, but the brain got the major brunt and it became brain dead.
Yeah. Okay, so I think we are now taken almost 1 hour for this panel discussion, and I think Dr. Narmada, hope we were able to do justice to the topic of playing with the lab. So we tried to use some of the lab parameters and correlate it with the clinical course. I hope you all liked it. Thank you, Dr. Rajendran and Dr. Narmada, for giving us the opportunity. And thank you. I thank all the panelists for amazing, engaging discussion.
Thank you, sir.
Thank you, Dr. Arun. Thank you.
Thank you, sir.
Now I request our secretary, Dr. Rajendran sir, to give a vote of thanks. Before that, Rajendran sir, before that, I would like to take this opportunity to thank you first for giving us such a freedom for us as a coordinator for myself and Dr. Narmada. Really, no one will do these things. We are zero interference from the TNSE, and we are so supportive. In spite of making us to get in touch with the speakers, you do all the work behind the screen, actually. Thank you. Salute to you, sir.
Yeah, Dr. Sudhakar, one point I always make with Dr. Rajendran, he is one person who has, because of him, I am surviving.
Oh,
he has saved my life. And if Dr. Arun remembered when we came to,
I was there at your bedside.
yeah, Dr. Arun was at, I had a severe hypotension, and he stood at my bedside for almost 4 hours to see to it that I get out of the problem. So he's
great,
a real gem. He's a very decent person. He's a silent worker, non-interfering, very respectable person.
Yeah, that's why I want to record it in the auditing, sir.
I totally agree with that, Dr. Sudhakar, and that experience was during the NAPAM, which happened at Kuwait. So we were there at that time. So
yeah, we are privileged him as our secretary, sir. Thank you, sir.
And we thank the Tamil Nadu chapter also, Dr. Sudhakar, and everybody, and Dr. Rajendran for this. Thank you so much.
Thank you, sir.
And also special thanks to Dr. Thangavelu, sir. He's always very supportive and engaging.
Yes.
Thank you so much, sir.
Thank you, sir. Thank you very much, sir. Very nice.
He's an amazing person.
Thanks for the opportunity to learn from all of you. Thank you.
Thank you, Dr. Dhiran, for your kind words, and Dr. Arun for your kind words. It is my duty to do all the best and maximum from our side to all the guests or wherever we are listening. That's why we did it. Thank you for kind words. So on behalf of IAP TNSE, I am really happy to have one of the excellent CME meeting, and it's one of the best I have seen the past 2 months. Every month we are 4th Sunday we are connecting. I think we are attended more than 400, 450, 500 members we attended. So really happy that we are having excellent that's infectious disease CME. And I thank all the panelists starting from Dr. Thangavelu sir. I think as usual, Thangavelu sir has done very well, and he has presented thrombocytopenia with the fever. I thank Dr. Thangavelu sir. And I thank lead panelist Dr. Ekumar from Kochi, and the panelists from Sija and Balachandar and Reminathan. And I thank Dr. Sudhakar, and he is one of the wonderful person who has presented this febrile infant on an outpatient approach. I thank Dr. Sudhakar. And next the panel discussion, the moderator is Winsley Rossi. I thank Dr. Winsley. And the panelist Wilson Verkis Philip from the Vellore, and Anila Chako from Vellore, and Dr. R. Palaniraman from Tindivanam. I thank Dr. Narmada from Vellore, who presented on infection control measures. And I finally thank our friends Dr. Arun Bansal from Chandigarh, and my friend Dr. Dhiran Gupta and Mullai Balaji and Suresh Kumar. So they interacted very well, and we are having pan-India meeting almost. We are having all part of high institutions, and as well as almost 40% from Tamil Nadu. We have presented a nice CME. I thank one and all for this wonderful opportunity. First of all, I want to really appreciate our young, energetic persons, Dr. Sudhakar, and yes, he's playing multiple role. I think he's the CCP secretary and ID secretary. A lot of things. I think he's working almost 20 hours per day. I think really I'm happy that that kind of person we are having. I think future is with the right Dr. Sudhakar. I think really appreciate Sudhakar effort, and I thank Dr. Narmada. I think this has arranged all the things from coordinate. Yeah. It's excellent coordination from Narmada. I think we are having a great person. That's why I never want to interfere that function of that organizers and conveners. That's my policy. That's why I want to make them to grow. That's my wishes also. Finally, I thank one and all for this wonderful effort. I thank Dr. Thirumurugan who has coordinated for the digital aspect. And I thank one and all for this wonderful opportunity. I thank and second time. Sudhakar, yeah.